ரன் ஆகுது. அப்படின்னு சொல்லி start. இதுல play ஆகும் சார் நம்ம இதுல.
அது தெரியும். நம்ம இது நேற்று நம்ம நினைச்சோம்.
Hi, Lakshmi. All the best.
Hi, Didi. How are you?
Fine, fine. How are you?
Fine.
Seeing you after a long time. At home or college?
No, I'm in office.
Okay. So,
Because anemia.
some other session, no?
Pardon, Didi?
First session is?
I think
There's
some
a second
first session somebody else is doing.
Okay. Yours is second. Okay.
Second.
Happy to introduce.
Thank you. How is everyone at home?
Yeah, all fine. What about you?
Fine. It's fine. I just recently had COVID 2 days back.
Okay.
Just joined.
Now you okay. Just 2 days back, you joined back.
Yesterday only joined.
What about kids?
So I think I have not tested, but all had
Symptoms.
Okay. What about you, Ananya? They all okay?
We all are fine by God's grace till now.
Okay.
Okay, dear.
Okay.
All the best.
మ్యూట్ నొక్కితే మ్యూట్ అవుతుందా?
Good morning, ma'am.
Good morning. Good morning.
How are you, ma'am?
Fine, ma'am. Fine, pa. Fine, fine.
Thank you.
for your involvement
Thank you, ma'am. Thank you, ma'am.
in the conference. Thank you for your support.
Thank you, ma'am.
Dr.
Ma'am?
Manju. Dr. Manju.
She's there, ma'am. Manju ma'am is there.
Yeah. Welcome, Dr. Manju. Thank you so much.
Yes, ma'am. Good morning.
Good morning. Good morning. How are you, dear?
Yeah, you are fine. All the best and congratulations, ma'am.
Thank you. Thank you. Thank you for all your support.
Yeah.
Just we are waiting for some more participant has to join.
I know.
Yeah. Dr. Muttama Chelvi, are you on the line? Dr. Muttama Chelvi, are you on the line, ma'am?
Shall we start? Good morning to one and all. Let's start with the second day of our webinar. So like every day is a new start, something beautiful. Each moment has its own value and a chance to change our life. Hope this day will be a fruitful day and you will have a good change in like updating your knowledge on various aspects in management of cancer. Now to start with our first session, I would like to inform call upon like the chairpersons now as Dr. Muthamil Selvi has not joined. She's one of the chairperson now. And our next chairperson is Dr. Manju Dandavani, Associate Professor, College of Nursing, PJIPMER, Chandigarh. We are happy to have you here, ma'am. Welcome to our webinar. Now one second, ma'am. Ma'am is an associate professor. She's working in PGIMR, and ma'am has been selected globally as globally among the 100 nurses by Women in Global Health in collaboration with WHO, ICN, ICM. And ma'am has received the Best Publication Awards and a Neuro Nurse Award in 2012. And ma'am has more than 95 publications in indexed and 4 SR and MA and international journals. And she's an editor and reviewer in various journals. And she's been a speaker in national, international conferences, including like in Florida, Doha, Boston, and Sri Lanka. And ma'am is an executive member and TNI Chandigarh UT and board of study member at Himalayan University, Jolly Grant, Dehradun. Ma'am, we are happy to have you here. And the session is yours. I would like you to invite the first resource person, Mrs. Gomati Munasamy. Share screen.
Can you just share her CV?
Yeah.
So a very good morning to one and all. First of all, I would like to congratulate Dr. Kumari and her team for organizing this international webinar on oncological nursing. So it's one of the very important area. And yesterday we have seen some of the sessions, mini sessions, and which were all very fruitful and very, this talk was from expert speakers. So today we have the first talk on family-centered approach to the patient with cancer. So you know that the patients of cancer really require, home care once they get discharged from hospital. So the nurses needs to be skilled enough to guide the caregivers, whether it is family caregivers or other formal caregivers. We need to have adequate skills. And in India, that area is really emerging. But we can listen now from an expert speaker. This is Mrs. Gomati Munasamy. She's a PhD scholar. And she has more than 17 years of experience in the field of nursing in various capacities, as staff nurse, lecturer, professor in different institutions. She has publications of 72, which includes books, monographs, national and publications in national and international journals, proceeding and felicitations, volume, magazines, textbooks, etc. And she is also a member of various nursing society. She is now working in Malaysia, so we can also listen the perspectives of family-centered approach to the patient with cancer, what is happening in Malaysia. Over to Ms. Gomati.
Okay, thank you, ma'am. So I will share my screen.
Yeah.
Is it visualized by all, ma'am?
Yes.
Is it visible?
It's visible. You make it full screen. Gomati, make it full screen, ma.
Yeah, 1 second. Ma'am, for me, it is showing in full screen actually, after I am sharing my screen.
can once you can close and try again. Yesterday also it was happening with someone. You can
Okay.
close and try once again.
Now is it, ma'am? Is it visible?
No, let's say like a slideshow only. You make it slideshow.
But for me, it is.
You
Once
share
again.
once again. Share once
Yeah.
again.
Now, ma'am,
Same way.
same.
The same like previous.
But for me, it is showing a full screen, ma'am. Actually, in my laptop, it is showing a full screen.
Ma'am, shall we share the screen from here?
Yeah, no problem.
Try doing it, ma'am.
Yeah, no problem. You can. Shall I stop my sharing
Yes,
my
ma'am.
screen
Yes,
share?
ma'am.
Yeah,
Yes,
one second. Okay. So very happy morning to one and all who have been gathered here in this session. And I welcome to the second day of this session on the theme, current updates on oncology nursing for effective patient care. And before going to my session, it's my great privilege to thank organizing team, JIPMER, Chief Patron, Dr. Rakesh Agarwal, Director, JIPMER, and Patron, Dr. Pankaj Kundra, Dean, JIPMER, Organizing Chairperson, Dr. M.J. Kumari, Ma'am, Professor cum Principal, College of Nursing, JIPMER, and Organizing Secretary, Dr. Padmavati Nagarajan, Associate Professor, College of Nursing, JIPMER, and now for this session, Chairperson, Dr. Manju Dandabani, Ma'am, Associate Professor, College of Nursing, PGIMER, Chandigarh. So now let me move on to our today's session is family-centered approach to the client with cancer. So as we all know that who is family, how we are going to recognize them. So as well as cancer. So as we all know that cancer is a chronic disease and it will be entirely affecting the family as well as the context of the family transition also. So, and if you are going to the just universal fundamental rights of Universal Declaration of Human Rights, Article 16.3, which has already stated that our fundamental family is our natural and fundamental unit of our society, as well as it is entitled to protect as a family, as a protected by our society as well as by our state. At the same time, World Cancer Day theme also, which is close to near to that, close the care gap. So two together, if we are taking a family to understanding them and raising their cancer awareness towards the better outcomes and patient satisfaction and family satisfaction towards the quality of life and supportive care is very much needed here. Can you move on to the next slide? So the main central objective is at the end of this session, as learners, they can able to gain knowledge about various aspects of family-centered approach and develop positive attitude and application of knowledge and attitude towards various healthcare settings towards family-centered care approach. So learning objectives, these are all the learning objectives. Let me move on to the how do we define patient and family experience. So from the figure itself, we can able to see. So various issues will be there, various challenges will be there while we are giving and while we are dealing with the client with cancer. So it's a challenging issues not only for nursing, healthcare professionals and families also. The problems which may be faced by the family as well as the patient, personal issues will be there, familial issues will be there, social issues will be there, apart from the stage of cancer. So it will lead to decrease the quality of life of the client as well as the family. Stress level will be increased. Next slide, please. So here, in this situation, as a family members as well as healthcare providers, they have to manage the client carefully and compassionately until to the continuum of end. It maybe takes weeks, months, or even a years. So many ups and downs will be there in the stages of cancer as well as family transition. So as an evidence shows that whether it is curative or palliative approach, as a healthcare providers, we have to take highest possible quality of life and longest possible time, whoever the patient or the client living with cancer, with the supportive of family members. Next slide, please. Now we are moving on to the term family. Everyone we knows who is family. So just in one word, for whom it matters. So it is the family who is going to give a faith, hope, and loving care in that particular client with cancer. Then they can able to get a better outcome towards the quality of life or towards the curative treatment and supportive care. And we are moving on to the family-centered approach definition. So actually, it is deriving the approach which is derived from the family-centered care actually. So family-centered care is one approach. So this approach, which is planning, delivering, evaluation of healthcare between the consumers and the healthcare providers. It's a relationship between two consumers. Consumers is a patient and families, and between them, healthcare providers. So here, what as a healthcare providers we have to achieve? Patient and family satisfaction, and patient and family quality of outcome at last cost-effective care. So this is the family-centered approach, and as well as the family-centered care approach with the next slide, strength-based care and supportive care, coordination and shared decision making, family support, cultural competence, and communication. So other than that, resources. Next resources. Here there are three things are there. Resources are needed. So here resources, especially there are 8 M's we as a healthcare providers we have to remember. So man, money, material, methods, mission, minutes, and management and ministry. So we need these resources, especially cost. If you're seeing the cost of care, it's very much high. So the payment scheme, what it is needed, and the social and cultural beliefs about the particular family-centered care. So through this approach only, we are going to lead a client with cancer. Goal of family-centered care is nothing but to create a partnership, a collaboration between healthcare practitioners, patient, and families. It will lead to the best outcome and enhance the quality and safety of healthcare throughout the life, until the end of life. Next, core values of patient and family-centered care approach. There are, as we all nursing profession and healthcare professionals, we know that ethical principles same as it is core principles are there, respect and dignity. So we have to honor the patient or patient as well as listening the patient and family perspectives, family history and family developmental stage, participation. So each and patient as well as family member, they have to take the decision in their care of the client. Information sharing, whatever the communication, what we are doing, it should be clear and timely. Information should be communicated, because cancer, if we are day to day, it will be raising and it will move on to the chronic stage. So timely sharing of information to move on to the curative or survivorship, and unbiased information and collaboration between the patient, family, and consumers. So this has been proceeded with the next slide. Let me move on to the next slide, please. Kinds of hope and how hope changes related to cancer. So here there are several hopes are there. So just I have given some examples. So even we are the healthcare providers, when the client are coming coming for the medical checkup, if they have been diagnosed with cancer, we will have an hope. They have to get cured. They have to go back to the better quality of life, like that. As like patient hopes to go to heaven, caregivers hope passing to be peaceful, providers hope patient wishes to be respected, as like some of the examples I have given. So next slide, please. Family system perspectives. So family system perspective, there are three premises are there. So number one, if the client has been diagnosed with a cancer, it will affect both patient as well as family. That as a healthcare professionals, we have to have a knowledge. And second, as in family members as a client with cancer, the family members goes into the transition. Why means they will be having a challenges to try to maintain their stability in the family role. So this particular level of functioning from practical to existential, which makes the transition to as a family members, they have to face different direction and they have to master the crisis. And the third one is healthy functioning. So whether the particular stages of cancer, according to that, whether they can able to maintain their essential family functions, all the needs has been met, and whether goodness of fit is there between the patient, family, and the medical care setting. And next, we will move on to the family system perspectives. While we are dealing with the family system perspective, assessment of an individual client is important. Not only individual client, as an individual client, families, friends, and the medical staff. So what are the aspects? Emotional resources, cognitive, that is knowledge, coping behavior, developmental stage, illness and course, and treatment. So for example, developmental stage, if the client is an adult and the family caregiver is adolescent or children, according to the developmental stage, as a healthcare provider, we have to communicate and we have to make them to reduce their stress level, and they have to resilience in their day-to-day life. We have to create them. Next, families and the course of cancer. So as we all know that family which is having a different transition, and course of cancer, how they are diagnosed and how they are entering into the stages of cancer. So each type of malignancy which is having an own life, of course, and family issues will be different. And each family members, they will be having an anticipate points and expected to fulfill the psychological distress. So this practical and psychosocial task of the family members, they have to take it into the transition, present transition, not in the former role, present transition, and they have to master and face the crisis from the medical checkup up to the end of life, or they are re-entry into the curative treatment. Next slide, please. The clinical course of cancer here, it has been condensed into 3 stages: acute stage, chronic stage, and resolution stage. Acute stage, it is a sudden, because initial disclosure will be a shattering event. It is a shock. So in this time, as a family members, they have to be lead, or they have to deal with the patient pain, their incapacitation, their emotional support, which will be different, uncertainty will be there, patient experience with some uncertainty, and they could not able to take care of the medical culture that can feel hospitable, unresponsive, and some of the issues also as a family members they will face, grieving what has been lost, and finding the meaning for crisis, how we have to maintain our family competency and individual competency, and they will have a maximum ambiguity to maintain the sense of hope and continuity, experiencing feeling of helplessness, lack of time to anticipate and prepare, and even experiencing little sense of control and feeling of loss, grief. So in this situation, as a healthcare professional, next slide, please. As a healthcare workers, we have to promote some strategies. So many families, with the help of healthcare providers, they will buffering the patient, and they will be supporting with all the medical procedures, their discomforts, and with the treatment and the patient uncertainty to achieve the goal of better outcomes. And here, healthcare providers, we need to maintain an open exchange of information about the patient and the family, what are the decisions. Next, we will be moving on to the second stage, chronic stage. So chronic stage is we are as a client is entering into the long-term care, as a family also, they will be having a much more strain over the acute stage. So caregivers strain on practical demands and emotional aspect, strain on finance, that is cost, time, other resources. Time won't be there. Even for cancer patient, time won't be there. Only few little time will be allotted. Immediately they have to go for surgery or some other treatment. The patient return to home, extended treatment, lengthy hospitalization will be there. Remissions will be there. And here the strategies, the family must, what they have to do with the help of healthcare providers, they have to find a way, they have to meet the immediate needs of the client and continue to organize and regulate the family. And they have to put the ship gear to the crisis-oriented response according to that particular family transition where they are. So they have to support social, emotional, and economic functioning throughout the stage of illness, and as well as a healthcare providers, they have to support the family members in this situation. So next slide, please. And so here the family members, they will be having a changes in role. From the former role, the current role will be there. The sick person, they are returned back to the from the curative treatment and capacity to rejoin the family in that role. So they will face several difficulties. For example, if you are taking, if the patient can return to school or home or work, they will be having a family disruption will be reduced, anxiety level will be reduced. But how many patients or client with cancer, they will be returning very quietly to do or to get the optimal functioning of that particular demands. So here there are in this particular role also healthcare provider, they have to teach the client and the family members. So they have to, as a family member, they have to go and temporarily or permanently they have to give a regular care until reshuffling to compensate the former role of the that particular client. Resolution stage. So this is the central task for the family, especially because resolution is an either successfully they will complete the treatment or they will go for end of life. So when the patient successfully completes the treatment, they, as a family, they have to fully reintegrate the complete health functioning as it is normal. But in this case, if they are coming to the normal health functioning, they will be as a family members make arrangements, because as a client who is having a major role in the family and immediately they are rejoining the family after a treatment, they could not cope up with the optimal role what they have been did. And at the same time, what as a family members, they can provide a room for the assumption of a new role. This can be done by the family members by the help of healthcare providers. And if you are seeing in another angle, as I said, the particular patient has been recovered. They could not, some members, they could not accomplish or relinquishing the particular care, bring back again. Next slide, please. Relinquishing the care, whatever they have been previously, they could not able to go for the former role. So this is the assumption of new role as being provided by the family. And illness, for example, this is related to curative as well as the patient who is entering into the survivorship. Survivorship, they are entering also, anxiety still present. So as a healthcare providers and the family members, through them, we have to support them. If they are going into the end of life, so the family will be going into this furthermore crisis, loss and disintegration will be there, emotional shock wave will be throughout the family which will be present. In this, two cases will be there. Families, they will be moving into two directions. One is heroic stage, another one is disengaged family. So heroic stage, what they will do, until what extent I have to go and I have to get my patient back, I have to give patient life, like that they will go. So we have to make them to understand how they have to take a decision. And if they are going into the another angle, they will be leaving the patient. So because the gradual distancing and denial, they could not accept the particular grief and grieving process, it will be going into the another direction. So one is difficult to discuss the members who are dying and making efforts to protect each other from emotional distress. This is one aspect. The another negative impact is backfire will be there. Patient and family members, they will be isolated from one another as death approaches. Next slide, please. So resolution stage, as according to Minuchin and Minuchin, he has given a 4 paradigm. As a healthcare providers, we can understand the family transition here. One is period of stability, and second one is period of challenge, period of exploration, period of re-equilibration. period of stability. So in the family transition, how the family, they are balancing their family pattern. We have to assess. And the challenges, please, okay, period of challenges to this pattern of particular illness. So in this case, what are the challenges they are facing? So explore that particular challenges to the period of exploration by the evidence, with the communication support, with the current evidence support we have to give to the family. At the re-equilibration stage, here the patient, they will be regaining or restoring the order as it is previous role, or they will be adaptive stability will be there to maintain that particular current stage of illness and the client with cancer. This period of exploration, especially if you are seeing, they will be searching for different ideas. They will be speaking with everyone. So like if you are seeing this figure, loss of control will be there, orchestrating care, waiting for a long time, financial strain, uncertainty, relationships with the stress, pressure to be positive. These are all the crises which has been mastered in the family. So here we have to restore them, this particular order, or we have to reassemble the particular family role in the particular stage of illness instead of going into the psychopathology. Here I want to say that family talk intervention. So here it is as a healthcare provider, we have to give a family talk intervention. It is an evidence-based practice, what I have shown here. The pilot study which was conducted in Swedish children, 6 to 19 years old, the children who is having a palliative care parents. Sample of 34, they have interventionist has been taken and they have been provided family talk intervention towards these children's, because they will be having more crisis and they could not able to cope up as not like adult caregivers. So children who participated in this particular family talk intervention, providing they have been got illness related information, improving family communication when the parents are in palliative care, handling school related problems, preparation for the future, decreased family conflicts, and started to build up their resilience, how they can able to move even if they are end of life. So next, let me move on to the dimensions of family adaptation to cancer. Family developmental level, family history, family relationship with healthcare providers, cultural and social context. So first is family developmental level. There are normally there are two stages of next slide please. There are two stages of family developmental level will be there. So especially they want to fulfill the normal task according to the stage of particular cancer. The centripetal stage and centrifugal stage, it's a normal family life cycle. When the client is entering into the cancer, the family will be again going into the centripetal stage. So again, as a healthcare provider, we have to bring back to the particular centrifugal stage to the current position, how they can able to take care. So this is what I want to say. Next, as a family history, as a nursing professionals, we all know that healthcare professionals, everyone, genogram, it's a picture is worth 1,000 words. So let's history speak. What is the past history, past experience of the family with the illness, losses, and other critical transitions. Family relationship. So here, family relationship, if you are saying, it will take its own signature because each family pattern is unique. Pattern of interaction will be unique. Some family, they will be very emotional and they will be having enmeshed lifestyle. Some families will be disengaged, they won't speak each other, and they will be less emotionally reactive. Even the client has been diagnosed with the cancer. And we, as a healthcare providers, we have to understand the communication styles also here. Spokespeople. Some family members, they will be keep on asking and taking an information. Some family members, they will be advocate. Okay, taking the healthcare providers information, they will be advocating the decisions. And some others avoid confronting this particular communication. So whatever it is, we have to understand the family flexibility and their range. So here Minuchin is saying, he's saying that when the family is under the stress, so they have to explore a change in functioning, and even viable families may move towards a pattern of not optimal. They will be overshooting, misinterpreting the patient preferences also. So healthcare providers, we have to understand that if it is misinterpretation is there, we have to take their client values and it should be explained to the family members, and we have to put the highest value on the topest place. Family relationship with the healthcare providers, we all know that now we are in modern medicine development. So whenever we can able to intimate the area of professionals, whenever, however the patient comes also, we are ready to take all the challenges to meet the every aspects of patient care. In this situation, what I have to say here, medical care is very smooth and coordinated, means the family will be giving a value and they will predict that particular healthcare role, healthcare providers role, and they will take the decision through the communication. If it is care has been breaks or breaks down, it has been fragmented, family members, they will be going for more and anxious, and they will go into the more stressful situation. Next slide, please. And at the same time, as I said, disengaged family is there, the sole, the point person, the patient will be sole. So they will be having more depression. This is one angle. So that will be dealt separately. If the central goal for the family oriented provider, so here as a healthcare provider, and we have to say, identify both normative and idiosyncratic point of intervention. What intervention can guide for better outcome or better quality of life? So second one is flexible system. What kind of support they need as a sick person and the family in various healthcare settings that could be identified. Next slide, please. So here, as yesterday itself, they said multimodality approach. Here I'm saying multidisciplinary approach. So collaborative, integrative, and we have to highlight the importance of family system in the client with cancer. So especially here, we have to thinking family and working systematically. What we have to think as a healthcare provider, family system, family structure, family developmental stage, family history, and how to systematically we have to organize the intervention to give a better quality of care. So these are all thinking family and working systematically. Next slide, please. Next, we will move on to the quality improvement framework. Patient and family-centered care is at the core. This is the core. So here, improve the patient experience. Here, patient experience, we have to respect them. We have to honor them with the, not only here patient experience, even with the family perspectives. Listen there, what they are saying. So then, in multiple angles, we have to analyze them, and thereby the second angle is reducing the cost. So cost only is the major role, which is making an cancer patient towards survivorship or curative treatment, because better treatments are available now with money. Next is improving population health for quality care. Leadership is very important. Our administrative pattern is important. So it has to be start from the administrative support from the national, state, and municipal level. Next slide, please. Family-centered approach model. So number one is hybrid model. So hybrid model is nothing but using often more than one conceptualization in the abstract theoretical development for finding out the finding or significant changes we can make it in the theory development. The abstract ideas we can change us. So it is a study which has been conducted, qualitative study which has conducted in Iran. It is a concept analysis, thematic analysis on family-centered care in cancer. The aim is analyzing hybrid model. There are 3 phases they have been conducted. Theoretical phase by the extensive review of literature, and field work as a sample of nurses they have been taken. Final analytical phase they have been done. What is it is yielded a result? Family collaboration with professional, with the care professional, with the family presence in the bedside, and family participation in decision making, which has been yielded a better quality care. But here only one issue is there. While they are with the patient, family with the patient, their anxiety and stress level is increased. So here, healthcare provider, we have to give a family security and support. So this is what I want to initiate here, needed to promote a quality care. Next is universal model of family-centered care. So this is has been the scoping review done on this universal model of family care. So the main goal of this is plan, development, and implementation of family-centered care. Consideration of family context. As I said earlier, family is unique and transitions are unique, and we have to consider the family strength also. And another side, illness-specific education. Illness-specific education is nothing but the learners. It is a learning between the consumers and the healthcare providers. Here, consumers are, as I already said, the client and the family members. So here we have to train the healthcare providers to communicate, how to communicate to the client and family to take or to foster a better decision making, to better development of care plan. Can you show the previous slide? Patient, family, and care provider collaboration and dedicated policies and procedures. This policies and procedures which has been done at the 2 levels, micro level and macro level. So macro level, it will be with the national, provincial, and the municipal. And if you're coming to the micro level, so it is starts with the oncologist, because we are dealing with a client with cancer. So oncologist, a surgeon, oncological nurses, healthcare providers, various teams will be there, including patient and family. Here we have to consider the family environment. So this is the scoping review, which has been said that so each and every aspects of care plan, we have to include the family in its context. Then we can able to achieve the quality care or quality of life. Next slide, please. Next is shared decision making relational elements model. It has been starting with the decision aid. Here, decision aid is communication system. Communication with current evidence. If the current evidence is there, with the current evidence, we can able to inform to the client and the family members to take a clinical decision making properly. And decision support. So this support can be given by the healthcare providers in 3 ways: listening skill, questioning skill, information giving skill. Thereby the family and the patient, they will be getting a decision making skill. So after that, they have to go for shared decision making between the patient, family, and the healthcare provider. And they have to go for collaborative conversation. So collaborative conversation, which involves life goal changes, prognosis, what is the diagnosis, what is the stages, whether they need advanced care planning or end of life, how they have to be like that, they have to carry over to the patient and family centered care. So this aspect, they have been, as one study has been done on qualitative descriptive design with grounded theory conducted in Australia. This finding highlights 3 aspects. One is positive and negative. Positive is, if we are involving the patient in a future care plans or decision making, it has been recommended. So highly recommended, the caregiver has been highly recommended. They need a caregiver support to better quality of care to the client. The another negative impact is caregiver may, as I said, override or misinterpret the patient desires, caregivers, subsidiary planning, which may warrant the further investigation. So this, as a healthcare providers or healthcare professional, we have to understand this. Next slide, please. Next, we will be moving on to the nursing professional practice model, which has been derived from Swarson theory of nursing. So, which is having 5 core values. The first, caring for a patient and family center is a main core, and which is having other 4 values. Number 1 is accountability. As we all know that it's an ethical principle. Accountability, as a healthcare professional, we have to think it's my family, it's my patient, it's my team, it's my organization, it's my decision, and which is going to put into action. So then only we can able to give a conducive environment and safety among the client and the family towards that quality of care. And as a particular nursing professional, they have to work with a team and leader committed to be evidence-based practice and enabling towards the empowerment of ask, act, and design, and inspired to learn, innovate, and excel. That is learning and innovation. Next is learn model. It is developed by Berlin and Fox. It is nothing but listen, L for listen the family perspectives and patient preferences, explain, understanding the problems of client, family, and caregiver, acknowledging, discuss differences and similarities to reach a decision, recommending treatment or care plan to the family, negotiating, reconciling them, patient cultural norms, their lifestyles according to the family transition. Next slide. Benefits of family-centered care approach. As we all know that from the previous slide, it will reduce the stress and anxiety and improve the physical and psychosocial health of the patient, improve quality of life, collaboration with the families. It gives a family sense of control, sense of trust towards the healthcare workers and client, healthcare workers and families. And client and their families experiencing less anxiety, as I said, continuity of the connection between the client and the family will be maintained, as I said, re-equilibration will be maintained here. Next slide, please. Families gain knowledge about the client, illness as well as experience and progression of policies, practices, the programs which can be implemented in various roles. As a family, they can, if they are participating in the client with cancer, continuous, complete, impartial sharing of information about client to families in care and participation in decision making in client care. Some of the barriers to the implementation of family-centered care approach here, lack of resources, as I said, mainly money. Next time. So 8 M's, as I said earlier, lack of information and understanding, attitudes, and this lack of information and understanding is not only for patient, family, healthcare providers, three together. Attitudes and beliefs towards the painful procedures, advanced technology, advanced care planning, cost of care, family stress according to their economic level, and emotions according to the disease path. Next slide, please. Emotions involved in disease path. Next slide, please. High workload. So first of all, we know, as we all nurses, we know what is reality shock. So here also high workload, we could not able to communicate properly with the families. That is also one reason will be, one issue will be there. Communication problems between patients and healthcare providers.
You can just, time is getting finished.
Yeah, ma'am. It's going to complete. Thank you, ma'am. Thank you. Inadequate administrative support and healthcare providers engagement and acknowledgement. Next slide, please. Next is perspectives on, that is challenges of family-centered care approach. According to Mosher and colleagues, there are 4. Emotional aspect, managing caregiving, dealing with uncertainty, whether patient and family, responding to symptom-related suffering. Next slide, please. Patient and family-centered. Now we saw the problem. What is the problem? That only involving the patient or family with the patient instead of that patient family-centered care for patient. And the second, the goal which has to be focused on to improve quality, safety, and outcome. Next slide, please. Solution is only 3 solutions have been given here. Creating a patient and family advisory council to, as a family, can engage in forum or long-term care facilities, and developing and refining the tool, the organization which is accepting the family-centered care, engaging with the client with cancer. And the next is cancer coaching, especially for healthcare providers, and empowering the patient, engaging the family, enabling the care for better positive outcome. This is the conclusion. So as we all now entered from the patient-centered to family-centered care, so in the continuum, because the outcome will be different. We could not say client with cancer, they will be live or getting sick or receive treatment or recover, or they will go for remissions or death, whatever it is. So here, as a partner, partnering with the patient, family, and healthcare provider, we have to support the family as well as giving an insight to construct the decisions in a positive outcome with the transformational information that is evidence-based for the high quality of care and high possible long-term outcome. So like that, if you are planning, it will be easy to gain the challenges or meet the challenges, because demographic changes is there and biomedical technological changes is there. So they have to adapt. Some of the references have been given here. Can you proceed the slides a little faster? Next. These are all the references which are taken from the PubMed. And please end. So here, what I want to say with the figure, we have to take a patient and family with the right path, right direction, and we have to protect the family and the patient together to approach for patient satisfaction, efficient and effective quality care. Thank you, one and all, and thank you, especially my special thanks to Dr. M.J. Kumari ma'am, who has given this opportunity. Any queries you can ask.
Thanks, Ms. Gomati. You have presented in very detail about family-centered care for the oncology patients. So you were very rightly talking about the patient and family-centered care, which is the cornerstone of the oncology nursing care, which can reduce the physical and mental challenges of the patients as well as improve the quality of life of the patients. So as you rightly told, some of the cancer patients, they get back to the society with a near normal life. Some get back to the family with near normal life, but with a lot of challenges, physical and mental challenges, and some enters to the palliative care. And so some of the interventions that in Indian setting, what we do over here include, like, that one is like support groups, cancer patients and caregivers support group, and like the ostomy support group, etc., where the patients can share their experience and how they overcome various challenges. Because though it's easy for us to give health education and other things, but they are the one who is actually facing and actually utilizing various strategies to overcome those challenges. So support group is one of the things that is happening in India. Other one is like like technology, use of technology, telemedicine, telenursing to train especially during the COVID also, it was very useful to train the family members and the patients. Even an ICMR project under being Dr. Gopichandran, yesterday he was a speaker, he being the principal investigator, we had done a project where we had installed a mobile app in patients' phone to enhance the medication and adherence. And it was found that it could reduce the pain and other side effects of the chemotherapy drugs and the problems what patient is facing. And the other thing is that we have in India, NPCC, that is a National Program for Palliative Care, which was initiated in the year of 2012, and for which I am also a trainer, where we train medical officers and ANMs and community health nurses on palliative care. They visit the patients, and most of the patients who are registered in this palliative care program, they get almost all the services free, including medicines. So every month, or if needed, even more frequently, they visit the patients, and even they are trained on, ostomy care, wound care, counseling, shared decision making, as we're telling, bereavement care of death and dying, etc. So it's a very big support. It's very prevalent in actively going on in Kerala, West Bengal, Assam, Telangana, etc. Other states, even almost all the states, it's implementing now. So I think so. This is the Indian scenario. So what about in Malaysia? How the home care has been facilitated for the oncology patients?
Same as it is. Each and every hospital, they are having telenursing, telemedicine and telenursing. Through that, they are overcoming this. But each and everything they have to pay. Cost will be there. So without cost, they could not able to acknowledge or they could not able to recommend that. And if, for example, if the colleges, they were going into the community, and with the support of the governmental support will be there, some of the organization which has been undertaken by the private, like NGOs, they are running. So through them, they are getting some supports, same as it is Indian scenario. But wherever it is, even Indian scenario, or it is a well-developed country, still there is an dilemma. So it is reaching to the up to the tribal. We could not say even it is a developed country, everyone are getting, no, everyone not getting a proper family-centered approach. Whatever we are facing here, as it is same as a nurses, we are also facing there. With the reality shock is there, we could not able to get a time. If you are getting on time also, the family members' role is little bit different. So like disengaged families will be more than compared to the enmeshed family. So like that we are facing, but I could not, I don't know about into the governmental sector, because I'm working in a private sector. I was worked. This is the one, telenursing and telemedicine, which is focusing towards the family-centered approach with the cost.
Okay, and here again, thank you. And again, here nurse-led clinics are coming up for breast cancer patient, even in PGI, and the guidance of Dr. Supal Kaur and us, we have started a nurse-led breast cancer clinic. So similar to that, any nurse-led oncology clinics are there?
Yeah. Clinics are there. Clinics are there. It is running, but it is not like some of the government sectors also is there in India. But here in Malaysia, the minimum amount to be paid to that particular sectors, and they can able to pay.
Okay.
Like that.
As you rightly told, actually here also NGOs are very much supportive for this NPPC program, so which actually facilitate the home care of patients who are undergoing palliative care. Thank you, Ms. Gomadi, once again.
Yes,
so
thank you very much.
So we all know that chemotherapy drugs are one of the the only one and only treatment modality, one of the main treatment modality in the cancer patients. So we know that a lot of side effects patient can undergo, a lot of benefits patient gets due to with the help of chemotherapy. But as well as we know that a lot of it has some of the toxic effects which can affect the nurses who are involved in preparing this. So how we have to handle chemotherapy drugs? this information or the awareness is not only important for the nurses who are preparing the drugs, but also for the educators, administrators, chemotherapy nurses, everyone. It is very, very important. So today we have an expert to talk on this topic, how to handle chemotherapy drugs. So we have Dr. Lakshmi Ramamurthy. I'm very happy to introduce her. In fact, she is my friend and she was my colleague and during my MSc in AIMS Delhi. So we were the first batch of MSc nursing in All India Institute of Medical Sciences, from 2004 to 2006. So I'm very happy to introduce her, and I would just like to tell about her. She has completed her BSc from KG College of Nursing, Coimbatore, Tamil Nadu, and MSc from AIMS Delhi, and in critical care nursing, and PhD from INC National Consortium, and also she's pursuing a course in advanced course in research and statistics. And she has also work experience as assistant lecturer in Sri Devraj College of Nursing, Karnataka, Padma Shri College of Nursing, Bangalore, and KGNC Pondicherry, and now she is since 2010 working in JIPMER as assistant professor. She is involved in training masters and PhD scholars, and she's also a member of various committees, ethics committee in JIPMER, and also research monitoring committee for PhDs, MBBS, and nursing in JIPMER. And she is also involved in various research projects, funded projects, intramural funded project in JIPMER. So she has about 17 years experience in the field of nursing in various capacities, including staff nurse, some clinical in charge, lecturer, assistant professor in different institutions. And her field of interest is non-communicable diseases. And she's also, as I told, member of various research monitoring committee, also board of examiner in different universities, and GFATM and TB trainer. She has contributed 4 chapters in different books and organized conferences and workshops. And she has very good publications, and mainly in index journals, and more than 30 publications are there. She's a very good nurse because she is my friend, I know that. So over to Lakshmi, Dr. Lakshmi.
Thank you, Dr. Manju Dandavani. I share my screen, ma'am. Just a second. Is the slide in full mode?
Yes, yes.
Yeah. It's a very good morning to everyone. I take this opportunity to thank the organizing chairperson, our beloved principal, Dr. M.J. Kumari ma'am, and also Dr. Padmavati Nagarajan, the organizing secretary, and all the team members of our college. It's a team effort. Everybody has contributed to the for the good outcome of this conference. So I thank everyone for this opportunity. So regarding about this today's session, we know that cancer care is a complex phenomenon. In this, in the oncological nursing practice, the medication administration is the core of the nursing practice, core of the oncological nursing practice. There is a chances of the errors. If error happens, there may be the catastrophic event in the oncological patients, even death would occur. So today's session would be how do we handle the chemotherapeutic drugs, and what's our role, in nurses' role in administering these chemotherapeutic drugs. So end of this session, we'll be able to cover, these are my objectives, especially focusing on the chemotherapeutic drug administration and what are the different methods of administration. And also we must be able to differentiate what are the vesicant and irritant chemotherapeutic drugs. That is to prevent extravasation and some safety standard for nurses. So end of this session, I hope I'll be able to do the justification for these objectives. So since yesterday we are listening, the goals of chemotherapy, the purpose of chemotherapy is either it can be classified under either it can be an adjuvant therapy. The adjuvant therapy is nothing else, mostly following the surgeries, to prevent a reoccurrence, we use it. And neoadjuvant, it is mainly being used to shrink the tumor before the surgery, so that the surgical procedure would be easy. And or it can be the chemotherapeutic drugs are given for the palliative purpose, or it is maybe for the palliative purposes, and that is in the palliative purpose. When it is being given, it increases the survival rate, also symptoms relief. Induction chemotherapy, that is mainly the induce the remission, or it can be the consolidation chemotherapy, that is to sustain the remission. Once the remission is induced, after that the remission phase will be sustained for the consolidation chemotherapy, or it may be the maintenance chemotherapy, that is mainly the prolonging remission phase. Whatever the phase, when we administer the chemotherapy, it is associated with the many the medication errors. So why the chemotherapy administration standards are important? If you see, this is the oncological American, the standards are based on the American Society of Oncology. It has a 2016, they have published this oncological nursing standards, which is being practiced worldwide. So if you see why this chemotherapy administration standards are necessary, if you see, as I said earlier, the error happens when we administer the drug to the patient in the various phases, from the preparation phase to the administration phase. There is a chance for the error. This is in a study, it shows 63% of the nurses who administer the parenteral chemotherapy drugs, they have reported that they know themselves that there is a personal knowledge of the medication error. The reason for the chemotherapeutic drug administration is, we all know these anti-neoplastic drugs are very toxic. It causes a very hazardous outcome to the patients. It also has a various the narrow therapeutic indices. And further, most of the time we will see the novel agents are being administered with a combination of the other drugs. When these drugs are administered, there is a various drug adjustment and a precise monitoring is needed. So here, the nurse must be aware of all these standards to prevent the side effect to the patients. Let's see what are the role of the nurse in chemotherapy administration. The nurse's role, it starts with the checking with the chemotherapy orders. The first she must be checking about the patient name before administering. And the another concept is before administering, when she reviews the chemotherapy orders, the second patient identifier. This is the second patient identifier is a concept. It is for the identification of the patient, also for the identification of the drugs which is being prepared by the nurse. Both the way it will be applicable. So whether the second patient identifier is being written, second patient identifier in the sense, other than the patient name, what are the other identification? Is it a patient date of birth? It can be any other driving license with the second patient identifier. And again, this is regarding the patient. If you take about the nurse, when the one nurse prepare the drug, there should be a second designated person to check what is a prepared drug before administration. So this has to be mentioned in the chemotherapy order. So she will be reviewing that also. And what is the date of the order written and what is the regimen? There are various regimen and protocol depending on the type of cancer. For example, breast cancer protocol would be different. At the same time, the patient of the CS cervix protocol would be different. So what kind of the regimen is being advised? And again, each regimen or the protocol may have the different cycles and each cycle may have the different phases also. So what is, she also should be reviewing that. And all the medication within the order set are listed by using full generic names. And further, when she reviews the order, she should know that what is the trade name and what is the generic name. Even there was an incident when the nurse administered instead of the the following appendectomy for the painkiller, that is for the pain medication, she mistakenly administered the vecronium. I hope you know, the one is the muscle relaxant, vecronium is the muscle relaxant, where this is the Oviran is the painkiller. Without checking, because it looks like sometimes there will be confusion. Some drugs maybe the sounds like, some drugs maybe the look like. So when we check it, always double check with the generic name when we review the order, not with the trade names. And drug dose, whether it is written following the standards abbreviation. That is, what are the trailing zeros? That is leading zeros. It means after the decimal point, the how many number can be considered as appropriate. And dose calculation, mostly the dose calculation is being done on the total body surface area. And what are the other variables being considered for the dose calculation? So the first step would be she would be reviewing the chemotherapy orders. The next is after reviewing the chemotherapy order, the nurse, the main role will be the clinical assessment. The clinical assessment, which include pre-existing health problem, whether the patient, other than the cancer, what are the other comorbidities patient has, and what are the allergies patient has allergies to any medication, or anytime previously patient received the chemotherapy drug, that history she should be able to check it. And what is the age of the patient? Because as the age advances, the chemotherapy side effect is more. So what is the age of the patient and what is the stage of the development of the disease and which stage, which TNM classification the tumor is there? That also she should be able to review. And further, the more important is the reviewing of the hematological parameter. We all know upon receiving the chemotherapeutic drug, many patients will get into the bone marrow neutropenia and the thrombocytopenia related complication. Whether the patient's counts are within the normal range, that has to be checked before. The clinical chemistry, other parameters also to be whether it is the normal range, like whether the renal function parameters, whether whether can we proceed with it, because many drugs are nephrotoxics. When it is administering already, if the patient is having the underlying CKD, which will again cause the more morbidity to the patient. So that also should be checked in. Again, if the patient is a cardiology patient, also he is in a failure, that means the drug dilution should be taken care. So that also clinical chemistry parameters, also clinical condition parameters, the nurse must be able to check. Venous axis. Another component is the venous axis. Mostly the drug is being administered 80% of the time, which is by the venous axis. So it is whether the venous axis and what is the site and position and patency of the vein and the integrity and the visibility, this all should be able to check. Of course, the psychological factors also, whether the patient is ready to receive the drug. If he's not in position ready to receive, the related complications also arise. So this is about the clinical assessment before administration. The next is the patient and the treatment identification. That is very much important. As I said, the drug once before preparation, there must be two patient identifier other than the patient name, other identifier, which is established identifier in the hospital protocol, that should be ensured for before administering the drug. And the nurse also must be checking the drug generic name, what is the dose and the route of administration, and what is the rate of administration, and how it is calculated, on which treatment cycle, on which day of this particular cycle, and also what diluents has to be mixed with the drug. So that these are the verification should be done before preparation of the chemotherapeutic drugs. The next is upon preparation, as I said earlier, once the nurse prepared the chemotherapeutic drug, the second check will go for the again by the identified person as per the unit protocol. She will be checking, the second nurse will be checking the drug vial and whether the concentration is appropriate and whether the drug volume is adequate and what was the diluent time was used and administration fluid time, and also which tubing is through which the medicine is going to be administered. This is by the verification by the second person. So here we have to understand that it's also the second identification is for the both for the patient, also for the drug once it's prepared. It both has, this will be avoiding the error. This is about a study where we have appointed a verification nurse. What is the effect of this verification nurse before the administering chemotherapeutic drug? They have monitored the chemotherapeutic events while administering from the 2009 to 2015 after appointing the verification nurse. So there was a total of 4,282 events which was prevented because of this verification nurse, mostly because of the prescribing errors. So, so every time, because there will be a chance for the error, that is especially medication errors, there are more chances. So there should be a standards and protocol in a unit to prevent this kind of errors, because this sometimes, many times, this we may take it as a easy, but it's chemotherapeutic drugs are not same like other drugs. Not anyone and everyone can administer the chemotherapeutic drug. The person must be aware of what kind of the drug and what are the side effects of this particular drug on the patient, how it is the special preparation is needed, so that the second verification will be useful to prevent the error. Let's move on to the routes of administration of the anti-cancer drugs. What are the standard care guidelines for administering IV chemotherapy? As I said, there are various routes. One of the main routes is the intravenous administration of the chemotherapy. So before administering, what are the standards here in the IV drug administration? Verify the signed consent, which is signed with. It is that consent form should be signed, but the nurse must be checking. Also, they take the measures to perform independent double check of the original orders with a second person. The double check for the accuracy of the treatment regime, also the calculation, and calculation is based on which variable, is it body surface area, and what is the schedule, she must be checking it. And recalculate the chemotherapy doses independently for accuracy. Even though we calculate once, recalculate it, because because these drugs, as I said, they have the narrow therapeutic range. If it is in drug dose is increased, then maybe the chemotherapeutic side effects will be increased. And verify the appropriate pre-medication and prehydration orders. Most of the chemotherapeutic drugs causes the nausea and vomiting. So many patients will be receiving the antiemetic protocol. Also, there will be the antihistamines, because to prevent the hypersensitive reactions, the pre-medication will be the antihistamines or the steroids will be given. And prehydration orders also, because some of the medications will causes the nephrotoxicity. So patient must be hydrated well before the administration of the drug. So what is a unit protocol and administration of the particular drug? So what is a prehydration should be given on which fluid, and how much prehydration and how much was the volume per hour, that should be checked according to the unit protocol. This is essential. Pre-medication and the prehydration orders to be checked accordingly. The patient should be treated with the pre-medications and the prehydration before administering the chemotherapeutic drugs. And when we administer the chemotherapeutic drug, we must be knowing about what are the type of these chemotherapeutic drugs. Generally, these chemotherapeutic drugs we classified under the vesicant and the irritants. What are the meaning? What is the meaning of vesicant? If you see, once upon administration of a particular drug, if at all it infiltrate, that it goes out of the vein, that will cause the tissue necrosis. That which causes the tissue necrosis, we call it as a vesicant. Again, this vesicant, it will be classified under the two types. One is a DNA binding, another one is a non-DNA binding. If you take the DNA binding, once upon infiltration, what will happen? This drug will be binding with the DNA of the adjacent cells, which is there in the maybe the interstitial cells, and it causes a necrosis. After the necrosis, from what will happen? From the cell death, again this chemical will be released, and surrounding areas also will be. So that is the damage which will be caused by this DNA binding vesicant drugs causes the more damage compared to the non-DNA binding vesicant drugs. So message here is we have the chemotherapeutic drugs which falls under the mainly the vesicant and the irritation. One is a DNA binding and non-DNA binding. Again, the DNA binding causes the more damage compared to the non-DNA binding. So we say once the infiltration occurs, the common complications are the pain. Patient may have the burning sensation, also the stinging and erythema and sudden onset of the severe pain will be there, and also tissue necrosis. The tissue necrosis may vary from the superficial to the deep. Even I'll show the case scenario where the whole thickness of the muscle has been lost, where the patient has been surgical reconstruction with the skin flap was done. So the another kind of drug is the irritants. So irritant drug, while this the name drug, the patient may feel the burning sensation. So it is pain at the injection site, also along the vein. So that is an irritant drug. But however, compared to the vesicant drug, this will not cause much damage. So these are mostly the non-vesicant drugs. So second classification is the irritant drug. And the next is the inflammatories and the neutrals. The inflammatories causes the moderate inflammation. That is the it's like a phlebitis. Same like any antibiotic when we administer, we expect the phlebitis. So that is the inflammatory drugs. Commonly the 5-fluorouracil and methotrexate, it comes under the inflammatories. The neutral drug classifications. These neutrals are the drugs neither it causes inflammation nor the damage. The another type.
Please mute yourself.
Another classification is the exfoliant. This exfoliant cause only the superficial exfoliation of the skin will cause. It will not cause the damage to the skin, only superficial tissue injuries. The common drugs will include the cisplatin, docetaxel, and liposomal doxorubicin. This comes under the exfoliant. So with this, we can say the major classification is the vesicant and irritant, which the nurse must be knowing what are the vesicant drugs. And again, vesicant drugs, as I said, once the vesicant drugs infiltrate, it becomes extravasation. While administering, due to the administration error, if an extravasation happened, that area goes for the necrosis. So again, vesicant drugs, these are the DNA binding agents, vesicant drugs, that is mainly the alkylating agents, that is the nitrogen mustard and anthracene. These are all strong vesicant drugs. And other agents, including dactinomycin and mitomycin, comes under the vesicant DNA binding agents. And non-DNA binding agents are almost all the vinca alkaloids comes under. Vinca alkaloids are the vesicant, but that is a non-DNA binding. This also causes the tissue necrosis, but damage may not be same to the DNA binding agents. And irritant drug, these are the classification. These are alkylating agents, including carbaplantin, carmustine. These group of the drugs will comes under the irritant classification. The same classification. When we administer through the bolus, when we administer the IV bolus chemotherapeutic drug, mostly it is administered through the line is not available. When it is administered through the peripheral line, the new cannula is preferred. And when irritation to the veins. And again, vesicant should be administered very carefully. If more drugs are administered, vesicant drugs are chosen first and followed by the non-vesicants. So because vesicant drugs, following the vesicant drugs, will be flushing it. that will flush off the irritation effect, and followed by other drugs are being given. And once the peripheral line is chosen, changing the cannula site after 24 hours is considered. Even though maybe sometimes if the fluid runs freely and there is a good blood return, peripheral vein, it is better to change the cannula and every day to prevent the complications. Always before administering, check a blood return so that the drug is not being injected extravasation. We are not infiltrating the blood. Return should be checked in, so the medication is being administered through the vein. That has to be checked to prevent the extravasation. So again, when we choose the medication administration, mainly the forearm veins are preferred. In the forearms also, compared to the preferred site is usually compared to the distal veins are chosen than the formal veins. That is, you choose the distal areas because again maybe avoid the areas where it has a flexion, where the bony antecubital area, the ulnar and the radial, where the nerve endpoints and nerve flexes, that wherever that area is there, that has to be avoided. Because if at all, if the drug causes the extravasation, the nerve injury can be prevented. And peripheral site should be changed daily. And when we choose the lumen, there should be a small lumen veins. Actually, it is a legible vein. It is not a small lumen vein. It is a avoid the use of the small lumen veins, and always small cannula with the legible veins. It should be the small, always the approach should be the cannula should be smaller, appropriate. At the same time, with the good vein, this very smaller vein should be avoided. Very commonly, we practice in the daycare the butterfly needle. Butterfly needles are not advised because butterfly needles are more. It is plastic. That is, butterfly needles. It is more rigid. When the patient moves, there is a more chance for the damage to the vein. Out of the butterfly veins butterfly cannulas are avoided, and plastic cannula, that is with maybe the 20 gauge needles can be the preferred for the daycare also, and 22 gauge needles. And the vascular access, since many speakers were discussing about the vascular access, mainly the route would be of the central venous access device. If the patient may be going with the periphery, if the periphery, again, when the patient long-term chemotherapy, I hope you all know about the peripherally inserted central line catheter and Portacat catheter. This is if you see the Portacat catheter and the peripherally inserted catheter. Also, when the patient who is having the long-term chemotherapy is being administered, so that every time the everyday pricking of the vein is carrying of these cannulas. We have seen yesterday under this separate session, that is care of the patient with the central venous access device. And whenever you use the medication administration, always use the liver lock syringes. The main here you can look at it, liver lock syringes. The tip you can see it is and the IV set should be of the liver lock systems to prevent the drug spillage, drug leakage, and also the nurse also will not come in touch with the drug. So the liver lock syringes and the infusion set will prevent it. And when we administer the drugs, these are the critical areas where the tip areas. The nurse should not touch these critical areas to prevent the we should not touch it, these critical areas, and also maintain the aseptic technique. This critical areas should not be touched. When we administer the chemotherapy drug as a infusion, always the infusion set should be primed, that is flushing with either the appropriate solution, usually either through the regalactate or the amoxicillin, and using the non-touch aseptic technique and wearing the protective, that is including all personal protective equipment is necessary. And the patency of the line should be confirmed first. The blood return should always be before the vesicants are administered. And prior to administration, the patient should be advised of the possible local adverse event, because some drug causes the patient may have the allergic reactions. So the patient should be educated. If the patient develop any kind of the symptom, they immediately should inform and the drug should be stopped. Appropriate action should be taken. And also the infusion site should be checked according to the extravasation policy protocol of the institute, and also for the systemic adverse reaction, the infusion site to be monitored. If extravasation occurs, the very common complication with the chemotherapeutic drug administration is the extravasation. Once the extravasation occurs, if you notice the extravasation, immediately stop the drug. Immediately stop the drug, and any residual medication or the blood should be aspirated with a separate 10 ml syringe. We have to aspirate it so that the local area is not littered with the same medication that is in the subcutaneous area. The IV cannula is removed. Mostly it will be removed, but before removal, you can inform the physician. It can be the because if the IV cannula is there still there, it further anyway the drug is extravasated. There is no use of it. It's better IV cannula can be removed. The affected limb should be elevated for the 48 hours, and the surgical consultation and the photograph to be taken, because these drugs can cause immediately. There are some antidotes, and the nursing precautions would be of the elevation of the hand, residual drug removal, and also the application of the cold pack and hot pack. Only for the Vinca alkalides, it is a hot pack, because cold pack will cause the further the tissue necrosis by the vasoconstriction. Other drugs, it can be the cold applications. The specific antidote as per the unit protocol, because these antidotes can be injected surrounding the area where the extravasation is occurred, that is subcutaneously. Topically also, subcutaneously also, with the use of the appropriate needle and syringes, this antidote can be infiltrated to prevent the tissue necrosis in that area. The grading of extravasation, if you see, maybe the ranges from the no symptoms to the erythema, that is a grade 2, and ulceration or the necrosis is the grade 3, and that is a life-threatening. The total necrosis patients is developing into even the veins are damaged and to the death. These are the grading extravasation. As I said, each drug, most of the drug, it will be of the topical cooling, except the Vinca alkalides and oxaliplatin, there's a topical warming, because in the Vinca alkalides, if following administration, the cold application causes the vasoconstriction in that area, that again causes the tissue necrosis. Antidote, the common drugs which is used are the hyaluronidase, which degrades the hyaluronic acid and break down the subcutaneous tissue bond. Normally, it is being used as a 1 ml. It is administered as a 1 ml. It is divided as a 5 lots. It is divided as a 5 lots, and each lot would be of the 0.2 ml. It being administered with the using the puncture mark, and surrounding area of the 25 gauge needle, it is being infiltrated surrounding wherever the extravasation is there, and followed by it may be with the irrigation with the 0.9% of the saline. The another drug which is used is the sodium thiosulfate, also as the antidote for the extravasation. And next is the dexamethasone, that is the only treatment approved for the anthracycline extravasation. Dexamethasone is being used. These are the common antidote which is in practice, but to check with the unit protocol, whatever the drug, according to the each drug, it differs the particular antidote. So that has to be used it for the prevention of necrosis in this area. The same, this is a guideline. What is the Oncological Nursing Society of the American Society, which recommends the antidote for the extravasation. So what is how do you prevent the extravasation? Usually before administering, we must be knowing, is it a vesicant drug are we administering, or is it a irritant drug? Irritant drug means we should be careful, but still the extra precautions to be taken if at all vesicant drug. So that's what knowledge of the drug before administering is essential. And administration of the vesicant agent should be carried out through the central vein whenever is possible. Whenever is possible, the central line only, the vesicant drug should be given. If at all, if you don't have the central line, use the peripheral line. During the peripheral line administration, when we initiate the peripheral line, avoid the dorsum of the hand, antecubital region, radial, ulnar region. Because these are the areas where the nerve plexus are there. If at all tissue necrosis occurs, the nerves will not be damaged if you avoid these areas. Peripheral assessment will give an idea about the fragility of fragility of the veins, whether multiple puncture has been done, what is the vein anatomy, you'll be able to understand. And identify the potential risk factors before inserting Venflon or administering chemotherapeutic drug. What was the number of puncture being done, and what is the patient, whether the patient has any disorders of the movement like a Parkinsonism, or whether he has a sensory deficit. Because sensory deficit, he may not be able to listen to the nerves and he may be moving it. That will lead to the while administering drug extravasation. And if at all this, as I said, the butterfly needles to be avoided. And if also inadequately secured peripheral IV catheters, before administering, please check whether the peripheral IV catheters are properly secured, because if it is the loosened catheter, there is a chance that peripheral spilling up out of the medication. And further, central venous access for the, if at all 24 hours second infusion, it must be through the central venous access, not through the peripheral, when the drug is being given as infusion for the 24 hours. Administer the drug in a quiet and hurried environment. We may have like a tertiary center like ours. Maybe there is a lot of patients in that our daycare, but still it should be proper lobbying with the nursing, other higher nursing officials. So adequate nursing staffing should be ensured to prevent this very hurried environment related errors. So it should be given the quiet and unhurried environment. Testing the vein patency without using the chemotherapeutic agents. That is, before the chemotherapeutic agents, administering, test the vein patency with the flush, maybe the normal saline or the D5 vein patency to be checked. Provide the adequate drug dilution as specified in the protocol, and use the smallest size cannula in a larger vein. As I said, the vein should be the legible vein, that is a larger vein, and cannula should be smaller, and the plastic cannula length should be 1.2 to 1.5 centimeter, preferably. Maybe the 20 or 22 for the adult patient would be sufficient. Careful observation of the access site and extremities throughout the procedure, whether the patient developed any extravasation, because if it is unnoticed, there is a tissue necrosis will occur. And educating the patients regarding the symptoms of drug infiltration, that is especially the presence of the pain and the stinging sensation at the IV site, to be educated to the patient. This is actually following the epirubicin. It was a delayed identification of this extravasation. You can see on the 11th day following the drug administration, you can see only the superficial, that is exfoliation, is being noted. But look at it on the day 20, as it is identified later, the total necrosis, it is a full thickness, including the muscle, even the bones can be visible, full thickness. So the same patient has been underwent the surgical reconstruction with the flap. So this extent can happen, extravasation with the Vasecan drugs, if that is mainly of this error, and this harm, catastrophic event can be prevented by the nurses if it is administered with the standard protocol and when we administer with the care. Next, it is about the administration of the chemotherapeutic drugs orally. So tablet, when we hand over the drugs, we should not touch the drug. Usually that is non-touch technique should be used. And oral doses of the chemotherapy should be dispensed with the disposable, it is by the separate cup, and that can be discarded after administration. Always the oral chemotherapy drug should be administered with plenty of water, if at all the patient doesn't have any cardiac failure and any CKD which needs the fluid restriction. And the patient, this drug should not be chewed to avoid the local irritation. Tablets should not be preferably crushed. If it is crushed, there is a chance for exposure to the oral mucosa and even swallowing the esophageal mucosa. Preferably, it's not crushed, but there are situations where to be crushed in children, the different formulation can be asked from the physician. Tablet crushers and the splitter should be rinsed with the water after use. Avoid splashing that may contaminate the surrounding surfaces. The next route of administration is the intramuscular. Though 80% of the time it is being administered through the intravenously, there are certain drugs which is being administered through the intramuscular also. When we administer through the intramuscular, same like other technique, appropriate needles and all is being chosen with appropriate muscle mass, where is it a gluteus or usually it is not being avoided into the where the lower muscle mass, where the appropriate muscle mass is there it should be given, and use the Z-track technique. The Z-track technique should be used to avoid the leakage into the skin, so that the drug is being instilled into the muscle. And some hormones, it's also being injected through the subcutaneous route, especially the hormonal agents is being same like other drug preparation precautions. This when we administer the hormones to the subcutaneous, depending on the needle size, is it a 45 degree or the 90 degrees being chosen appropriately. Usually the insufflant needles should be considered if the patient requires the multiple insufflant needles. The sites it's been shown insufflant needles which has the adapter where you can multiple injections are being given, so you can just lock it and set another syringe, you can use it. So when the multiple injections are being used, insufflant needles are used. Ensure the no leakage from the site, cover with the cotton wool following administration. So the next method of administration would be of the intrathecal. Intrathecal, it is when the patient has the malignancies of the, especially the hematological malignancies, that is especially acute lymphoblastic leukemias, when there is malignancies there, the secondaries are there in the prime. In that condition, we use the intrathecal administration. Generally, the intrathecal administration is through the lumbar puncture. The common drugs which is administered through there is the methotrexate, and it is a cytosine arabinoxide. These drugs are being administered intrathecally. The main here, the nurse role will be, usually this drug is being administered through the LP. Physician would be administering it. The nurse role will be assisting it. But if the patient has the Ommaya reservoir, the nurse will be administering through the Ommaya reservoir so that the drug will reach the spinal space. We have to understand that the CSF half-life of this methotrexate and this cytosine drugs are much prolonged. So there is a chance for the chemotoxicity and proper monitoring to be given. So whatever the route we administer, we have to educate the patient about the patient diagnosis. What is the purpose he is receiving the chemotherapy, whether it's for the remission or for the maintenance or for the reoccurrence, or is it for the palliation? What is the main goal of the chemotherapeutic? That has to be educated to the patient so that we can get a cooperation from the patient. And also the planned duration of the treatment and scheduled treatment administration, and we have to educate the patient. And potential long-term and side effect, long-term and the short-term side effect also educated. Because patients sometimes we'll see that the adherence to the drug will be lesser if they are not educated well about the adverse effect and how to overcome the adverse effect. And usually the symptoms or events that require the immediate discontinuation of the oral drug also to be educated to the patient. It's about the drugs administration. Other than that, the nurse's role would be of especially the personal protection. All the chemotherapeutic drugs should be handled with the care because these are the hazardous drug agents. So always double chemotherapeutic glove and a protective chemotherapy gown should be worn. And if at all there is a chance for when the liquids are being prepared, there is a chance for the splashes, eye and face protection, and the respiratory protection. Respiratory protection, normal, either the N95 or the 100 or the even the cloth mask is not protected. If we expect there is a chance for it means there is a chance to inhale the chemotherapeutic drug. Appropriate chemotherapeutic respirators are available. That should be used when preparing the drug. It may not be that much. Inflationary harm would be there with the administration, but it will be with the preparation. There is a chance, especially when we dilute the powder form drugs. So this normal mask will not give the adequate protection. So especially these kind of the drugs, especially carmustine, cisplatin, cyclophosphamide, etoposide, these drugs, when we prepare it, appropriate respirator should be used to prevent the occupational exposure. Other factors which include unit surveillance. The unit surveillance which include, there are chances that sometimes the spill up. Chemotherapeutic drugs will be spilled. For the spill management, there should be in a unit, the spill management protocol should be there. All individuals involved with the spill cleanup must done the hazardous drug tested PCP. And usually we'll say that the spill is, if it is less than 5 ml.
Quickly?
Yeah, sure. It is a 5 ml. If it is less than 5 ml, it is considered as not risky. If it is more than 5 ml, appropriate persons using the protocol should be used. If you don't have the appropriate solution, there is no recommended solution. Usually the 10% bleach solution with the 1% sodium thiosulfate followed by the 1% sodium thiosulfate is used. And whether the hazardous drugs exposure is there in the area. This swipe testing, this is also unit protocol for the unit surveillance. The nurse also must be aware of educate the patient about the common side effect, which we have learned yesterday. The common side effect, which include the nausea and vomiting, it is being commonly treated with antiemetics. Also the bone marrow suppression that is being treated, that is bone marrow suppression, mainly the neutropenias and thrombocytopenias related precautions to be taken while carrying. And other side effects, also oral mucositis is another common problem, especially with the head and neck cancer, which is exposing to radiation therapy. That also appropriate protocol to be followed. And febrile neutropenia. So key message here is, while administering chemotherapeutic drug, it is adherent to the chemotherapeutic drug administration standards as recommended by the various agencies. That is significant. And also the protection of the healthcare workers is essential. And early identification of the chemotherapeutic drug side effect is a significant essential step in improving the quality of life of the patient. With this, I thank the organizing team, also the moderator, for the opportunity.
So thank you, Dr. Lakshmi. Thank you for detailing about the nursing interventions before, during, and after chemotherapy, administering chemotherapy, and also discussing about various side effects and unit management and surveillance. So I just would like to ask you, like we're telling that Potacat we can give. Are we using in your setting? PICC?
Liver lung syringes we are using.
Okay. Okay.
We are using.
So, like, I think if Ms. Gomati can add, I think if they are using in Malaysia Potacat for the patients who are getting long-term chemotherapy.
Yes, ma'am.
I'm sorry, you're asking about Potacat. Yeah. Our long-term patient,
Yeah.
there are even our chemotherapy, we have trained nurses are there. Our chemotherapy, there are 2 trained nurses are there. These nurses will handle the even this peripherally inserted catheter insertion trained nurses are there. We have. And even long-term maintenance also, especially handled by these nurses. Especially under the surgical gastro oncology, surgical oncology, there were 2 nurse trained specifically for the peripherally inserted catheter insertion for the also the Potacat maintenance also. We have unit protocol in our area.
So happy to know that you have specialized trained nurses only for chemotherapy administration. So that's how we are coming up with specialization and utilization of the skill of specialized nurses in India. So do these patients require any special care during their home care? Potacat, those who are on Potacat.
Potacat, it is having somewhat, it is, looks like, just a second. Yes, same like a similar central venous access device. The patient should be taught, usually these Potacats are, it's being implanted under the subcutaneously. It is so while accessing the drug, the patient should be taught whether above over the area is there is any redness and is there is a skin changes. They have to intimate to the healthcare provider immediately, and unnecessary touching of that area, even the loom and where the medication can be administered. This can be educated to the patient. The special even over movement, avoid excessive movement, the weight lifting to that area, that can be educated to the patients, especially when they are in home care.
Thank you so much, Dr. Lakshmi, for detailing very much about the management of chemotherapy drugs. Thank you for sharing your expertise. Okay.
Thank you.
Any doubts from the audience? Like after the last talk, I forgot to ask. Any question? There are no questions I'm finding in the chat box. If anyone is having any doubts, quickly you can take. We can take up 1 or 2 questions. If not, we can move to the next session.
Yeah, as you said, actually, JIPMER is the one of the tertiary care center. Also, it is a regional cancer center. So when we receive the patients from the many states, that is southern states, the nurse-led care really bring a change. We have our PhD scholar, one Mrs. Arunisha. She's doing under the guidance of Dr. MJ Kumari, especially for the breast cancer patients, lymphedema. Such kind of services really will improve the patient's quality care. It is much needed area, this quality nurse-led services for the
even lymphedema nurses in Western countries. I've heard about the lymphedema nurses. So
yeah, we have our one of our faculty
come up in India too, right?
Yes. One of our faculty is doing a project that is, she's a PhD scholar.
Very good. So we have so far heard about the patient and family-centered care, and also we learned about the responsibilities of nurses while administering chemotherapy drugs. So we know that chemotherapy drugs are to kill or destroy the cancer cells. They have the potential to kill all the fast-dividing cells. So not only in the patients, even in the people who are administering, right? So you know that we can have certain side effects of toxic effects of chemotherapy drugs to the healthcare workers while administering. So we have Ms. Dr. Ruchika Rani from AIMS Rishikesh to share about her expertise in about prevention of occupational exposure among healthcare workers. She's assistant professor in College of Nursing, AIMS Rishikesh. Can you share her CV? Yeah. No. Yeah, she's also a life member of Oncology Nurses Association of India. She's certified. She has certified training BLS, ACLS, and ATCN. She's certified Indian palliative care nurse care course training by IAPC. She has also certified as administering guided imagery and yoga nidra, and presented oral and paper presentation in conferences and got many awards for achieving first position in 2 national conferences, having more than 20 national and international publication in indexed and PubMed journals, editorial member of journal in IP International Journal of Medical, Pediatrics and Oncology. So we are happy to have you, Mrs. Ruchika Rani. Over to you.
Thank you, Dr. Manju, for the beautiful introduction. Good morning, everyone. I would like to congratulate the organizers of this wonderful 6th CNE webinar on oncology nursing, and it is specifically focused on the patient care. And my heartfelt thanks to Dr. M.J. Kumari, Principal, College of Nursing, for giving me this opportunity to present the topic as an oncology nurse in such a platform. And I'm delighted to speak on this beautiful morning. I would like to have my slides. Is it visible to everybody? Are the slides visible?
Yes.
Okay. So the topic as assigned to me, that was the prevention of occupational exposure among healthcare workers. It's such an important topic to talk about this, specifically in the COVID times, where we have actually seen the scenarios where our healthcare workers, they are working in such a hazardous condition, where everybody, like specifically nurses and doctors, even the housekeeping staffs also, they were exposed to such a infectious diseases, and they are sacrificing their lives just to protect our people. So when we are talking about occupational exposure, first of all, I would like to share one incident with you. It's being like 2 to 3 months before in oncology ward, I have seen that there's one nurse, maybe she will be 28 years old, nursing officer. She was preparing the chemotherapy. It was carmustine. And when she was preparing, because in our institute, but I have seen that there are lack of some facilities, like it's biosafety cabinet, which is not available in the oncology ward. However, it is present in a daycare unit also, but it is lacking in oncology wards. So she was just preparing very casually, and when she was preparing and spilling the, there was a spill, great spill, even on her arms and even on her clothes. Afterwards, she has cleaned her hands, washed her hands, but she hasn't removed her clothes. And after 1 to 2 hours, what she noticed, she was complaining that I'm feeling abdominal upset. And suddenly she was having profuse vomiting and profuse diarrhea was there. And she was feeling like so drowsy. And because it has been come in our notice that carmustine, because it has been absorbed from her clothing to the skin. And so such a, we can say that the toxic drugs, like very casually our nurses are taking these drugs while they're preparing it or while they're administering it. So such a casual approach, it should be, we have to take some actions in the, like either the nurses or the organization or like as a being the oncology nurse, it is a really important task that we have to educate the nurses that it's not such a simple antibiotic, it's such a simple medicine or analgesic that you can prepare it anywhere. So moving forward, let's move on to the topic. I think I have given some clues that how we will, at what topic we are going to talk about. Sorry. Occupational exposure, it's a really a global concern. It is not about that we are in the developing countries and it is only present in the area where we are
like slideshow.
Slides are not moving.
It's not in slideshow mode.
Oh, okay. Is it okay? I think.
Yeah, we are not able to see slideshow mode. me just close and open once again.
Is it visible now?
No, it's not visible. Do you want them to share the slides?
Yeah, it will be better. Yeah.
Yeah.
Okay. We'll share
okay.
the screen.
Yeah.
Okay, so I will just continue the talk that it's really a concern, a global concern. If you're talking, it's not a matter of that the developing countries or developed countries. We have seen such a huge data that patients are like healthcare workers are also suffering with these things also. These are exposures also, occupational exposure. If you see the facts and figures, let's have attention. In 2019, in US, I'm talking about the developed countries, there are 5,333 fatal injuries. It has been recorded. And if we'll see in the developed countries, more than 40% cases are of the needle stick injuries, even in these nursing personals. And these needle stick injuries are the main concern of having these blood-borne infections, like specifically hepatitis C, B, and HIV infection. 54% of healthcare workers in low to middle income countries, they are having latent TB infection. Further, I will have to, there are some evidence-based facts. Next slide, please. Next. The data showing that these facts, actually I have taken in the India. From the Indian studies, I have seen that there's one study, those who have taken 101 healthcare workers with TB cases and 101 without cases. It has been seen that pulmonary TB rate is 1.86 times higher than that of the general population. It's a serious concern that occupation is being a risk factor for developing the infections among healthcare workers. Similarly, in Chennai, there's a study, like 140 healthcare workers were taken. They have reported it. Half of the patients they have, half of the healthcare workers, they have reported the symptoms at least in one body part, specifically the low backache. It is the most common complaints during their occupation they have recorded. Working in the same position for the long period, working in an awkward period or cramped position, sometimes doing the repetitive task. It has been the commonest risk factors. Ergonomic factors, we can see that. And in Rajasthan, there's a study, they have reported among the dentists that 16% reported allergy symptoms to latex gloves. 81% of people, they were wearing gloves for more than 5 hours a day. So it was significant associated with the allergic symptoms. Similarly, Priya, she has conducted a retrospective review from the past 3 years, where she has reported that needle stick injury is the commonest type of the exposure, followed by the mucous membrane splashes and exposure on the intake skin. So there is a lot of study. I have taken only few studies from the recent data, but it has shown that occupational exposure, it is not a simple thing that we are just ignoring these things, but it is because healthcare worker, it is a major workforce. If we'll see worldwide, 1/3 of the population is actually working. And many people, they have been died while working in their occupation also, because they are committing, they are doing their work. So it's being the organizational responsibility, or it's been our right to have such a healthy environment to get work. Please, next slide. So now we'll talk about occupational health. So we are talking about the occupational exposure. First, we should have an idea what is actually occupational health, where it has been stated by the National Institute for Occupational Health, Safety and Health. The protection and promotion of health of workers by preventing and controlling occupational disease and accidents. How? By eliminating occupational factors and conditions hazardous to health and safety at work. Actually, occupational health is an area of work in public health where we have to promote and maintain the highest degree of physical, mental, social well-being of workers in all the occupation and their working capacity. It's not being just we are giving them work and we are giving them salary. It's actually how conducive environment we are providing to them for their safety and for their working conditions, for their health also. Next, please. Now, the occupational environment. So when we are talking about the occupational health, afterwards there's an environment. What does this environment consist of? It is not only the simple work what I'm doing. Actually, it is the sum of all the things, the external conditions, the influences which are present at the time of their work and have influence on the health of the working people. Like, it's not only like what I'm doing. It's like, man, it's my surroundings. It can be the biological agents, physical agents, chemical agents with whom I am dealing with. Similarly, the mechanical work, the machines which we are using. And similarly, if I'll talk about the man and man, it's a really important, my colleagues, like with whom I'm having such an occupational environment. Am I feeling happy there? I'm feeling like content while working with them. If I'm having support, so I feel good to work there. So this is not only occupational environment with machines, it is actually machines, agents, and also the man with whom I'm working. Next, please. Now I'll talk about the occupational hazards. Occupational hazards, if I'll talk about, according to occupational safety and health, there's a two term, health and risk. If I'm talking about the health, it is a potential source. It is an anticipated source. Actually, it has potential to have an adverse effect on a person or persons, we can say. But risk is the likelihood that the person may be harmed or suffer adverse effects if exposed to hazards. We can see that there is a one like image I have put, that hazard and risk. The person is sitting outside the sea. He can see that there is a shark, but that has potential that it may harm. But another thing, if I'm seeing the risk, the person is actually exposed by that hazard. Next, please. So what type of health hazard the occupational workers are actually facing? It may vary, but if we'll talk about in which area we are working, that broadly we have classified biological health hazards, chemical, physical, psychological, and ergonomics. So first talk about biological agents. Next slide, please. Let me elaborate about the biological hazards. Like healthcare workers, they have a high risk of contact with infectious agents due to various types of activities involved with their jobs, because we are dealing with patients, those who are having infections, and the chances of contamination from the patient, I may get infections. And these infections may get from the patient's body fluids, patient's blood products. Like if I'm getting the exposure to the microbial agents, bacteria, virus, fungus, as we in the COVID-19, we have seen that we have actually worked in that area where we have suffered with infectious diseases, and we are such in a like risky area that where the healthcare workers are more risk to get all these infections. Bloodborne pathogens, like HIV, hepatitis B, hepatitis C. These are the serious threats to the healthcare workers to get all these diseases. Similarly, airborne pathogens. I have discussed about one study that to have TB, tuberculosis among the healthcare workers, it's 1.86 times higher chances to get rather than the general population. Similarly, needle stick injuries, infectious diseases, we are getting it either by the bloodborne method or airborne, or we can like sometimes from the, if we are forgot to wash our hands and we are just touching our body areas, and we can get all these diseases. Next, please. Now we are talking about the chemical hazards. In the chemical hazards, if I'm talk about like many chemical hazards, chemicals are present in healthcare setting which we are using for the cleaning surfaces, we are using for treating the patients, or sometimes for the surgeries also. Even in the anesthesia, there are so many chemicals we are using for preservatives. Like if we're keeping the specimens for the preservation, we're putting the formalin, formaldehyde, toluene, xylene, even as a fixative, we are using them. So such a large number of chemicals we have been exposed in the healthcare workers. It has been some evidences that they have told that these cleaning agents and disinfectants, they have been associated with 67% increased risk of developing asthma, specifically bleach and glutaraldehyde. It has been seen that these two agents, if the any healthcare workers, they're continuously having exposure to these agents, it increases or it doubles the risk of developing new onset asthma among the nurses. Next, please. Psychosocial hazards. Psychosocial hazards are like it seems very occult. It seems very like subtle form of hazard. Sometimes we are just ignoring the presence of these hazards, but actually it impacts our efficiency. It impacts our effectiveness in the working capacity, like workplace violence, working conditions, stress, fatigue, intimidation, verbal abuse, working long hours, rotating shift work. As a student, I would like to say that I have seen that like the type of verbal abuse we have felt in our occupation. It's such a threatening, or it's such a demotivating for the students, for the nursing officers, because we are not following such a ethics that how we should respect the other person. Maybe that person is not knowing, I mean, that maybe that person is at a less cognitive level at present, or he has committing any mistake. But it is very important that we should follow all the communication techniques. We should respect each and the other. Like if I'm talk about the workplace violence, it has been seen that in last COVID condition, also pandemic, the people are like so aggressive when their healthcare workers are caring for these patients, and at such a like hazardous condition where they can himself they can get this threatful condition disease. But in these conditions also, the patients and sometimes their family members, they're getting so we can say violent, and they're doing assaults on them. It has been seen that 62% health workers, they have experienced workplace violence. And the most used violence in the healthcare area, it is the verbal abuse. 58%, it has been noticed that 58% people have suffered verbal abuse, followed by threats, 33%, and 12% sexual harassment cases also has been noticed in the psychosocial hazards. So it is like even not only in the developing countries, also in the developed country, it has been seen that it ranges from 60% to 82%. Next, please. Physical hazards. Physical hazards, it's like exposure to needles, noise, physical condition, extremes of temperature, and you can say electrical hazards, ionizing radiation, gases. And these are all the things that how these are affecting my efficiency. Like the continuous noise is coming, it is putting me difficult in concentrating my work. So these are the things like slippery area. I have seen in many hospitals, like the you can say health, their attendants, the family members, they are actually getting the help for their patient. They are actually getting the treatment for their patient, but because of slippery surfaces, they just get slipped. Now they're admitting along with their patient also, because they have their back problems. Now they have it. It's not their fault. It's actually organizational faults, or it's a physical hazard. Here the family members are suffering. Anytime healthcare workers also can get these such type of injuries also. Next, please. Next, moving to the ergonomics. Ergonomics, if I'm talk about, these are how the body movements physically, and like my working like positioning, we can say, repetitive works, awkward postures, vibrations, contact stress. It has been suggested in one study that occupational physical risk factors for musculoskeletal complaints, like working in the same position for a prolonged time, and working in a bent or twisting position, lifting and transferring the obese patients, handling many patients. So these are the things which can we have, like if you have seen in the earlier, I have already told that there is one study where backache was considered as the most ergonomic risk factor as the conditioner as suffered by the nursing officers. Next, please. Now we are coming to the prevention and control. We have seen the various types of hazards in the occupation, and because now we'll talk about the like oncology area. So I will try to focus on oncology cancers area, where we have to maintain the we have to prevent or maintain the minimum standards to prevent these occupational exposures. Like first thing is immunization, personal protective equipments, and ventilation. Next, if we'll talk about immunization, next please. So immunization is an important part that we have to, like, it has to be ensured that all the healthcare workers, those who are working not only in the oncology area, in the healthcare industry, if they are working, they should get immunized. In the previously in our Indian culture, it has been seen that all the nurses, all the healthcare workers, they should get immunized with Angelics or hepatitis B vaccinations. And along with that, it has been also like they should be vaccinated with like for the BCG injections, measles, varicella, and also nowadays COVID-19 vaccination, it has been recommended an important part to work as in the healthcare industry. Next, please. Next, please. Personal protective equipment, already Dr. Lakshmi very beautifully, she has explained all the like areas in the personal protective equipments, what it includes, ranging from the total gowns to everything. Next thing is ventilation. Ventilation is an important part. Actually, the importance of ventilation we have noticed while during the pandemic period. In the modern areas, we have seen that we should have a building, it should be closed spaces, there should because we are using the you can see air conditioned system, and we don't want to work, we don't want to have a natural light. Sometimes, like we can say that in some areas where it is very humid areas, or we can say it's very hot, so we have to make the comfort of the healthcare workers, we have to provide AC conditions to that engineer as engineering control. But what we have noticed, there are so many studies, they have actually told that the buildings where the natural ventilation is there is a cross ventilation, the chances of getting the infection, specifically airborne infection, are getting very like reduced in that cases. But higher ventilation rate, as what it will do, it will able to provide the dilution capability and reduce the risk of airborne infection. Because in pandemic period, we have seen that they were just telling that it should be open, because what will happen, whatever the person will sneeze, that that infection, it will get diluted if there is a natural ventilation should be there. So next, please. Now we'll talk about the definition of hazardous drugs. Hazardous drugs, we all know that, but how we will come to know that in which classification, if we are putting them in the hazardous drug, what actually the criteria that drug should follow. That should be genotoxic, that should be carcinogenicity, it should have teratogenicity, and teratogenicity, like it is able to cause fetal malformations, reproductive toxicity, organ toxicity, even at the low doses also. Structural profile of new drugs that mimic the hazardous drug. For the organ toxicity at low dose, I would like to say that because there is one case that there's a one pharmacist who was handling with the chemotherapeutic drugs since, I think he was working for 20 months only. After 12 years of his job, it has been noticed that the person is having hematuria. And he was getting his treatment for the hematuria. But when he got his diagnostic test, it was found that person was suffering with the transitional cell carcinoma. And it was papilloma, actually, papillary transitional cell carcinoma. And it has been seen that because of his continuous contact with cyclophosphamide, ifosfamide, doxorubicin, that drugs are in which the area where he was working, there was actually continuously airflow towards his mouth, towards his face. And he was unknowingly, he was doing their work, preparation of chemotherapeutic agents, and he was getting the papillary transitional cell carcinoma after like 12 years of his working condition. So it is like very low dose of he's getting, but he was getting all these things, that drugs as exposure. So there were numerous studies, they have shown that surfaces in the area where these drugs, actually hazardous drugs, are stored, mixed, administered, and wasted, even the patients are cared for or contaminated with measurable level of HD residues. There are so many studies, they have seen that they have taken some samples from the tables, from the nursing stations, from the patient bedside area, where, especially in the oncology area, it has been noticed that every area they were getting some residues of the hazardous drugs. And very like the nursing officers, they are being very casual while they're working in the oncology area. They're touching the surfaces and they're touching their face and without washing their hands. So actually these hazardous drugs are getting inside of them, right? Exposure. The following route, please backstage. So ingestion, how we will see how ingestion can be the route for these drugs, because if without washing they are eating anything in that area, so it can be the route for that. Inhalation, specifically 5-FU cyclophosphamide, it has been detected in air without ventilation. If they are working in without biosafety cabinets, they are not preparing in the closed system, it has been seen that these drugs are present in the air and it can be inhaled by the anyone working in these areas. Dermal absorption, already I have discussed with that case. Eye splashes, injection by the accident needle sticks. So there are so many cases that where the persons can get all these drugs by the exposure. It has been seen that inhalation and skin absorption, these are the most likely route of exposure. Next is hazardous drug exposure. Like at what time we are getting these hazardous drug exposure? Like any time from the manufacturing to the spillage, where the drugs are getting manufactured, how it being shipped, how it being handled, how it is coming to our area, how we are preparing, how we are dispensing, administering patient, how we're dealing with the patient care, if we are disposing it, if there is spillage, how we are handling it. It all depends the way we are doing it with precautions or not, we are actually getting exposed ourselves to these hazardous drugs. Next, please. Next, recommendation. There are various recommendations and guidelines which are discussing about the how to handle these drugs, hazardous drugs, like Occupational Safety and Health Administration, OSHA guidelines, ASHP, NIOSH guidelines, ISOPP, and Oncology Nursing Society guidelines. Next, please. So on the basis of these guidelines, if we are working, that we can prevent the exposure. But it has been seen that despite of using these guidelines, like if we are like violating any standards, we're violating any guidelines, there we are exposing ourselves to have these infections, occupational infections. Effects of hazardous drug. It can have acute effects, it can have a chronic effect. Acute effect, already I have discussed one case that just after the exposure of carmustine, she was suffering with gastric upset, dizziness, and all these things. Similarly, skin rashes, nausea, hair loss, abdominal pain, headache, allergy, skin eye injury, dizziness, and chronic cough. And chronic effects, it can be seen in malignancy. It has been already discussed that that person who got transitional papillary cell carcinoma, 7 to 50 cancer cases per year, workers, those who are exposed to cyclophosphamide. Reproductive abnormalities are noticed. Congenital malformations, it has been seen. Stillbirths are cases are there. So it is not a simple thing. It's a really a concern that we have to see that how we can prevent it. Next, please.
Ruchika, we are running short of time. Can you just wind up?
Sure.
Really?
Next, please. Now, fundamental principle of infection prevention and control. There are various fundamental principles. The first is standard precaution. All you are well versed with standard precautions like hand hygiene, how we are using the personal protective equipment, how we are keeping the patient. If patient is having infection, airborne infection or any infectious disease, how we are keeping the patient in isolation area, how the way we are managing the sharps, medication handling, specifically chemotherapeutic drugs, cleaning and disinfection of the devices and environmental surface. It has been seen that, it has been told, recommended that we should clean the surface, specifically where the chemo drugs are prepared, where it has been administered with that bleach or sodium bicarbonate solutions, 1% sodium bicarbonate solutions. We have to educate, train our nursing staff, the pharmacists, healthcare workers, even the housekeeping staff, that how not to take these drugs, simple drugs. If there is a spillage, that how we should maintain that, prevent that exposure. Next, please. These are the areas where specifically drugs are actually, we are getting exposed. Like how when we are compounding or dispensing the drugs, we are administering the drugs, or disposal of drugs and contaminated material. Dr. Lakshmi very beautifully, she has explained with that, with the importance of closed system, the use of lure lock system, how to avoid the spillage, how to prevent, there should not be air, there should not be like when you are removing the air from the needle, like all these things we have to keep in mind. Next, please. Prevention of employee exposure. Like there are various like how we can prevent hazardous drug safety and health plan. There should be some plans like that is, if you have heard about one principle, ALARA, that is as low as reasonable achievable, that there should be some guidelines how we can work. There should be exposure limit, that nurses should work for a specific period only. There should be a continuous rotation. We should have staff, proper staff should be there, so that it is not like that only one nurse is working for a long time in the preparation of this drug and she's getting exposure to all these drug compounding precautions. We should use when we are preparing, wearing PPEs, biosafety cabinets, all these things. Compounding aseptic containment isolator. These are talking about the biosafety cabinets also. There are various type 1, 2, 3, 4 work equipments, how we are handling the equipments, in the way we are practicing, actually how we are dispelling the air, like if we are generating aerosols during the administration of drug, and if you're expelling the air from the syringes. These all gets the reasons for the we are putting these chemotherapeutic agents in the air also. And the drug administration. Okay, so next, that this is a very important part of the hierarchy of control. This is a traditional concept, that exposure control, like hierarchy of control. It is, if it will be the control is more effective when it is control at the source level rather than at the workers level. You can see that the effectiveness listed from the most effective to the least effective. The most effective part is the elimination of the hazard where it is actually produced. If we are not able to eliminate, like if we have to give the chemotherapeutic agents to the patients, we sometimes, if we can substitute, we can see the replace the hazard with less hazardous condition. If it is not in our control, that we are not able to substitute it, but there should be some engineering controls. It includes the ventilation, how the provision of biosafety cabinets. There should be some things, the air entry, the air exit, where it is being present, that these redesigning and automation part of it can control the exposure to this. Similarly, if you are not able to prevent the hazard, then we have to take actions to reduce the risk. That is administrative control. Change the way the people work. There should be standard guidelines. There should be proper working conditions, how they should work. And it's a last resort, that PPE, that if we can't do anything, at least we should provide the personal protective equipment to all the workers who are working in that area. Next, please. This is very important, medical screening and surveillance. Like if we are keeping it, those who are healthcare workers working in this condition, we should have some backup. We should have some baseline data of these people. Like before joining in the oncology area, they should have some CBC testing, LFT, KFT testing, so that we can monitor their values after some time if they're getting exposed to oncology area or they were getting any disease. Next, please. Similarly, we have talked about the in the chemotherapeutic drugs. Next part is the radiations. So in the radiations, the basic principle is TDS, that is time, distance, and shielding. Less time should be spent in the radiation area. Distance should be there, and we can prevent ourselves from by shielding lead gowns, lead caps, and lead neck areas. Next, please. Sometimes those who they're working in the radiation oncology area, that should be the justifiable exposure should be there. Like it has been recommended that only 50 millisieverts exposure should be there only for the full, the people who are working. 50 millisievert in 1 year. If we can see that it was also calculated that the age of the people multiplied by 10. So this is the type of only this limit should be, the person should get this exposure. LRI is already as low as reasonable achievable. And next is all these workers, they were given TLD badge. It is like there is some Teflon discs are there, and they should, we can record that any beta and gamma doses of they have exposure. Next, please. Next, please. So coming to the conclusion part, healthcare workers continues to face several hazards in their workplace. Healthcare workers need to be protected from occupational hazard because these hazards have the potential to cause disease and injuries and can adversely impact the retention of healthcare workers. There is need to follow recommended guidelines and SOPs for the procedures. Organizational commitment toward making occupational health and safety a primary priority public health issue is necessary to ensure the safety of healthcare workers. Next, please. Any question? I'm happy to answer any question you might have. Okay, thank you for your attention.
Yeah, thank you, Ms. Ruchika. You have detailed about the occupational health hazards, not only related to oncology, nursing and oncology health hazards. I think you have covered overall. Okay, especially when we talk about oncology nursing, we know that the three main areas is one is chemotherapy administration, and the other is when we take care of the patients who are admitted with brachytherapy in radiation therapy wards, and in patients, I mean, healthcare workers who are working in external radiation units, right? So when we talk about chemotherapy, yeah, she has given the guidelines about PPE training and everything. So it's very, very important for us to make sure that the nurses there are well trained, and proper surveillance and monitoring about the nurses' health and rotation of the nurses is very, very important. So we need to ask nurses, we need to take care of our nurses to reduce this toxic effect of these drugs over them. So can you just tell me, elaborate on what is the role of laminar flow do we use in our settings?
Yeah, ma'am.
While preparing chemotherapy, can you just highlight for the participants?
Very important part. That is the engineering control part, if we'll talk about, because it is like laminar flow. We are having in some areas, I have seen that there's a provision of biological safety cabinets and laminar flow hoods are there, because it will protect the flow of air where the drugs are actually prepared. It will prevent the person from that exposure actually. Similarly, if we can see that there is a provision of that neutralizing the air within that area, and it prevents the person who is preparing it, he is not able to get all these gases or fumes where it is preparing, because there are aerosols are there in the air.
Aerosols are there.
Yeah, so it will prevent
that vertical flow in the laminar flow will prevent it from spreading towards the person.
There are HEPA filters which actually yeah.
And what about the healthcare hazards that the healthcare workers, what safety measures we need to take when we are working in brachytherapy units, especially patients with tandem applicators and other applicators with brachytherapy inserted. So because they must be producing certain amount of radiation.
Yeah, ma'am, that we have to follow these principles, that time, distance and shielding, because the nurses, she has to work in that, because she can't deny I will not work in that area. So we have to see that there should be a provision of staffing should be appropriate, so that it's not like that one person is getting exposure for a long time. So like 20 minutes of duration, it's a 20-20. So it is told that within the 20 minutes, you have to complete your work, whatever the priority work first before entering to the patient's area, you have to prioritize it at what the main things you have to complete. Similarly, that distance, 6 feet distance, that should have to maintain, and shielding when she is entering the area. And we also have to see that the person in the, if she is pregnant, that should be avoided. So these are
they also have to wear dosimeter?
Yeah, TLD. All
and
the
patients who are getting discharged on brachytherapy with some seeds inserted, what type of advice we give to them?
Yeah, like if they are at home, that specifically the exposure is happening when they are doing using the same washroom facilities, and that should be told them you have to flush it 2 to 3 times. Don't share the utensils, and don't tell the pregnant females and the persons with less immunity and children, they should not go to that area also, where the person is resting. So these are the things, because that area that person should not go to the outer areas where the public are dealing with theirs there.
Okay, thank you, Ms. Ruchika. Thank you, Ms. Gomadi, Dr. Lashmi and Ms. Ruchika for sharing your expertise on various topics. So it will help us to make your journey smooth and to improve the outcome of the patients as well as the quality of life of the nurses who are working in oncology. Once again, I would like to thank you, Dr. Kumari ma'am, Dr. Lashmi, Dr. Padmavati, everyone for inviting, and your team of organizing team. Thank
Dr. Ruchika, there is one question in this chat box. Do the nurses working or affecting in the department get any compensation? There is one question in the chat box. Dr. Ruchika?
Yes, ma'am. Actually, it should be there from the organization. The first thing is same thing that there in the, if you'll see the in hierarchy of control, the first thing it is task of the actually organization, the safe area we should provide to our employees. If we are not able to provide according to the guidelines, NIOSH guidelines, even the that labor rules also, we need to provide compensation for the loss or for the injury that person has got.
Thank you so much. Actually, I acknowledge Dr. Lakshmi because you only suggested your name. You are the right person, I hope so, for this topic. Thank you. Dr. Manju Tandaboni is very thankful from my heart because due to the technical issue, Dr. Guttami Shelby is unable to join as a chairperson for the session. You are did the timing. JIPMER, Dr. Manju. Thank you so much. Thank you.
Thank you so much, ma'am. It is my pleasure.
Thank you, Dr. Manju again. Nice to see you. Okay, thank you, Ruchika. It was very nice presentation.
Thank you, ma'am. It's my pleasure to be part among the experts.
Thank you. Thank you. Thank you, all the resource person and the chairperson. Thank you so much. We'll now move on to the next session. Let's not break for tea or anything. Like, we'll continue with the next session. I'm very happy to invite the next chairpersons. The chairpersons are, please share. The chairpersons are Dr. Asha Pishetty, Professor cum Principal, College of Nursing, AIIMS, Bhubaneswar. Madam is a life member of various member in various national editorial board, member of Manipal Journal Nursing and Health Sciences. She is an associate editor for Archives of Medicine and Health Sciences at Enopoya University, member of editorial board for MGM Journal of Nursing Sciences. Ma'am is a recipient of the University Distinguished Alumni Award conferred by Manipal University, and she is a recipient of Excellence in Professional Contribution Award conferred by K. Pandyaraja Balal Institutions. Madam has published around 40 papers in journals. Madam, we are happy to have you here. Welcome, ma'am. And the next chairperson is Dr. Vasanta Kalyani, Professor cum Principal, College of AIIMS, Dioga, Jharkhand. Madam has 22 years of teaching experience. She has approved patent for instrument. She has authored books and chapters in nursing books. And ma'am has published review articles and research articles at about 60 index journals, in 60 index journals. And she is member for various national and international workshops and conferences as an organizing committee chairman and secretary. And she's an editorial and reviewer for various national and international journals. Ma'am is an executive member of for SRHU, UKMU universities. We are happy to have you here, ma'am. Welcome you here. And the session is over to the chairperson, and you can introduce the speaker or the resource persons.
Okay. Very good morning, all of you. First and foremost, I thank the organizers for giving this opportunity to be the part of this 6th CNE webinar on oncology nursing, on current updates on oncology nursing for effective patient care. So I thank the team member of the organization for introducing me to the audience. Without wasting much time, let's move on to the next session now. Now, the next session we have a renowned resource person, Dr. A. Balasubramanian, who is going to deliberate on ways to clear future without cancer. Dr. Balasubramanian, to tell about his brief, he is a surgeon, oncology surgeon, and currently he is working as a G at JIPMER. He has completed his undergraduation from Tamil Nadu, Dr. MGR Medical University, and also his post-graduation, that is MS Surgery, General Surgery from the same university. And then on, he moved to Kilpack Medical College for continuing his MCH in surgical oncology under the Tamil Nadu Dr. MGR Medical University, Chennai. He has more than 16 years of total academic experience in surgical oncology. He has received several honors and awards, to name a few: fellowship in minimal access surgery in February 2016, endoscopy fellowship of Indian Association of Gastrointestinal Endosurgeons. And also he has done a lot of live surgical demonstrations in surgical workshops, total thyroidectomy, etc., in various conferences. He has conducted several training programs, like in surgical oncology workshop on gynecology nursing, minimal access surgery for alimentary tract cancers, international workshop on esophagus cancer, and also training program on proximate staplers. I think there are several. I think I'm not going to list out all those. To add to his credit, he is a life member of several professional associations and very renowned associations as well. He has published in peer-reviewed and indexed journals more than 13 research publications. And he was also an invited resource person and faculty for more than 35 times. So I think we have a renowned resource person to discuss on the next topic now, that is ways to create future without cancer. Over to you, sir, and I welcome you to this session.
Thank you, Madam, for a nice introduction. I thank the organizers for inviting me. I share my screen.
Sir, shall we share your content if you have?
It is not sharing option. Screen, yeah. Are you seeing my screen? Screen is visible?
Not
Yes,
visible.
sir.
Desktop screen is visible. Yeah, yes, sir.
Now it is visible.
It is
Yes, sir.
visible, sir. Visible.
Can you make it full screen, sir?
Is it okay now?
Yeah, yes, okay, sir.
Yeah, the topic allotted for me is ways to create future without cancer. A vast topic. So we will be covering only the outline or the overview of what are the ways to create future. This is the outline. It starts with introduction and burden of the problem and cancer trends to make some understanding about the problem, so that the importance of this topic. What are the challenges faced while implementing the ways to create a better future? For that, we need to understand some of the basics of cancer, what we are going to deal with. And there are some mitigation strategies which are also discussed. So it is well said that knowing your enemy from its origins is the best way to fight it and win many battles, by a bioscientist named Post. So if we can't slay the beast, learn enough about it that we render it harmless. So I am sure there was a big discussion on cancer burden yesterday, but I won't be covering it in detail. But it is essential to make a plan to create a better future. So there is continuous decline in deaths due to infectious disease in the recent few decades because of the infections being controlled by advances in antibiotics and other developments. By the way, the non-communicable diseases are rising. That too, especially cancer in low and middle income countries have worse outcomes, and we are going to face a growing cancer pandemic that we need to avoid. So cancer forms the second leading cause of death, with about 8.2 million deaths happening in the year 2012 by a report. The other important causes of non-communicable disease death include heart diseases and stroke. So globally, cancer killed about 9.6 million people in the year 2018. This is more than malaria, tuberculosis, HIV, which were causing a lot of deaths before in the early 20th century. The single biggest hurdle to boost life expectancy in the scores of nations is the management of cancer, because the challenges faced and the outcomes are poor. So there are a lot of geographical variations in cancer incidence, not only by numbers in each areas, by anatomical site is also there are a lot of variations. For example, stomach cancer is the commonest cancer in Japan, whereas prostate cancer is the commonest cancer in USA. Even within India, several cities have several zones, regions have different cancers, which is top the list in that area. For example, oral cancers are common in northeast India, eastern and northeast India, and breast cancer is the commonest cancer in Western India. Gallbladder cancer is common in certain North Indian states. This needs to be taken into consideration in planning. So this slide shows the temporal trends in cancer incidence for the 9 decades from the year 1930 onwards. This is taken from the US statistics. We can notice that the lung and bronchus, that is lung cancer, the temporal trends we can see, the curve is peaking up in the year around the 1980 and 1990 up to that. Then the curve tends to decline. This corresponds to the increase in the tobacco usage habit in the country. The other cancers are steady or minimal fluctuations in their temporal trends. So this shows the importance of prevention by preventing the tobacco usage to reduce the lung cancer incidence. This slide shows the number of new cancer cases. The top one is the prostate cancer in males and breast cancer in females. The top 3 cancers form almost 50% of all cancer cases occurring. Whereas the most common cause for death is lung cancer, common for both males and females. This shows the differences in their lethality. Lung cancer is more lethal than the other cancers. Because of that, this leads, even though the incidence is comparatively less. And more indolent cancers are included in prostate cancer, that leads to more numbers. So they may not harm the individual, even if it diagnosed, for the rest of the life of the individual. These factors need to be considered in making the planning. The lifetime risk of cancer has been charted out here. All sites put together, in males, there is a lifetime risk of 1 in 2 individuals in their lifetime, they have the risk of getting the cancer. Whereas in females, it is around 1 in 3. This is for the US, the statistics which are readily available in the ACS site. Yeah. Breast cancer risk is, lifetime risk is 1 in 8. The risk also varies by the different age groups. because those who are less than 50 years, the risk is less compared to the age group of 50 to 59 or 60 to 69. This is common because aging increases the risk of cancer. These are the trends in survival to know the problem of managing these cases. We could not achieve very good survival even after so many years. The survival, 5-year survival is around in many cancers. All sides put together, even though the trend is better, increasing trends in survival compared to the previous decades. The survival depends on not only the anatomical side, but also the different stages in which it is diagnosed. Early stages when it is diagnosed, they have better outcome compared to the late or advanced stages. This emphasizes the importance of early diagnosis to have the better survival rates and cure. What are the challenges we are facing to achieve the goal of future without cancer? The growing burden itself, the growing burden of cancer itself is a major challenge. The disease intrinsic factors, the tricky pathophysiology of cancer, and the anatomical diversity and the dynamic heterogeneity of the cancer, because the cancer cells are continuously evolving and they are transforming, and the presence of getting high quality evidence. The implementation perspective, man, money, and management, all those things have to be managed. It should be an individual based or a population based implementation for getting the outcome. We need to close the care gap so as to avoid the cancer disparities. That is a major thing. And the WHO now has got the World No Cancer Day. The UICC have now adopted this concept for this year to close the care gap in cancer management. So out of all this heterogeneity, one size of approach or one type of approach does not fit all the problems. So we are in a situation to tailor our solutions to meet the needs of the individual areas or groups or individuals. These are the common issues which need to be dealt with whenever we are going to do some interventions: amenability, availability, accessibility, acceptability, and adaptability. Any intervention, these are the common issues which need to be looked into. So identifying the gaps is the most important thing, so that to fill the gaps to improve upon the future. The current knowledge gaps, because the evidence is evolving and our understanding about the tumor biology is also improving. The knowledge gaps have to be filled up, and the effective integration is another thing in the management. And we have to the people have within among the people we need to debunk the myths so that they will come forward. It will be acceptable for them to take part in this in the past. The understanding about the cancer was very little. It was gradually improved. Now we are in the state of understanding the tumor biology and even at the molecular level. And now we know what is cancer. Cancer is uncontrolled growth of abnormal cells at the cost of normal cells. This is a simplistic definition of what it is. So it involves more complex processes and factors. This slide shows the normal cellular differentiation. The three fundamental lines of differentiation of ectoderm, endoderm, mesoderm, everybody knows. Whereas in cancer, what happens is this cellular differentiation becomes aberrant and abnormal proliferation, abnormal excessive proliferation happens. In addition to that, dynamic heterogeneity, it is dynamically evolving and those are the challenges. What it takes to form a cancer, we need to understand. So it involves the carcinogenesis involves the three steps, that is cancer initiation, promotion, and progression. Cancer initiation starts with these causative factors insulting the target cell to transform into a cancer cell, and then it progresses into full-fledged cancer, advanced cancer, and metastasis. These are some of the general properties of cancer. The cancer becomes autonomous group of autonomous cells, and they evade the apoptosis, and they evade the host immune system also. So it is important to understand the presence of the pre-invasive phase from transformation from normal to invasive cancer. This pre-invasive phase permits us, or is a Achilles heel, where the screening program of can be planned. So it is a steady progress from hyperplasia, mild dysplasia, carcinoma in situ cancer is a model, cancer progression model. This carcinoma in situ corresponds to the pre-invasive phase. So there are several types of cancer. It is not a single disease arising from all three fundamental differentiation germline tissues: carcinomas, sarcomas, lymphomas, leukemias, other liquid tumors. And there are several other, more than 200 histologic types are there. And they occur in different grades, and their biology are different. Their response to treatment are different. And they occur in any anatomical site. No, it can occur in any organ or any tissue or any cell. No cell is immune. So, but we can reduce the potential for transformation into cancer by applying some prevention measures. So all these factors put together demands us to have an individualized approach to reduce the toxicity and improve the benefit. That should be the goal of any management program. So these are the mitigation strategies, can be broadly classified into general measures and anatomical site-specific measures. For implementing the mitigation strategies, we should know what causes cancer so that we can prevent that at that level, so that we have a better effective and prevention of cancer. So these are the external factors: chemicals, radiation, viruses, and lifestyle factors. Internal factors, and these factors are classified into modifiable and non-modifiable factors. Modifiable factors, we can utilize those factors to modify the risk and reduce the incidence of cancer. The most important chemicals include, the tobacco is the most important one. Tobacco usage is rampant, and it has got a tobacco epidemic happened in the middle of early and middle 20th century in various countries. Now it is declining trend in developed countries, but it is not shown a decline in the developing countries, which need to be focused. The other chemicals include alcohol abuse and these occupational related chemicals. It is a tendency to think, many people to think like cancer is hereditary disease, but it is not correct. It is only 5 to 10% of cancers are hereditary causes. All others are caused by the other risk factors that we are discussing. Lifestyle is another important factor. Obesity epidemic is happening in developed countries. And as a consequence of this, the non-communicable diseases are increasing. Mainly, we are concerned with cancer now. So these are the oncogenic viruses. Hepatitis B and human papilloma viruses are very very much implicated in the carcinogenesis of various hepatoma and cervical cancer and other cancers, which have the potential for intervention by usage of vaccines. H. pylori has been implicated in the stomach cancer, and these are the parasites, Schistosoma and Clonorchis sinensis. These parasites are implicated in bile duct cancer. These diseases are more common and endemic areas. So what are the factors which are believed to contribute to the global cause of cancer? Smoking and alcohol use contribute to 30% of all cancer incidents. And diet and other factors, related factors, contribute up to similar proportion of cancer incidents. And the infections contribute to 18 to 20%, more so in the developing countries. So what is prevention? Prevention is not just avoiding the risk factors, increasing the protecting factors to reduce the chance of developing cancer. Prevention can be primordial or primary or secondary or tertiary prevention. Primary prevention is prevention before the disease occurs, to prevent the disease from occurring. The most important principle to be kept in mind is primum non nocere, first to do no harm, whatever we are implementing. So primary prevention can work well when the social and economical conditions and the medical systems work in concert to support it. Here I want to emphasize on one important point, the prevention paradox. That is, the prevention strategies will offer large health benefits when it is focused at the population level, when the risk factor exposure is less exposure to risk factor. Whereas when we focus at the individual level, the benefit will be less to the population, society as such. So it is cost effectiveness comes with the population based strategies. This slide, you can very well understand why the primary prevention is needed. Cancer is a disease which occurs in which causes a lot of morbidity, demands a lot of resources, and also the treatment is not very effective when found in advanced stages. That demands the need for primary prevention. So what are the general measures? Tobacco is the one important leading preventable cause of death worldwide, tobacco use. And it causes many cancers, and 2.4 million deaths are reported from cancer due to tobacco products every year. Tobacco is a risk factor for more than 20 cancer types, and in addition, there are various non-communicable diseases. Risk is also increased. So these are the cancers attributable to tobacco usage. Lung cancer, about 80% of the lung cancers are caused by the usage of tobacco. Larynx, esophagus, oral cancers, and urinary bladder cancers, more than 50% of them are caused by the tobacco. In India, also the same scenario. About 27% of cancers are attributed to tobacco. More common in India is the oral cancer compared to the other regions of the world. So comprehensive tobacco control is a need. Regulations can be applied to reduce the tobacco usage, availability, all those things. And we can ban smoking in workplaces with 100% smoke-free environment. That prevents the second-hand smoke harms also. Higher taxes can be imposed to, and sustained tobacco control program funding is needed to organize all these things. In addition to that, mass media campaigns are very important. And the best way to stop smoking is to not to start at all, because the nicotine is addictive. Once started, the tobacco cessation becomes more complex, and many of them are, even though they want to stop their habit of using tobacco, they are unable to do so. And the tobacco cessation treatments need to be widely covered for covering those. So with relevance to diet, nutrition, and cancer risk, colorectal cancer is linked to various dietary habits and dietary constituents, and certain diet are implicated in especially salted fish in nasopharyngeal cancer, and certain diet for stomach cancer in Japan. And aflatoxin is that food poison, contaminant that causes the liver cancer. And fruits, vegetables, they give the protective effect. Even though all these things are described, the evidence is currently not strong enough to be sure for many of these. So what are the cancers attributable to excess body weight? Endometrial cancer leads the list, followed by gallbladder cancer, liver cancer, and kidney cancers, and esophageal cancers. So what are the cancer site-specific mitigation strategies? We see, before that, we need to know what is screening. Screening is the identification of the people with the early stages of disease, even before the symptoms occur. These are the criteria for suitability for screening programs. Various disease-related factors, test-related factors. The test should be highly accurate and sensitive. Disease should be amenable for screening. And system-related factors like adequate infrastructure, accessibility, provision of accessibility, and supported by information system are required for success of good screening program. So the screening pathway, there is systematic invitation to define target population and application of the screening test for the asymptomatic participants, and notification of results to the participants. It doesn't stop with that. We need to, the screen positives need to be evaluated further for confirmation of diagnosis, and they need to be treated for that. So organizing a screening program is, has to be a well-coordinated effort of all these factors. We need to identify the when, where, and what, and how, in addition to the logistics. The early detection has got several advantages. The chance of complete treatment and minimal treatment with maximal benefit is there, and the risk of dying from cancer is reduced by early diagnosis, as already shown in one slide. What are the caveats of the screening? Overdiagnosis, overtreatment, or the risk involved. False negative can give false reassurance. So we are in a state to optimize the balance to get the most benefit with less harm. This can be done with the personalized screening, that is risk-based screening, that is coming in big way in many cancers now. So the risk assessment has to be done and followed by risk management based on the risk assessment. Let us see some of the anatomical sites which are common in India. Oral cancer is one of the commonest cancers in India, and the causation is by tobacco, whether it is smoked or smokeless tobacco. 90% are attributed to tobacco usage, and the risk increases with the usage of more tobacco, quantified by the pack years. There is our own Indian solution for the Indian problem by the National Cancer Grid of India is there. That is a retrostratified clinical practice guidelines for prevention of oral cancer. This is based on the availability of resource in the limited resource or enhanced resource or high resource. And the primary screening method used was oral visual inspection, which includes a careful systematic examination of the all subsites of the oral mucosa are systematically examined. And this has been shown to reduce the mortality and morbidity from oral cancer by randomized controlled trials. The other important cancer, the most common cancer among women, is breast cancer. It is important to understand the risk factors and the magnitude of risk each risk factor confers. These risk factors have to be understood by whether they are modifiable and non-modifiable or partially modifiable. Modifiable factors is the area we can intervene to reduce the risk and the self-breast examination, clinical breast examination, based on these criteria, the change in the size and shape of breast, change in position of nipple, nipple distance, nipple retraction, presence of lumps and skin changes. This is not presently approved in by any guidelines because of the risk of overdiagnosis and the false. We need to demand for more usage of our system for evaluating those overdiagnosed lesions. This is the American Cancer Society recommendation for average risk asymptomatic adults. Women 45 to 55 years should be screened annually. After that, 55 years, they can be screened every 2 years with mammography. Next common cancer in India is cervical cancer. This is the 4th leading cause of cancer death in the world also. India accounts for 25% of all global cervical cancer mortality in the year 2018. And the current age standardized rate is around 22 per 100,000 in India. The prevention mainly based on the modifiable risk factors addressal and vaccination and screening. They all should be linked with the timely treatment of precancerous lesions. Screening is in the form of visual inspection or HPV test or pap smears based on the availability and the resource stratified recommendations are followed. This is the World Cervical Cancer Elimination Initiative adopted by the WHO with the aim of eliminating the cervical cancer. What does it mean? Is reducing the incidence rate below 4 per 100,000 women. And the key pillars for achieving the target is through vaccination, screening and treatment. 90%, 70%, 90% target by 2030 to reach the target. These are the screening programs, target population and frequency, and the application of screening tests in these common cancers. Another important thing is this risk-adapted screening. That is the when the average risk people all are put together and screening is done, they are less effective, less cost effective, and they have the tendency to cause more harm. So the ACS have recommended, based on the high quality evidence, low dose CT should be performed in patients with 55 to 45 years of age who meet the criteria based on the smoking history and health status, that is 30 pack years of smoking. Surgery has got the role to play in prevention. In familial adenomatous polyposis, these are the few conditions I have mentioned. Colectomy can be helpful in prevention of the cancer. In medullary thyroid cancer, based on codon-directed thyroidectomy can prevent. Hereditary breast and ovarian cancers, mastectomy, oophorectomy, BRCA and BRCA mutation positive cases. Chemo prevention is the usage of natural or synthetic agents to reverse or prevent carcinogenic progression to invasive cancer. The most important thing is we need to balance the benefit and adverse outcomes. And we need to confirm this with the generation of evidence that is lacking in many areas. So presently, the very important thing is primary prevention, which will have a major impact on reducing the cancer incidence. Has to be, and the other important thing is the cancer awareness to the public. We have already have the very well-managed cancer registries and other information systems, which include the notification of individual cases, which can help in the planning, large-scale planning. So coordination of the regional local institutions, governments, international organizations, healthcare providers, research is the will achieve the above target of no cancer in the future. These are the future perspectives. That is the potential of biomarker, immune surveillance, and immune attack on the cancer at the earliest occurrence. Artificial intelligence and genetic interventions can help in the. They have got the potential to reduce the incidence of cancer, and the future relies on that. One other dream is the multi-cancer screening blood test. One drop of blood or one drop of urine, any cancer in the body is detected, then it is very attractive. But it is currently it is not anything available like that. It is awaiting research, and the cancer treatments have progressed very well. Likewise, because of the lot of improvements in technology and understanding and science and evidence, we are able to now achieve better outcomes in the treatment of cancer. Likewise, we will be able to achieve better in the prevention also, but prevention mainly relies on primary prevention, which needs to be given because this gives the largest benefit, the tobacco avoidance and lifestyle modifications. With these two things, we will be able to prevent about 50% of all cancers, and sun protection for melanoma. And vaccines are available for oncogenic viruses, which will give protection from cancer occurring. Screening is another important thing. And more important thing is the regulation by the government bodies. So these are the ways for cancer prevention and control and create a future without cancer. Risk reduction, early detection, and policy and programs need to be coordinated. So in conclusion, it is a complex global health challenge, and improvement in data collection and surveillance is required to give adequate information to the health policy makers in allocating limited resources, and replicable models of cancer care and prevention to be shared widely and to be implemented broadly. And current situation is a clarion call for capacity building and equity-driven research, so that we will have few cancer patients in future generations and not more. Thank you very much. It's my end of the presentation. Thank you very much, the organizers.
Thank you, Dr. Balasubramaniam. You have enlightened the audience with the burden of the problem, the cancer, its strengths, the challenges, as it is there is a great burden of cancer, and you have also emphasized that lung cancer is more lethal compared to others. You have detailed on the knowledge gaps that exist in the population and the measures that we need to take in every level to increase the knowledge from planning and management, and the various focus that you have given in mitigation strategies. And especially, as you rightly said, like the focus has to be on lifestyle modification, where people should be aware of like what to do and what not to do, what to eat and what not to, and all these things. And for which, as you have detailed, screening, the early detection, all these things which are very essential, which we will foresee a decade without cancer in future. Thank you very much. On behalf of everyone, I request the audience on this platform, if there are any questions, to kindly put forward. Are there any questions in the chat box? Organizers, I'm not able to see it.
Hello, ma'am. Am I audible, ma'am?
Yes, yes, you're audible.
Thank you, ma'am, for chairing this session. There is one question in the chat box. How artificial intelligence will play?
Yeah, how artificial intelligence will play a role in oncology?
Yeah.
Over to you, Dr. Balasubramaniam.
Yeah, a lot of developments happening in artificial intelligence, which helps in our cancer diagnosis and management. Especially most of the things now, the cancer subtypes can be found with the help of artificial intelligence called radiomix. Application of artificial intelligence principle in radio diagnosis, and which can improve upon the diagnosis and even find the histological type and subtype. Apart from that, artificial intelligence has got a main role in breast cancer screening, which can reduce the requirement for the manpower, which is in high demand to detect and diagnose the cases. And also it can help in the risk stratification of what could be the risk of malignancy, and also the risk of the malignancy, what will be the outcome. That is, it can predict the future also.
Okay, thank you for enlightening on the effect of artificial intelligence. Are there any more questions from the participants? Okay, I think there are no more questions. If no questions, we can move on to the next resource person. Thank you, Dr. A. Balasubramaniam, for your wonderful session. Thank you very much. Yeah.
Dr. Vasanta Kalyani, please unmute your speaker.
Yes.
Dr. Vasalyani, madam.
Yes, ma'am. How are you all?
Yeah, fine.
Yes, I'm pleasure to introduce Mr. R.S. Ramesh. He's more than 35 years of experience, which is very rich in the field of nursing. And then he has started his career as a public health nurse, and then he worked in that 10 years more. And then he is a life member of various professional associations. I have seen his, and then he is having various posts he has hold in his profession, various professional organization members. And then he is a very active member of many things, being a public health nurse, dengue awareness, National Deworming Day, everything he is actively participating. And then he is a trainer for essential newborn care for nurses, first aid in IRCS and GFATM program, attended numerous workshops, various workshops, and then actively participated and organized various programs related to public health. And then in this note, I am welcoming Mr. R.S. Ramesh to deliver a talk on palliative care, which is very much coming in our India. So I am welcoming him to talk on palliative care, especially in home setting. Welcome you, sir. I hand over to Mr. Ramesh.
Thank you, madam. Thank you, Vasanta Kalyani, madam, for the good words about me. And at the outset, I like to thank Madam M.J. Kumari for giving me the opportunity to talk about this topic, palliative care in home setting. So we will be going to discuss about these points. Am I audible?
Yes, sir.
Yes, sir.
Lights are okay?
Yes.
Full screen. Yeah, thank you. So we are going to learn something about definition and meaning of palliative care. Who requires palliative care? Standards of palliative care, components of palliative care, holistic care in palliative care, complementary therapies, home care providers, points to ponder. So this is what we are going to discuss in another 15 to 20 minutes. So we'll see first of all the definition of, I thought we should start with the definition of nursing. Sometime back, Virginia Henderson in 1978. I think all of us are familiar with this. I like to just highlight this particular sentence that the activities contributing to health and its recovery or peaceful death. Maybe this is what they meant during 1978 to tell about palliative care. So that particular word maybe was not famous that time, palliation. So I thought we should start with this. It's a good definition of Virginia Henderson. So one more information is scientific palliative care was started by Dame Cicely Saunders, who was a nurse, as well as a doctor and a social worker by training. She started the first modern hospice, St. Christopher's, in London in 1967. So the credit goes to a nurse who started the palliative care in 1967. So as per WHO estimates, an estimated 40 million people need palliative care, 78% of whom live in low and middle income countries. Worldwide, only 14% of the people who need palliative care currently receive it. That is a big problem between the need and the availability of care. Where is 40 million? And most of the people live in low income countries, and only 14 people have got access to it. Unfortunate. Next, we will see something about definition of palliative care. It is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of pain and suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So ultimately, the palliative care aims to improve the quality of life and relief from the sufferings. So Palliative Care Day this year is celebrated on 8th October 2022, World Hospice and Palliative Care Day. So it is the question of care versus cure. We aim to give the cure. When we cannot achieve that, when cure is no longer possible, we start giving care. Does not mean care will start little later. Care starts also with cure. But the aim of the treatment, when it is not cure, people go for palliative care. It is symptom versus disease. So we try to cure the disease in the initial care of patients as long as he is alive. So what are the diseases which requires palliative care? There is a big list of around 25 diseases. Before, palliative care was started only for cancer patients. Now it is extended to a lot of communicable diseases where people live longer, have a lot of complications. So big list is there. Maybe I'll read out one or two. Maybe breast cancer, dementia, HIV/AIDS, kidney diseases, Parkinson's, stroke, Huntington's disease. So big list of around 25 diseases where people live longer with complications. So they need to be taken care in the form of palliative care. So we'll see the expansive meaning of palliative care. What it tells, it provides relief from pain and other distressing symptoms, affirms life and regards dying as a normal process. There is a saying in Sanskrit which tells, Jatasya Maranam Dhruvam. Whoever is born in this earth should die one day. It's a philosophical statement. Intends neither to hasten nor postpone death. Integrates the psychological and spiritual aspects of patient care. Offers a support system to help patients live as actively as possible until death. Offers support system to help the family cope during the patient's illness and in their own bereavement. So palliative care also supports the family members as well as the patient. Uses a team approach to address the needs of patients and their families, including bereavement counseling if indicated. So here we have a multidisciplinary team of people working, like physiotherapists, doctors, counselors, nurses working in hospital and in periphery.
Dear participant, please mute yourself. Dear participant. Please mute yourself. Mute yourself.
The quality of life may also positively influence the course of illness. Is applicable in the course of illness, early in the course of illness, in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications. So that is the expansion of meaning of palliation care. And there are 13 guidelines given by NICE, England. Like, what are the guidelines? We have one is coordination of care with various multidisciplinary team, user involvement, face-to-face communication of the patient as well as their family about their condition, information about the disease process, what they need to do, what they need not do, what they are supposed to do, how much help we need to give them. Next is psychological support services, social support services, because we need somebody to support the patient, maybe their family members or neighbors, friends, philanthropists, NGOs, including the health professional. Spiritual support services, depending on their religion, by their religious heads. General palliative care services and specialist palliative care services, wherever it is required. Next is rehabilitation services, where the patient can live in a better condition in the community, who lives with the disease, who adds life to the disease. Next is complementary therapies, services of families and carers, including bereavement. Research in supportive palliative care. Research goes a long way in finding out how we can help patients in a better way. These are the 13 guidelines given by NICE, England. So this is the palliative care model, where we start the care palliative. At the time of diagnosis, we try to cure the disease. The portion covered by curation is more. As the disease progresses and not responding to the treatment, we start palliative care. So palliative care is started along with the diagnosis. Maybe the portion is less. As the treatment fails, the palliative care takes over much portion. Next, at the time of patient death, so we give bereavement services for the family members. So palliative care starts at the time of diagnosis. Next, we have a basic multidisciplinary team. Who all are there? What can be given? Give me 1 minute. How to remove the screen? This one I should remove. So there is something called multidisciplinary team in the center. Yeah, so basic components of home-based palliative care. We have multidisciplinary team in the center. It is accompanied by so many things. One is home care kit. We're going to discuss a little later. Available caregiver, stigma-free home situation, transport facility, 24-hour support, supportive care network. So these are the various components of home-based care. So caregivers, as I told some time back, maybe their relatives, friends, philanthropists, including the health personnel. So framework of expert nursing practice. So on one side, we have patients. On the other side, we have the nurses. What do they do? So patients meeting their needs, being in control, hospice as family. Nurses know what they are doing, working together, providing comfort. So patients and nurses work hand in hand, so they give relief for these patients. So nurse and patient perceptions of an expert nurse in palliative care. So what all things she processes, what she does. So personal characteristics of any palliative care nurse, or in general any nurse, these are the various characteristics. We know that, so I'll not go into those details. Any nurse should be a warm, compassionate, friendly, genuine, dependable, kind, dedicated. Relationship with patient, knows me as a person, builds rapport, have confidence in them, spends time with the patient, supports patient and their family, being there. And she will have very good communication skills, like willing to listen, provide information, someone to talk to. Patient feels that way. Next is knowledge about pain, symptom control, professional and personal experience. And she'll provide comfort tuned into patient's needs, able to control distressing pain and symptoms, knowing about my illness, attention to details. So these are in general, the capacities to be provided by an expert palliative care nurse. So I have shown only one slide about pain. It was in detail discussed by Dr. Suresh Sharma yesterday. So it only tells that based on the pain level, we need to give treatment. Pain important and living sign of any cancer patients or symptom. So where we need to assess based on their level of pain, we give various treatments, maybe non-opioids, weak opioids, and strong opioids. I just wanted to just mention this. Yesterday it was discussed in detail. So pain we need to take care. Next is grief, the subjective response of emotional pain to actual or anticipated loss. Total process of reacting to and responding to one's losses in one's life. So people taking care of cancer patients know very well that they are going to die one particular day. So even though they know loss is a loss of anyone, whoever it is, one, though we know patient is dying, people go through all these emotional reactions. So those support also can be given by the professional nurses. Next is palliative care is a holistic care where it will take care of physical, spiritual, psychological, and social. So physical, we know all the management of the symptoms, basically pain, any other symptoms, nutrition's needs, and any other needs as they arise. Even simple attending to the daily needs also. Spiritual, many people are attached to some sort of religious practices or religion. So opportunity to give and forgive, encouragement to end quarrels, because he has to go to another world. So we have to prepare them for that. Getting ready to depart in a calm and peaceful frame of mind, so that they should be prepared to do these things so that peacefully they'll reach the next world, whatever we believe in. Next is psychological, professional counseling to provide a feeling of safety and security. Social, acceptance as a part of the group, encouraging a self-belongingness, treated with dignity as fellow human being. So we take care of all these needs, physical, spiritual, psychological, and social. It's basically a holistic care. So we look at the patient from all these different aspects. So how does holistic care relate to quality of life? Quality of life can be understood as individual subjective satisfaction with life and is affected by all the dimensions that is shown before: physical, psychological, social, and spiritual. So complementary therapies and alternative therapies include a large range of therapies: physical, psychological, and pharmacological. Complementary therapies are designed to be used alongside conventional medical treatments. So these are the big list of complementary therapies we have. Patient can avail these services if they are available, accessible, and affordable based on where the patient lives, their socioeconomic status, all these things. Some certain things can be practiced at home also with the experts in these particular fields. So meditation without any adjuvants, they can practice at home, but for all these others, they need some expert to give them care. Then we have again continuation, music therapy, naturotherapy, reflexology. So I want to mention here, yesterday Dr. Suresh Sharma was mentioning about his own personal experience about his mother who was suffering from cancer and he lost her due to the cancer. Like reflexology, sir was talking about. Therapeutic touch, yoga therapy nowadays being done in a big level, and others. So complementary therapies goes a long way in relieving the symptoms, and patients can avail based on where they live, and a lot of other things comes in way. So what are the basic principles of complementary therapies? They relieve tension, pain and other symptoms, relax, revitalize, and nurture, improve circulation, balance energy flow, support psycho-neuroimmunological responses, release negativity, and affirm the positive. So, principles also in mind when we are taking care of patients, like respect for the individual, autonomy, give the decision-making powers to the patient, justice and utility, treat everyone equal, beneficence, do good, non-malfeasance, do not do harm. Suppose we know something is going to be a harm for the patient, we are not supposed to do that. So ethical principles we should keep in mind while giving palliative care. Actually, there is a national program for palliative care sponsored by central government. It was started in 2012, which will again insist on care being given by the peripheral health workers for those patients in palliation. Where no hospital can hold a patient for a long time. Ultimately, they should be treated in the homes when the care is taken care and cure is not the objective that particular time. So coming back to the home-based care, what are the advantages? It improves simple symptom control, health-related communication and psychological support, promotes increased number of home-based death, appropriate and early hospice referral, and avoids needless hospitalization. So most of the time, patients feel they need to be there among their kith and kin and their home when they are leaving this world. And as I told again, so hospital cannot hold all the patients in all the stages of their illness. It improves bereavement outcomes and caregiver satisfaction. Whoever is there along with the patient feels that they have done their might, their what all possible care they can take care of the patients. That satisfaction goes a long way and it reduces their guilt. What are the other advantages? Easy access to care, more effective caring by their own kith and kin, access to complementary services, expert referrals to the patient. Suppose they need any expert referral can be done. Maintains confidentiality. So some patients don't want their status to be revealed to others. Spreading awareness in the community that palliative care can be taken care in the house itself. Mobilizing local resources like health personnel, maybe volunteers, maybe the volunteers from the palliative care associations. And it provides the training opportunity for maybe the volunteers who are involved, family members, other community members. So it goes a long way in having a big pool of people trained for palliation care. So this we all know, home sweet home. Nothing can replace the home. So many things we have accumulated throughout the years. The neighbors, friends, the atmosphere we are brought up, we are living day in and day out. So home care goes a long way in general treating any patient, particularly patients who are in the palliation. So home, sweet home. So home-based care providers, who can provide the care? So one is the family itself, friends and neighbors, non-governmental organizations, volunteers from that, then the community at large. So patient family, their own immediate family, they need not be in the same house. They can be in and around the particular area. They can be in different houses. Extended family, they can give their help. So ultimately, patient gets help from all these places. It is nice if they can get all these places so that the care burden goes down from the family. Ultimately, the responsibility lies with the family members to completely take care of them. At least they get relief from these people if they can pitch in. So I feel the education should start in the hospital, the patient attenders. Like patient is admitted in the acute stages in a hospital, which is treating cancer patients. So education should start by the multipurpose healthcare team members. Then follow-up training can be given by the members, community health nurses, or whoever professionals are there in a community. There is one toll-free number where they can contact this number and get the help. And I feel these people can form a WhatsApp group and then share their expertise or the help. Then what they can do, they can have a home visit, details of patient details, the patient's ability to communicate, ambulation, bladder bowel, sleep activity, social support, mental status, then other symptoms. So we can have a small case sheet like when we visit a family. Then home care kit I was talking some time back can be with the healthcare worker, which can be shared by needy patients. We need 3 things here: equipment, supplies, and medicines. BP dressing materials, Foley catheter, paracetamol, these are the pain medications, Brufen, Tramadol. This can be kept in a place, maybe it can be given to ASHA in a village level or A&M, where needy patients can be given these things. Then volunteers, what they can do? They can give emotional support, basic nursing care, follow-up of professional home care, linking up with the professional team, social support to the affected family, by way of giving food, educational support for children, helping with transport, linking with other support groups, rehabilitation of the people. Community volunteers can take up responsibilities related to organization and administration of services such as training family members, training volunteers, administrative management. So another main problem is grief. So we need to understand every culture has got their own ways and means of managing the grief. Then rituals connected with dying, again it differs from every religion. So they need to be talked about and given support during that time, which is very important. They would have lost all the energy taking care of patients. The family members particularly, they need to be supported during that period. So culture, meaning of death. So it is individual, cultural rituals regarding death, personal differences in grief and mourning. So we should be more careful about the sensitivity, cultural, coping with grief, coping with change after loss. So respite care, sometimes it is required for the people who are immediately taking care of patients. They need to have take some deep breath, relax for some time. So someone should replace them during that period so that the family members get some vital energy they need. So I have referred this community health workers. There is one handbook and national program. Then some ideas I have. So we can pool the community resources, pool the healthcare devices or rental devices. We can rent the devices if it can be reused. Mandatory community work for students in palliative care. Community sensitization about palliative care. Opioid access, yesterday Dr. Suresh Sharma sir was talking about this. It should be available in the peripheries. Now a lot of rules and regulations are there which are controlling. Maybe they can be to any patient who need that. Promoting Ayush in palliative care. Enhancing access to complementary therapies. Medical use of marijuana for palliative pain. I feel special leave like CCL given for the employees to be given for government servants who take care of these palliative patients is only my idea. Financial incentive for non-governmental personnel. Some sort of financial incentive so that they'll be motivated to take care of these patients who are in palliation. And palliative care to be part of the pre-service education so that they get first-hand information as to what they should do when they become the regular staff. So thank you all. Particularly, I want to thank here Mr. Dinesh and Kalyani for all the help they gave me in preparing these things. Thank you one and all who are listening to me. Any questions I can take and try to answer.
Thank you, sir.
Thank you, madam.
Yes, sir. Ma'am, shall I take up?
Yeah, please.
Yes, ma'am. Sir, it's a very, that is knowledge that is regarding the palliative care, what it is needed for the, you see, for the cancer, whomever have come in the initial stage, there are very much treatment available. And then who are all not, that is many cancers, which is not able to identify in the initial period. So such a patients, when they will be reaching to the healthcare management itself, they are in the palliative phase. So in that palliative phase, hospital, if we see that India, like developing countries, it's a very much economy. So because we don't have grassroots insurance like Western countries, in that palliative to be in the home care setting. So this will improve the quality of a patient. Ultimately, if we see for the palliative patients, quality of life is very much important from their activities of daily living and other things. So for the home setting, which will be reduce their cost, and then it will give multi-sectoral approach. In that, you have explained what is palliative and then which are all the things we have to implement to take up this palliative to the community level. So I feel if your ideas, what you have given, futuristic ideas, if we started to implement from today onwards, and then in that one more thing, we have to train all the volunteers from the community. It's a very good information that, and then we have to sensitize, and then we should get the volunteers. Like for a situation of COVID, we have seen many states, they used volunteers for their home isolation. So we have achieved it. So the same thing we should do it in the palliative also. It's an example, it's an evidence, and then this evidence will give the palliative, who are all in the palliative care, they will get a very good quality of life, and then their symptoms will be also in ease. So we can give them a moral support, psychological, so everything. Sir, your discussion is very good, and then which is youngsters who are all in the group, they will be listening, and then who are all want to be a palliative healthcare professional, either a nurse or other healthcare professional, this talk will be very much informative. So I feel any questions we will take up, sir, from the chat.
Dr. Vasudha Kalyani, there is one question. What is the scope of palliative care nurse in India? I hope this question for speaker.
Yes.
Yeah. Okay. Madam Vasudha Kalyani wants to answer this, or?
You are
you. Yes. You can answer, sir. If anything points up, I will tell.
Nowadays, a lot of diseases are there, as I showed in maybe my third or fourth slide. Patients are living longer, people are living longer. As we live longer, we get diseases, chronic diseases. We have to live with that. And longevity is increasing on the one side. As we live longer, we get diseases. So the scope is very much high. Like we'll have our bread and butter taking care of these patients. Recommending things to the government. At different levels we can work. There is a lot of scope.
Thank you, sir. I thank Dr.
Shall I add one point? Shall I add one point?
Yeah, sure, please. Yes.
In India, there is a scope. It has come specialization in a particular field. It has started emerging, and then practitioner courses. So it started emerging. So in that, all the nurses, we have a very good skill for the palliative, and then scope is very wide nowadays.
Yes.
Yes.
There is one more question. What could be natives in the chat box?
Could be the role of palliative nurses in palliative acceptance among patients and relatives. What could be? I'm not getting this. What could be the role of nurses in palliative acceptance among patients and relatives? I don't know. Understanding goes, I can tell that nurses are accepted in almost all the care given. Like basically, they were conducting deliveries before. Now they take care of patients at different levels. So acceptance is there. Because we give a lot of services in the community as well as in the hospital side. So there should not be any problem in giving for the patients. And relatives and patients, they encourage us because we talk their language. We have their socio-economic background. And we are used to taking care of patients anywhere, either in the community, in the hospital. I think there is a lot of acceptance. It is there, and I don't know whether I have answered this question.
Thank you, sir. Thank you. I thank Dr. Asha Shetty ma'am and Dr. Vasudha Kalyani. Part of our conference. Thank you so much for your support.
Thank you,
Dr. Asha ma'am, sorry.
Excuse me, ma'am.
Dr. Asha ma'am on the line.
Excuse me, ma'am.
Yes, yes.
Because we have ma'am, out of network issues. Ma'am, may I ask?
Yes.
May I ask a question, ma'am?
Yeah, yes, please.
Okay. Hello, ma'am. Sir, I was the one asking what's the scope of nurse in India. Actually, I worked in Canada. They have a separate bed for palliative care in a hospital as well as a long-term care home setting. How about India? Ma'am also stated that we have a bright future in India, but do we have bed?
Yeah, yes, ma'am. Shall I talk?
Yes, yes. My question
yes,
finished.
Ma'am, in India, if we see, AIMS Delhi is collaboratively running palliative care program. And then they are all over covering pan-India for the practicing the nurses as well as doctors. And then volunteers. From Kerala also a state which is in top in palliative, and then it's in pan-India, the course is running. Even I also trained from there. So we are having a dedicated bed in all the state government hospitals and even AIMS and then JIPMER. Everywhere there is a dedicated hospitals. Nurses are working for it. So it's in institutional based Am I audible? Institutional base, it is there. The scope is very bright, and then it started here. And then many homes are there. Palliative homes are here also there. Every corner. Only the thing is, sometimes it will be costly for a people. So in that condition, we can go with the home settings.
Okay. Thank you,
Many
ma'am.
NGOs are there for home settings.
Oh, okay. Thank you, ma'am. Ma'am, you just mentioned we do have it in JIPMER. Pondicherry means, do we have a separate ward for palliative care in Pondicherry, or I didn't get that
They are
point.
dedicating the bed. They are dedicating the bed.
Whenever required?
Whenever required. Already patients will be there always. Everywhere, even AIMS also, we are dedicating the bed 6 to 10 for the palliative patients. Well, starting of the morphine and then how they are accepting, like that, there is dedicated the bed for the particular areas. And then many state government, they are having NGOs are there. They are having the hospice home for palliative centers. Many things are there, but anyway, it's coming up, developing. So it will come on pan India maybe very shortly, because act which has to pass for the government. So that is the thing they are having.
Okay, thank you very much, ma'am. Because when I was studied, when I was studying here in Madras Medical College, that time we don't have any palliative care. That was in the theory only when I studied. But
coming.
Okay, thank you very much,
now.
ma'am.
Within 7 to 10 years, it's coming up. Maybe within 2-3 years, it will boom like anything in India. There are very much scope.
Sure, ma'am. Thank you. Thank you.
Ma'am and Dr. Vasudha Kalyani, besides your busy schedule, you are accept our invitation and be a part of our conference. Thank you so much for your support. Due to the shortage of timing, we are moved for the next session. Thank you so
Really,
much.
ma'am. Thank you. Thank you for the opportunity. Thank you for the introduction also. Thank you, ma'am. Thank you.
Thank you.
Thank you.
I thank the resource person and the Professor, College of Nursing, AIMS, Raipur. And Madam is having an 18 years of teaching experience, and she is Comes Award 2018 from the Institute for the contribution towards reproductive and child health care. And she has received an International Scientist Awards on Engineering, Science and Medicine for excellence in service. Madam has more than 8 publications in national and international journals. And she's been a co-guide and guide for the undergraduate and postgraduate nursing students. Madam, we are happy to have you here. And the next chairperson is Dr. Padmavati Nagarajan, Assistant Professor, College of Nursing, JIPMER. And Madam has 28 years of professional experience, and Madam has published more than 22 scientific papers in national and international index journals. And she has presented papers in various conferences, and she's a resource person, come trainer in GFATM project under Indian Nursing Council. Madam has organized a conference and chaired the sessions at national and international conferences. And Madam is a member of various professional organizations. We are happy to have you as a chairperson, ma'am. Over to the chairpersons. Chairperson to introduce the resource person.
Good morning, one and all. I submit my humble gratitude to all my teachers. They were supporting in all my career, and the organizers of the today for this opportunity. Dr. M.J. Kumari Madam is known for her hard work and dedication. The way the 2 days conference is sequence is the evidence of the excellent teamwork of the JIPMER faculty under the able guidance of Madam. To introduce the speaker, Dr. C. Shivakumar, and having his PhD in social work, having 20 years of experience in medical and psychiatric social work in clinical rehabilitation and academic setup, including the theoretical and practical guidance to medical and psychiatric students, attended numerous workshops and CME, and he is a life member of All India Medical Science Medical Social Worker Association India, Indian Society of Professional Social Workers India. He attended and presented papers and conferences. He has 15 research paper publications in his area of specialization. He has published a book. Can you get the next slide? Next slide. So with the next slide.
That's it. That's about the.
Okay. So this is we're working with various setup and with the different age groups and the different patients with the different illnesses. And I think he has worked in different NGOs. And so we look forward you for the piece of your wisdom on the topic, the role of government, national and international NGOs in cancer care. And being a big democracy like India, definitely, not only the government organization, the private organization and the NGOs have a vital role in the cancer care management. And the forum is yours, sir, for the next 30 minutes. Please,
good morning, one and all.
You can speak.
Good morning, one and all. May I have my slides, please? Good morning. May I have my slides, please? Am I audible?
Please, organizers.
Am I audible?
Yeah, you're audible.
We'll share.
Yes. Okay, good morning. If I'm not audible, please stop me anyway. Good morning, one and all. Here I'm to present the role of NGOs in cancer management. So already Dr. Balasubramanian had covered some of my 5 slides. So I request you to go to the slide number 5, please. Can you go to the slide number 5? Yes. So given the continued growth in the number of persons with cancer globally, the primary prevention of cancer remains an urgent public health priority, which we all know. Last 2 years, we were talking about the COVID deaths and COVID related issues only. But parallelly, the cancer and the other lifestyle diseases are contributing to the same level of impact globally, and the death rates are increasing only. So only 5 to 10% of all cancer cases can be attributed to genetic defects, whereas the remaining 90 to 95% have their roots in the environment and lifestyle. So which means that cancer is preventable once we adopt to a better lifestyle. So lifestyle factors include cigarette smoking, diet, alcohol, sun exposure, environmental pollutants, infections, stress, obesity, physical inactivity. So this evidence that all of the cancer related deaths, almost 25 to 30% are due to tobacco, as many as 30 to 35% are linked to diet. About 15 to 20% are due to infections. So it's very, very, very meager and little to contribute to the genetic aspect here. So therefore, cancer prevention requires smoking cessation, increased ingestion of fruits and vegetables, moderate use of alcohol, caloric restriction, exercise, avoidance of direct exposure to sunlight, minimal meat consumption, use of whole grains, use of vaccinations, and regular medical checkups. So when it comes to non-governmental organization, so it's a voluntary group of individuals or organizations, usually not affiliated with any government, that is formed to provide services or to advocate a public policy. So for your information, NGOs have existed for centuries. Indeed, in the year 1910, some 130 international groups organized a coordinating body called the Union of International Association. So NGOs have existed many years as parallelly the cancer is existing. The term non-governmental organization was coined at about the time of founding of United Nations, UN, in 1945 to distinguish private organizations from intergovernmental organizations such as the UN itself. And many large international NGOs like Amnesty International, International Federation of Red Cross, Red Crescent Societies, Oxfam International, these are prominent international intergovernmental organizations. So most of the NGOs are small, grassroots level organization only, not necessary to be affiliated with an international body, though they may receive some international funding for local programs. Since World War II, and particularly since the 1970s, NGOs have proliferated like anything, especially at the national and local levels. At the international level, a large number of NGOs have been created to address issues such as human rights, women rights, and environmental protection. And at the same time, international NGOs have become important factors in world affairs within the UN and its specialized agencies and within other forums. So this is about the NGOs. Can we have the next slide? So NGOs perform a variety of functions. They provide information and technical expertise to government and international organizations, such as specialized agencies of the UN on various international issues, often supplying local information which are unavailable to the government. NGOs may advocate on behalf of specific policies, and they may provide humanitarian relief and development assistance, which you could have seen through Red Cross, Oxfam, and CARE like international NGOs. NGOs may also monitor human rights and implementation of environmental regulations. The main task of NGO in the health system, next slide, Ma. The main task of NGOs in the health system are providing services and health advocacy. So provision of services includes medical, social, and psychological services, as well as integration activities like care and nursing, material and financial support, educational and information services, and training. Health advocacy is a combination of individual and social actions designed to gain political commitment, policy support, social acceptance. So to that extent, NGOs can play a very active and prominent role to influence government and to see to that the schemes and the government policies are reach the common people. So when it comes to the cancer, the areas of NGOs where it can contribute is holistic. So we talk about holistic care when it comes to the cancer-like diseases. So holistic means we don't treat patients as a person with a disease. We treat him as a person. We treat him as a person himself, as a holistic person. So it combines the social, economical, mental, and spiritual aspects of living. So to address the all the holistic needs of patient with the cancer as well as with the patient's family, the NGOs has huge part in contributing to all the areas of prevention, treatment, rehabilitation, and all other holistic needs which are related to the cancer patient and to his treatment and to the community he belongs to. For the poor, the fight against the cancer is a long struggle. Those who are working in any hospital, like any government hospital, you could see the pain and suffering that these patients and their families go through, even to assess the treatment, even to come for the regular checkup. So it's not so easy for them to come. Most of the patients would be the breadwinner of the family. So already the breadwinner is with the disease, cancer, and he will not be able to go for the work. Somebody has to take care of his role. And beyond that, you need one more caregiver to accompany the patient. So that caregiver should be replacing the breadwinner as well as accompanying the patient to the family. So it's a very complicated situation. When we these are the very basic things where the NGOs can contribute better. So let's
Sure.
Sir, your voice is not audible.
Dr. Shivakumar, your voice is not audible. Kindly check your signal.
You're not audible, Dr. Shivakumar? Sir, you're not audible.
Dr. Shivakumar, you're not audible. You check your audio from your side. Hello. Yeah, now. Hello. You're not audible. Hello. Sir, you're not audible.
Hello, Dr. Shivakumar. Hello, Dr. Shivakumar, you are audible. Hello, Dr. Shivakumar. Please unmute yourself.
Yeah, I'm using my phone speaker.
Okay, now it is audible. Now it is audible.
Yes, now it's okay.
Yeah, I've closed my video. I'm just using my. Can we go back to the slide of which says prevention? Go back to the slide which says prevention earlier, before.
The previous slide.
Previous slide number 9.
Yeah.
Yeah. So when it comes to the prevention, health education plays a very, very major role in communicating the therapeutic knowledge to the patient's community, not only to the patient's community, to the general community itself. So NGOs play a greater role in this, carrying out the information of clinical knowledge into the grassroots. So it could be a simple rally, it could be a simple awareness program conducted in a school. It could be an organization-based, an industry-based, and awareness talk, or it could be a mass awareness program conducted for the group of colleges or institutions in a given district, or even at the state level and the national level. Most of the programs are concentrated on the school education programs, which we call as participatory school education programs. So it involves the students as the stakeholders, and it has been conducted through the part of their curriculum. Another way is conducting the screening camps. Through screening camps, and huge awareness is made among the community as to what are the symptoms that they can look for, and what is the necessity of undergoing periodical medical checkup through which we can identify cancer symptoms. And youth development programs and healthy child rearing practices are as part of rural health missions through which the NGOs are actively contributing, and they are sustaining the knowledge of cancers to the general community. Nutrition enhancement program is one another program where the importance of diet is very much known to the healthcare personnel. And when it comes to the prevention, we talked about obesity and we talked about lifestyle challenges which are contributing to the cancer. So when there is a nutritional enhancement program, so the more focus on the overall well-being of a child, overall well-being of the adolescents is concentrated, through which the cancer can be prevented. Can we have the next slide? So the treatment aims to cure disease, prolong life, and improve the quality of life. So this is the baseline of any cancer treatment across the country, across the globally also. Quality of life is what we are aiming to achieve to the patients. But it's not so easy. Some patients who have come from rural area where they are not able to access, where they don't have facility for a quality of cancer care, has to travel. Even in JIPMER, we see patients who travel from 300, 400 kilometers. So they have to come here, take treatment and go back. It could be a day or two, or even sometimes it goes beyond a week or 2 weeks. And imagine that when the breadwinner of the family is the cancer patient, and whether the caregiver is the breadwinner of the family. So these are the complications where they leave the young children at home and they have to come here, and they have to consider the transport cost, they have to consider the food expenses, they have to consider their stay and accommodation expenses here. So it's not an easy task. And we healthcare personnel expect the patients to adhere to the treatment 100%. But given all the challenges, the patient has to come. So here where the role of NGOs is very prominent and very important. And many NGOs contribute to this very fantastically. See to that the patients come to, while the you could have heard about Indian Cancer Society. Indian Cancer Society found that patients alarmed by the high recurring cost often stop their treatment after their first scan itself. They don't return for even for the diagnostic level. So they arrange for funds that cover the cost of initial screenings, diagnosis, in addition to the part sponsoring funds during the treatment. So this happens with many NGOs. Many NGOs are supporting this. So not only to the patients level, there are family intervention programs where the children are being taken care of the NGOs when the parents are away for the treatment. And they are community-based rehabs where the small-scale level in-depth trainings are given to support the income level of the family. So not only the social and economic, considerable level of focus has been given by the NGOs on the mental health of the patient, as well as the primary caregiver, and even to extend to the whole family is also done by the NGOs. Important area is the peer group, So these NGOs give a chance for the patients to visit, interact, and motivate themselves along with their peer cancer patients, which is a very rare scenario in government hospital. Given the infrastructure and limited resources government hospitals are having, so having a peer group meeting or a network is very, very rare, Though the regional cancer centers are meant for that, one of the key component of RCC is to have the peer group network. So for practical reasons, it's not happening. So the NGOs have taken this task. So they arrange the peer support group networking meetings and see to that the fellow patient doesn't fall, So even socially, economically, mentally, and psychologically. So all sort of support given through the peer support group, which has been taken care of by many NGOs. So overall, the treatment from diagnosis to the follow part, the holistic aspects of treatment has been taken care by the NGOs. Next slide, Mark. So rehabilitation, when it comes to the rehabilitation of cancer patients, we have medical advances in the diagnosis and management of cancer, which have markedly increased the survival rate of cancer patients. But though the treatment for some patients may now result in complete cure and no perceived physical deficits, for others, an aggressive definitive treatment may result in significant physical impairment or disability. Think about patients with bone cancers, where the legs and limbs are amputated and they have to go with the rest of their life with the amputated limb. So here comes the rehabilitation part. So we are aiming the improved quality of life of the patient through social security program. Many NGOs have taken the social security program. See to that the patients doesn't stop their life after treatment. There is a life beyond treatment. So they contribute enormously on the social security program. Lifestyle challenges are addressed. No, once the post cancer treatment, patient has to undergo a lot of challenges in their life. That they have to go back to their work. There are NGOs who have created jobs for patients after their post treatment. There are NGOs who have intervened with the employees and send back the patients to their routine work life. So there are a lot of lobbying is happening with the NGOs with the employing category of patients. So again, here the peer support rehabilitation program has been widely and popularly taken by the many NGOs, focusing comprehensively on the individual, family, and the community-based levels. Next slide, Ma. Next slide, please. Palliative care, just now Dr. Ramesh had enlightened us on the palliative care. Palliative care meets the needs of all patients requiring relief from symptoms. No? And the symptoms of patients need not be the patient's relief of pain. It could be the family also. Family's psychosocial and supportive care is very important. This is particularly true when patients are in advanced stages and have a very low chance of being cured, or when they are facing the terminal phase of disease. So because of the social, emotional, and spiritual and economic consequences of cancer and its treatment management, palliative care services addressing the needs of patients and their families from time to diagnosis can improve the quality of life and the ability to cope effectively. So palliative care can address a broad range of issues, And again, the major health infrastructure lacunae that most of the countries, especially the developing countries and underdeveloping countries, are facing the infrastructure and the manpower aspect. Where the NGOs have taken this area of palliative care in a huge level, and besides palliative care, hospice care has become very popular, and there are NGOs who are contributing enormously on this area. Next slide. Most of the NGOs fundings, though they work on the grassroots levels, their funding is a very tricky issue. Let us not get into that. But WHO, we quote WHO for anything. They are the world leader behind all these programs which are being organized or being taken up by the national and international NGOs. There are some key points where the WHO is expecting, and WHO is expected to perform globally, like to coordinate and conduct research on causes of human cancer and the mechanism of carcinogenesis. There are NGOs which I will quote later who are working on this area. And monitoring the cancer burden is not only the role of government per se, it is also the role of NGOs who are involved in the cancer care and cancer intervention. They also do monitor, and they also give enormous statistics to the respective stakeholders. And to develop standards and tools to guide the planning and implementation of interventions to prevention, early diagnosis, screening, treatment, and palliative care, rehabilitation, and whatever you say. So because the NGOs only work at the grassroots levels, and they only know the real impact of and the pulse of the remote villages globally. Globally, I can tell globally. So these NGOs carry a lot of information and data to the government, so that the government can intervene and formulate a policy, inclusive policy, which will involve in all the aspects of cancer fact pertaining to the particular state or nation or the country. So we are not worried about the breast cancer increase, and to improve breast cancer control to reduce avoidable deaths from breast cancer, focusing on health promotion. The women health is always given importance. I will not say that it is not denied, because we have to motivate the general women population to avail the services that the governments are offering to them. So NGOs again here motivating the major women population, especially the rural and tribal women, to come out and to go for the screening and to prevent cancer at the advanced stages. And it is also the role of NGOs to support governments to improve survival of childhood cancer through directly country support, regional networks, and global action as part of WHO Global Initiative for Childhood Cancer using the cure-all approach. Now, there is a WHO is using a cure-all approach, and it's focusing on the children only. More than that, to provide technical assistance for rapid, effective transfer of best practice interventions to countries. It should come from the grassroots. Again, it should come from the grassroots level only. Let me show you a few NGOs because I'm short of time. So I'm just showing a few NGOs and their role in specific. Can I have the next slide? So this is the St. Jude India Child Care Center, which is existing in India. The organization centers are a home away from home for underprivileged families during their child treatment for cancer. So its mission is to provide a clean, safe, and cost-free environment and holistic care to children affected by the illness and to support their parents as well. So this cancer care NGO provides every child suffering from the illness, irrespective of economic status, a chance of surviving the disease and leading a full, healthy life. So we have 33 centers across India, and it provides families in need with free housing, nutrition, free transportation to the hospital, and counseling services. It also offers art-based therapy, music therapy, and yoga for the patients, along with skills training for the family income generation. The next slide. So we talked about malnutrition among the cancer kids, and here is an NGO called Cuddles Foundation. So this child care cancer care NGO believes that providing nutrition to the illness affected, especially children, is one of the most effective ways of fighting cancer. With around 40% of children with cancer in India being malnourished at diagnosis, Cuddles believe in providing holistic nutrition to the underprivileged children fighting cancer. So it has a program called Food Hill program. So it is about providing proper nutrition, customized to every child. Customized to every child, because every cancer patient has a unique challenge. Like similarly, every kid with cancer is also has unique challenges. So they do a customized diet for every child, and it has a trained nutritionist work with the government and charity cancer hospital and share food and supplements with patients and families. So this foundation supplying nutritious food for children plus for about 30 plus government hospitals and charity cancer hospitals, I think in 20 cities across the country. Right. So this is Scan Kids and Kids Scan. Now, as the organization name suggests, Scan Kids, Kids Scan works with children, obviously. So they have a special program called YANA. YANA means you are not alone. YANA, you are not alone. So they provide holistic support to a child with cancer and the family from detection through diagnosis and thereafter to improve the survival chances. So this organization runs 6 home away from home, a low-cost model where the children with cancer and their families can stay while they are undergoing treatment. It also runs one of its kind special school of children with cancer in Mumbai called Kanshala. Kanshala is a palliative care, provide comprehensive palliative and supportive care for the children with cancer. Next slide. So this is Sanjeevani, an NGO which works life beyond cancer. This organization mission is to raise the bar of cancer care in India through community building exercise and covering the entire patient cycle from prevention to rehabilitation. Sanjeevani works with patients from weaker sections of the society and provides them free treatment. It also motivates and encourages patients to keep a positive outlook toward treatment of life. So they runs various programs for cancer patients. One of them is called Cancer Yogi. Cancer Yogi means it provides emotional, psychological, and logistical support to patients and their relatives, hand-holding patients through the course of their treatment. Now they have 13 centers across 9 states and 1 union territory in India. Next slide. Can we have the next slide? Can we have the next slide? So founded in 1951, Indian Cancer Society is considered to be the first cancer care NGO that started providing help for patients in India. And it has been helping with the early detection cancer through centers and mobile camps across India, especially for the underprivileged. It also supports the underprivileged with accommodation, rehabilitation, and survivor support programs. So it runs several campaigns to create awareness about the disease, risk factors, prevention, treatment options, and counsel patients and survivors. So it is also the sole body among the Indian NGOs to run a cancer registry that provides detailed data and projected reports regarding cancer care. Next slide. Next slide. Next slide is Global Vision Care. It's another NGO with the aim of helping needy cancer patients and Mission Cancer Free India. So they have a mission called Cancer Free India. So they're running for the last 10 years. And they have assisted many cancer patients in the form of medical assistance and have organized. So they specifically focus on the underprivileged, especially on the slum community existing in the major metropolitan cities. And they do individual one-to-one screening. So their mobile vans are everywhere. So you can see them in all the metropolitan cities. So they conduct very individualized screening camps in these slums. So and they pick patients and they do according to that they do referral services for the treatment. Next slide. It's called Union for International Cancer Control. It is an international body. So the organization is dedicated to taking the lead in capacity building and advocacy initiatives to unite, support, and cancer community. So they work to reduce the global cancer burden, promote greater equity, and to ensure cancer control. So the Union for International Cancer Control has a membership of 1,200 organizations in 172 countries. It's a very big, they're very big people. So they represent the world's major cancer societies, ministries of health, and patient groups, and includes influential policymakers, research, and cancers. So their ultimate aim is to reduce the global cancer burden, to promote greater equity, and to ensure that cancer control continues to be the priority in the world health and developmental agenda given in any country. So they develop specific time-bound targets and indicators to measure the national implementation of policies and approaches to prevent and control cancer. Not only that, they raise the policy according to cancer in the global health and developmental agenda. Next slide, Ma. So this is International Society for Children with Cancer, which is ISSC. So they make a difference in the lives of cancer patients, again, adolescents and their families by giving them access to the highest quality care and services possible regardless of their financial status. So they also help to reduce the mortality rate of impoverished children suffering from cancer, particularly in developing countries, through financial assistance. ISSC is found to be working in more than 100 plus countries. So next slide. So NGO, next slide, please. NGOs play a critical role in addressing the issues that are overlooked or ignored by government and industry. So basically, they help raise knowledge and awareness, So they advocate for policy change and enforcement. Also, they instill a moral urgency to the neglected issues which the governments are failed to or overlooked by the government. So in the developing world, there are currently a number of important opportunities for NGOs to support cancer control and prevention. Chief among them is advocating for policy changes. That I would prioritize the lobbying for policy changes. For example, tobacco control, early detection programs to access high quality care, including essential medicine and pain control, are areas that NGOs should prioritize. So several factors account for the global cancer burden, and most of the factors are preventable. When it comes to the preventable factors, NGOs play a greater role, and many low and middle income countries have early detection and prevention programs, but the focus by the NGO should be much more broad and vision. One more challenge that we are facing is the aging population, in particularly important because it represents both a remarkable public health triumph that we have achieved over the years, as well as it behind the increases the total cancer cases also, because the more the population and the more the cancer patients that we are having, and more number of amount of intervention that this cancer population is expected to be served out. And they say, no, between 2000 to 2050, the percentage of world's population older than 60 is expected to be double from 11% to 22%. So that means doubling the number of people living to the ages where cancer becomes very, very common. So the much more focus is on the elderly population need to be addressed by the NGOs. Simultaneously, the forces of globalization and urbanization have facilitated broad and aggressive marketing of tobacco products, resulting in the growth of tobacco use. So you just imagine there are 1.25 billion smokers there are in globally, and there are increased consumption of high calorie foods driven by the global food industries. And one more challenge in front of the NGOs who are working on the prevention of cancer. So the end result of these major increase in people with chronic exposure to cancer risk factors and an increase in the number of cancer cases. So the deadline in cancer incidence and mortality rates in developed nations evidence that cancer can be controlled. However, without aggressive intervention by the government as well as by the NGOs, there is a little likelihood that developing nations will realize similar results in near future. So I believe that NGO community can play a significant role in advocating for change and in implementing key interventions to accelerate cancer control throughout the world, and it is not going to be a easy task. So NGOs has a prominent role as the challenges are increasing, and the government need to, or government huge dependency on these NGOs for better cancer prevention, treatment, and delivery services of cancer care globally. So thank you. That ends my presentation.
Thank you. Thank you so much, Dr. Shivakumar, for your excellent deliberation on the topic. And there are two questions in the chat box. One is about whether these services are free of cost and how to access it. That is the first question.
Okay.
Can you answer?
What is the next question?
The other question is about any job opportunities for the nurses here in this NGOs they are asking. They would like to know.
So most of the NGOs do deliver their services at free of cost only. So they have their own funding, whether it could be national level, regional level, national level, or the international level. So there are very limited number of NGOs only charge patients at a very minimal level. But otherwise, most of the services provided by the NGOs is free of cost to the patients and family only. I know there are NGOs which are giving high quality care, like free of cost, which the patient wouldn't been imagine. So it's free only. Coming to the next question, as I said, the population is increasing as well as the cancer burden is increasing. Similarly, the scope for multidisciplinary team to intervene in this particular area is also enormously increasing. So NGOs have openings for nurses also.
Okay. Any other question or the audience wanted to ask the presenter?
No, we can go for the next session.
Yeah,
Thank you.
yeah.
Thank you.
We are
Just one
we
last
are running
word.
short of
Thank
time.
you. Thank you, Dr. Shivakumar.
Just one
Yes,
last
yes.
word. Thanks to Dr. Kumari for considering us to be part of this wonderful event. Thank you so much. And thank you so much, all other organizations too. Thank you so much, ma'am.
Thank you, sir. Thank you, ma'am. Madam, shall I?
Angeline, can you go for next session?
Yes, ma'am. Yes, ma'am.
Yes.
Ma'am is there.
For next session, let me introduce Dr. Miriam Magora. Madam has experience at various levels of nursing and healthcare, from clinical nursing practice to administration, education, mentorship, and leadership. She has served as a technical expert in advisory boards nationally and internationally. She has published over 90 articles in journals and abstracts, books of international and national conferences. And she also has a credit of national and international panelists on mental health, professional nursing, ethics, and COVID-19 at several fora. Her areas of interest are quality mental health and psychosocial health of children, adolescents, and special populations at risk, model development and ethics in clinical and research practice. She is the global expert panel member on nursing bioethics of the UNESCO chair in bioethics. Madam, I welcome you, madam. Over to Madam Dr. Miriam.
Thank you very much for the kind words. I want to try to share my screen. This looks funny. Are you able to see my screen?
Yes, ma'am.
I can put
Yes,
it
ma'am.
on
The slides are visible, but
on slide screen. Is that okay?
Now it's okay.
All right. Thank you. Thank you so much, the organizers, for having me, giving me this opportunity. I shall start. My presentation outline, I want to take us through the background where we shall talk about concepts and rationale. Then we look at some considerations in interventions. We look at challenges in psycho-oncology nursing practice and some strategies to mitigate the challenges. Yet the beauty of being the last speaker is that most of the respected speakers before me have talked about some of the issues that I'll talk about, so I'll not need to explain in details. So by way of background, psycho-oncology is relatively a new subspecialty of oncology.
Madam, your slides are not visible. You are audible, but your slides are not visible.
Okay, so how do I go about that? Can I stop sharing and start again?
Yeah, sure, it will work, ma'am. Just unshare it, then we can.
Is that okay now?
Visible now.
You're able to see the slides?
And now it's clear and audible. You can continue the session.
Thank you. So I was defining the concept of psycho-oncology, which is a relatively new subspecialty of oncology with multidisciplinary interest concerning the psychological, social, behavioral, and ethical aspects of cancer. May 2009 defined psycho-oncology as the study of psychological aspects of cancer along the continuum from prevention, treatment, and cure for those which can be cured, but those which cannot be cured to a peaceful death, as one of the respected speakers said when we're looking at Virginia Henderson's theory. So psycho-oncology offers holistic management to newly diagnostic patients or even to long-term survivors and to patients' significant others, or what we normally call caregivers. In this respect, it looks at the psychological support of patients, the palliative care, psychosocial aspects of palliative care, ethical and spiritual dimensions of care. If the impact of mental health, then psycho-oncology must ensure that the relevant specialties are brought in to be able to support the patient. So psycho-oncology addresses all dimensions of cancer. We talk about psychological dimensions, responses. As the patient passes through the emotional trajectories from denial when the sad news is broken to them, they go through anger, they go through depression, acceptance, and all that. But we know that they also move in between those trajectories. So it is never a linear step. So in between there, the psycho-oncologist nurse should be able to assist the patient to cope. They also look at the patient's families and healthcare providers. One respected speaker had elaborated on how cancer is not an individual condition, but it affects the whole family and relatives. So we also look at psychological factors that may influence the cancer process and physiological and sociological issues that might impact on mental health. So a significant contribution of psycho-oncology, as we may all have now seen, has been identified as improving and maintaining quality of life by use of effective communication skills, effective ways of breaking bad news, ability to handle questions, and managing patients' emotions and counseling. So then we ask ourselves, what is the rationale of psycho-oncology after we have looked at the concept? We know that a high prevalence of mental disorders in patients with cancer has been reported over the years. We know that at least 32% of patients with cancer suffer from a form of mental disorder that requires treatment, including psychological care. In research with patients with prostate cancer, it was found that 30 to 50% of them had psychosocial concerns. And the concerns were various. One was unmet sexuality or psychological disturbances, health systems and information needs, clinical distress. Most of these have been expounded on by the speakers before me. So we know that mental health patients with cancer mental health for patients with cancer is normally not assessed. So mental health and psychological needs are undiagnosed because they are not assessed, and therefore many times they remain untreated. And so the patients that have psychological problems do not get the support that they need. So psycho-oncology is considered, therefore, and remains a crucial component of quality cancer care for improved quality of life. The ultimate goal of psycho-oncology is to identify and address the psychosocial components of adaptation to illness and delivery of care that leads to improved patient health, well-being, length of survival, and quality of life that has been stressed upon by one of the respected speakers. Now, I want us to look at this MOOS and TSU model that gives us the psychosocial adaptation to illness and the factors that influence how the patient psychosocially adapt. When the patient comes in with diagnosis, the diagnosis is given to the patient, but there are many things that influence the way the patient will adapt. One is the background and personal characteristics. And background is, we can think of the age of this patient, we can think of the sex of this patient, we can think of whether they are married or not, whether they have other children, whether they have dependents, and whether they have knowledge on the condition of cancer or the type of cancer they have been diagnosed with, and all the misconceptions they have, and the previous experience with probably relatives who had died out of the same cancer. Then we have features of physical and socio-cultural environment. Here we have the religion, we have the cultural backgrounds that will influence the person's adaptation. Then we have illness-related factors. And here we also appraise the cognitive functions and some of the adaptive tasks that are expected of this patient is how to deal with their physical pain. We know that pain is one of the severe symptoms that patients come with. How do they deal with it? We know there is that total pain. There is also many other types of pain. Then dealing with the hospital environment and procedures, these are people who may have been very senior in their work or social status, and now they're coming to the hospital. When they used to give prescriptions, now they are the ones to be given prescriptions, and that affects them. It affects their self-esteem and might affect the way they react or adapt to the psychosocial, to the illness. Then adequate relationship with staff members and also the relatives that give us the social support systems. And generally, how they are able to balance their emotional state, how they think about themselves, their image. You can imagine somebody with the cancer of the postnatal space that has now disfigured the face, and how adequately their family and friends support them with the relationships. But also there is the uncertain future because of the progress, and they know that they are one day may die, and now they don't know what the future holds for them. If this was a young person of 30 years, then their life is like shattered. So sometimes the coping skills of people may vary, and we all know the emotional trajectories that people go through. They may be denying, or they may be minimizing the seriousness of the condition that is given to them. They may be seeking relevant information on what to do, what this condition is all about. They may be requesting for reassurance and emotional support, for example, that people will not now leave them, that they have cancer. They also may be wanting to learn about the related procedure, illness-related procedures like the chemotherapy, like the interventional radiology, and many other things. And they may also be having, they may have to set very concrete goals at this time, and they may be rehearsing alternative outcomes that may come, and they may find meaning or purpose on the course of events. And all this will affect the outcome, whether they adapt or whether they maladapt. When they maladapt, there must be strategies to help them to adapt. When they're adaptive, there must be strategies to keep them on that adaptive mode. So then we have some interventions that we will want to think about in psycho-oncological interventions. Again, this is taken from Rollin and colleague. So we have the emotional problems, which is the mainstay of psycho-oncology. Here we are thinking of psychiatric morbidities. We know that depression is the most common mental disorder among people with the cancer, but we also know anxiety can be there. But we also know that these people may have had previous mental disorders, and so we need to target the emotional problems. There is fear of progression and some other psychological conditions. Then we also need to assist with the practical problems. The speaker just before me and talked about rehabilitation, where we'll think of how do we integrate this patient into the society and go back to work, financial issues, childcare if they are parents, and housing and other related issues. The physical symptoms that also will impact on the mental problems or mental aspect of this person will include pain, we've talked about it, fatigue, and most importantly, sexuality, especially for men, if they lose an erection, this has been a big problem from based on my experience in practice. Some of them have insomnia, some will have many other issues like confusion. We also want to target optimizing treatment. And here it is very important that we conduct psychoeducation so that the patients can be able to comply with the treatment. They should be able to make informed treatment decisions. If they are using the analgesics, they need to take them, but they may not be dependent on analgesics until certain times when there's nothing else that can be done. And some of the patients would want to use alternative medicines. Then the issue of improvement of general health condition, here we target a healthy lifestyle. And so there is the lifestyle education, there's nutrition, exercise, and how to manage stress. The spiritual aspect, the religious concerns, meaning what this condition means to the patients, and the anticipated death and the bereavement. And so from the targets of psycho-oncologic interventions, we realize that as a psycho-oncologic nurse, we cannot work alone. We must work with the social workers. We must work with palliative or oncology nurses. We must work with psychologists, psychiatrists, occupational therapists, nutritionists, and all other members of the healthcare team. So some of the mental disorders that will need specific treatments that I want to point out include major depressive disorder. Major depressive disorders, the symptoms may vary. The patient may be eating so much because that is the only source of comfort, and so you get a patient who is adding a lot of weight. On the other hand, you can find patients who have no appetite and are not eating, so they have reduced weight. So we shall need to screen patients for major depressive disorders. Now, bipolar disorder can also occur, and patients can present either in depressive or in manic phase, and we need to screen patients for this. There are neurocognitive disorders, like major neurocognitive disorders, what used to be called dementia or delirium. There may be anxiety disorders, and I will not take you through each one of them, but it is important that as a nurse, we learn, nurse in the oncology unit or palliative care unit, we learn how to do the basic mental status examination of patients and identify any abnormals and refer appropriately. This is where we talk about liaison, mental health services, or psycho-oncologists. Treatments may vary. There could be psychopharmacology, like when a patient has depression, you may need to give them some SSRIs or TCS. When the patient has a bipolar disorder in a manic phase, you may need to give them some antipsychotics. If they have mood swings, then we need to give them some mood modulators and many other drugs. Now, psychological therapies may vary. There may be psychotherapy, can be individual, can be interpersonal, can be group, or whatever your patient, whatever works for the patient. Spiritual care will be assessed and will need to engage the relevant pastor or the spiritual leader for this patient. Some of the assessments that we do that is very critical is the screening, and we have the PHQ. This is patient health questionnaire. It is useful for assessing depression or screening a patient for depression. It's not the only tool, there are others. We have the GAD, this is the General Anxiety Disorders tool. It's also used for assessing anxiety. We have the distress thermometer. It's a simple self-report which is used to measure distress and also some basic depression. We have the delirium scales. And what is very important is the suicide scale. Many patients feel like they have come to the end of the world and they would want to commit suicide. So it is very, very important that you use, you check the patient for suicide. You may not know the details of the third person's scale that we use, for example, or the suicide. Those are acronyms that we use to assess for suicide, but it is important to talk with the patient, find out from them whether they feel life is worth living. Be very straight to the point and ask them if they have contemplated taking away their life. That is a must question, very, very important. And ask them if there are any things that they see that gives them the hope to live. The patient may say, no, I have never contemplated taking away my life. But if you ask them, what are your plans for tomorrow? Do you see any hope to live? Then they don't have. That is a patient that you need to be aware of and observe a bit more closely. Then we also have other challenges in psycho-oncology nursing practice. One is patient-related factors, and this is related to perceptions of cancer by the patient, such as fatalism and cancer mortality salience. I take a minute to explain, to define them. Fatalism is the degree to which the patient feels that there is nothing that can be done to prevent or change the course of cancer once diagnosed. So the patient comes to your clinic or to your ward and you tell them, you have been diagnosed with cancer of the cervix. And from there on, the patient feels that there is nothing that will be done to change the course of cancer of the cervix until they die. Some other patients may have what is called cancer mortality salience. And this one is the patient, immediately you tell them that they have cancer of the cervix, they look at it as a death sentence. And you can agree with me that if you have these patients with these perceptions, then they may fail to comply with the treatment or any other prevention preventive measures, because they do not see the value of what you are telling them to do into their life. If you look at the health belief model, you realize that somebody can only take action when they know, one, that they are at risk of getting the condition, and two, that they will gain by performing certain health required actions. Now, there's also patient misinformation about cancer. We know now that there's Dr. Google, there's Dr. many things, and the patients always Google and they come up with a lot of information, including the ones they get from Wikipedia and others which may not be correct, or they can have a lot of information and they do not know how to interpret because there's a lot of medical jargon and they do not know how to interpret them. So then they come with their own misinterpretation and their own treatment plan that they had seen on the Google. For example, in some areas in neuro-oncology programs or units, we get patients coming in and requesting for TC, a form of antidepressant. They are called tricyclic antidepressants. And they are asking this because they say they have seen some discussion, or they have seen on the everywhere else, that these TCAs have anti-neoplastic properties. Then we have the socio-demographic characteristics of patients. There are religious beliefs. We all have religious beliefs. Some may say that there's no need for treatment. Some may say that you should only be prayed for. You don't need to go for treatment in the hospital. So all of this will affect, will cause challenges to the oncology nurse and the team who are looking after this patient, because the patients then may not comply. Then there are the socioeconomic dynamics. This has been explained very well by the respective speaker before me. In our country here, sometimes a cycle of chemotherapy takes $400. If a patient has to get 9 cycles, we are talking about $3,600 US. And this is a patient who is not working, or even if they are working for the government, I don't know the government in India, but the government in Kenya are among the poorly paid. So then it becomes very difficult if somebody does not have an insurance plan, like many of us don't have in Kenya. Then the patient may lack awareness of information. They may not know that there are these psycho-oncology services available. And I want to stress here that many times we talk about holistic care of the patient. And as a nurse, we think that we can do the physiological care, we can do social, we can do spiritual, and we can do psychological, because we are saying we are looking after this patient in totality. But I want us to know that there are specialists in different aspects. So here, I want us to always explain to the patients where these services are available, that they need to seek services of psycho-oncologist nurse or psycho-oncologist. And this is a new field. So it is important, if we don't have them in our places, then we refer patients to counselors, or we can refer patient to the psychiatric nurse, or we can refer the patient to the psychiatrist. Then the patient may lack insight. They may not know that they have emotional issues that should be they should be supported in. Healthcare delivery systems and related factors. We all aware that in our side of the world, in our infrastructure, we have inadequate and ill-equipped facilities. I listened to the NGO presentation, and I was just amazed at how well India is doing. As in Kenya here, we may not have that kind of rich support from the non-governmental organizations. Then there's lack of distress screening as a standard practice. We need now to include this as a standard practice, so that whenever patients come to us in our clinics, in oncology clinics or palliative care clinics, we need to integrate lack of distress. We need to integrate distress screening as one of the parameters, so that we can determine early if the patient is developing any mental health problems. Then we have inadequate systems to manage stigma, what I call the double stigma, because we know that cancer, it has also some stigma attached to it. And then now they have mental illness, and mental illness is also a stigmatizing condition. So this patient is suffering from the double stigma, and the healthcare system may not have structures in place to deal with this. Then personnel deployment policies. Many times we talk about staff shortages, and many times we also deploy nurses inappropriately. So we find nurses with palliative care or oncology, palliative training or oncology training are taken elsewhere, and we bring nurses who don't have any palliative or oncology training background. I believe that in every palliative care unit or oncology care unit, we need to have nurses who have mental health specialization, or mental health nurses or oncology nurses, palliative care nurses who have specialization in psycho-oncology nursing. Then the referral system, sometimes there's a lot of bureaucracy, so referring patients become a nightmare. So we have nurse-related factors. We have nurses' ability to assess and manage common psychological problems. This is the reason why I'm saying that it would be good to have a mental health nurse specialist or a mental health professional to work with the nurses in palliative care or oncology care units. Then the confidence and knowledge. And I ask us, to what extent are we confident and knowledgeable to be able to deal with or to handle patients who are going through the symptoms that I have put on the right-hand side? The concept of despair at the end of life. We know that sometimes patients have this. They become hopeless, they lose dignity. Some of this treatment that we that we give our patients or that we administer to our patients really make patients lose their dignity, because you can imagine a patient who is drowsy, a patient who cannot do anything for themselves, a patient who is being taken through some treatment, and then it involves the private areas. Sometimes also the patient will be demoralized. They may be depressed, anxious, or they can have panic attacks. They may lose meaning and spiritual well-being. They may desire to hasten death, and so they're asking for euthanasia. To what extent are we, all of us, confident and knowledgeable to deal with this? So then that becomes a challenge. Then their attitudes and personal interests, especially when we are taken to areas we have no interest, and probably we had, I had done my specialization in midwifery or in theater nursing, perioperative nursing, and then I'm taken to an oncology ward. So that means I'm not interested. Then we also have our own unfinished businesses as nurses, and sometimes we don't go for psychotherapy. We may be going through, we may have lost our own relatives or our own loved ones through cancer. And so we are having what is called transference. Whenever we see the patient, we are just transferring the feelings that we had to this patient, but we have not gone through treatment. So when we see the patient, we may not be able to offer objective care because we are thinking, and this may happen unconsciously, we are thinking of our own emotional trajectories we went through as we missed or as we lost our own relatives. So it is very, very important that as a nurse counselor, as a nurse psycho-oncologist, as a nurse who is working with the patients who have self-limiting conditions such as cancer, the nurses need to go through debriefing all the time, and the nurses need to go through what is called psychotherapy, so that if there are any issues that they have, it is dealt with. So then we have the COVID-19 related challenges that we are all aware of, that when COVID-19 started, we shelved all other treatments of non-communicable diseases and even other communicable diseases, and we only concentrated in COVID-19. And so this interrupted care. It delayed treatment modalities, it delayed and altered treatment, it reduced services. And then we also had problems with support resources and shortages, both to the patients and also to the nursing staff, because many of the nurses also passed on. Many of them were going through a lot of mental health issues. And some of the nurses also contracted COVID-19 and had to go on sick leave. So then this caused a lot of shortages in staffing. And also the nurses had psychosocial impact that they had to deal with. Then there's what I call triple stigma now. This patient has cancer, which is stigmatizing. They have mental health issues, which is stigmatizing. And now they have COVID-19, which is even more stigmatizing. So the patient is going through triple stigma. And we ask ourselves, to what extent are we confident to look after these patients during this time? So then there was the issue of remote contact, and we can call the patients, but the problem with that is that we are not able to see the facial expressions, we are not able to see other non-verbal communication that can help us to interpret what the patient is saying. And so some of the strategies to mitigate the challenges, I think some respected speakers before me had talked about this, so I may not dwell into the details. We needed to transform education system so that we give the basic, just basic guidelines on psycho-oncology to the students at whatever level they are in, and just and sensitize them on the importance of psycho-oncology. They may not know the details, but let them know that there are some specialization called psycho-oncology, and these are their roles, so that when they have the patients, they know that they need to refer. We also need to conduct researches for effective strategies, so that we are talking about evidence-informed practice. We need to reform our healthcare delivery system, so we may need to have a one-stop facility where when the patient comes in with cancer, psychological aspects are taken care of. If they're patients in the reproductive health age, if they had family planning, all those things are taken on at that particular time. Then public education, it's important. We sensitize members of the public so that we destigmatize and we demystify cancer, mental disorders, and so that the patients can feel that they are accepted, they can come up, they can talk about their conditions, and they can feel supported. Now, there's adoption of new technology, which is very important. I heard us ask about some new technology that can be used. So there is telepsychology for specialized psychological treatments in oncological patients, where we talk with the patients, and at least it's a stopgap measure if we are not able to see the patient. Then there are the telephone attendants. There's the emotional support that we can give during telephones. If the patients are in a position where they have the Zoom or they have the Google Meet, then we can also schedule those and talk with them. We have the media. Then we have the email accounts for specific consultations where we send emails and the patients can respond. The question would be, to what extent are we advanced in technology? And those are my references. And I want to acknowledge the organizers of the CNE webinar for the opportunity, and my participants for your kind listening. Many thanks to all of you. Thank you.
Thank you, Dr. Miriam. It was very comprehensive and very resourceful. And it's a new, like you told about the specialization of psycho-oncology, that also is a very good idea. We can have it. And you stressed upon the emotional distress associated with the cancer. That is what very much important. In current scenario, it is under-recognized, I feel. Because this emotional, more than a psychiatric problem, it starts with emotional distress that should be assessed and should be given importance. You stressed it very nicely. And you also spoke about the medications and other things and the strategies to mitigate the impact of the cancer. Very informative, madam, your speech. And I think the participants would have helped with this very good presentation. Thank you, madam. Thank you very much.
Thank you, Dr. Miriam, for your wonderful presentation and your participation in our conference. Thank you so much.
Thank you. I'm honored and privileged to be with you.
Thank you, ma'am, for giving the valuable insights on the topic. So now we have come to the end of the scientific session. For post-test, the link has been sent in the chat box. All the delegates can fill the post-test, but please remember that you have to enter your email ID. So now we'll start with our scientific paper presentation. All the presenters, make sure that your presentation is only for 8 minutes, 2 minutes for discussion, and you have to specify only the title, objectives, methodology, and the results. First, I invite Mrs. Bhagilishmi P, Tutor, College of Nursing, JIPMER, and Mrs. P. Aruna, Tutor, College of Nursing, JIPMER, for moderating the session.
Good afternoon, Mrs. Jasmine Kaur, Madam, Associate Professor, Punjab. Present a study on descriptive study to assess the knowledge regarding warning signs and risk factors of cancer among GNM third year students at Saraswati Nursing Institute, Punjab. Please, Madam, can you proceed, Madam?
Yes, ma'am.
Now, share your slides.
Hello.
Madam?
Yes, ma'am, I will do.
Please, slides, Madam. Otherwise, shall we share the slides?
Yes, ma'am, please. Hello. Is it visible, ma'am?
Yeah, sure.
Hello.
Yes. Visible, Madam, visible.
Okay. Good afternoon, everyone. My paper presentation is on the study of GNM students. Lot of technical issues. Ma'am, hear my voice? Hello.
Hello, yes, ma'am. Start, Madam, start.
Okay. My study is on the descriptive study to assess the knowledge regarding the warning sign and the factors affecting of the study to assess the knowledge regarding the warning sign and risk factors of cancer among GNM third year students at Saraswati Nursing Institute, Kanpura, Kurali, Punjab. In my study, cancer is one of the leading cause of death today and is advancing in rank. Year by year, the incidence of cancer is about the 70 into the environmental as used by the cancer researcher means any cause that is not inherited.
Madam, 1 second, Madam. You read alone statement, objectives, methodology, then findings, Madam.
Okay, ma'am. Okay. My objectives of the study to assess the knowledge regarding warning sign of cancer and to determine the knowledge regarding the risk factors of the cancer. And methods, in my study use the descriptive research design used in the study. Assess the knowledge regarding the warning sign and risk factors of the cancer among the GNM third year students. The study was conducted in Saraswati Nursing Institute, Kanpura, Kurali, in Punjab. The total 50 study subjects were selected by the purposive sampling technique. In order to carry out the study, self-structured questionnaire tool available for assessing the knowledge of nursing students on warning sign and risk factors of cancer. The investigator constructed a knowledge questionnaire of 25 items. In my study, results findings are revealed that knowledge regarding warning sign and risk factors of the cancer of GNM students, the mean value of student mean knowledge score on the 14.32 plus minus 6.62. And in my study, implications is the majority of students, 60% were having a good knowledge and 36% of students are and 36% students are average knowledge and 2% are excellent knowledge regarding the risk factors and warning sign of the cancer. In my study, implications about the nursing education, new models and teaching methods can be used to increase the knowledge of warning sign and risk factors of the cancer. Nursing research, in my implication is nursing research, a piece of literature generated by the present study will be referred by the future researchers, and recommendations are a similar study can be conducted with large sample by enrolling the different college nursing students. In the last conclusion of the studies, the study shows that 60% GNM students were having a good knowledge regarding the warning sign of the cancer. Is it okay, ma'am? Thank you. Hello?
Yeah, thank you, madam, for your presentation. Again, this is one suggestion. This instead of this study, conducting nursing students are better.
Okay, ma'am.
Even other generalized population.
Okay,
and in
ma'am.
recommendation also you mentioned this again, nursing students, a large group of nursing students.
Yes, ma'am.
Okay, madam. Thank you, madam, for your presentation.
Thank you. Thank you.
Still right. Next, I will invite this Dr. Kasturi Kanayaram from, Assistant Professor, Department of Biochemistry from Dagu Medical College, Chennai. Madam Kasturi.
Yes, madam. Thank you so much, madam.
Yeah, madam, this is to present her study on anti-neoplastic and anti-peroxidative property of nobiletin study in benzone pyrin induced experimental lung cancer in Swiss albino mice. Is an animal study. Okay, madam, can you start, madam? You can start, yes, madam, now.
Yes, madam. Yes, madam. Yeah. Yes. Can you able to see my PPT, madam?
Yes, ma'am. Yes. It's not clear, madam.
It's not clear, madam.
No, slide not visible, ma'am.
Slide not visible. Can you like display from your side, madam?
Our side we tried, madam. Even as a previous presenter also, we'll try.
I'm giving sharing, but screen is not sharing, ma'am. Now, can you able to see, madam? Now, can you able to see?
Yes, yes, ma'am.
Yes, it is visible.
No, not visible, ma'am. Now.
It's not visible. Oh, it's visible for me. Please, from your side, you please, ma'am.
We'll make it come.
Yes, madam.
You can.
Yes, yes, she told us.
Yes. Good afternoon to one and all present here. I'm very happy to present my study about anti-neoplastic and anti-peroxidative properties of nobiletin, which has been conducted in benzopyrin. It is an animal study. So next. Next, sir. So these are all the just introduction about what is cancer, what are all the types of cancer, and what are all the classifications, how it has been classified. These are all very basic thing. I just wanted to tell you one thing in the thing is that in classification, we have small cell and non-small cell. So the predominant lung cancer which is affected is non-small cell. And yes. Yes, madam. Madam, can you hear me?
Yes.
Yes, ma'am. Yes, ma'am.
Yes. Some okay. Shall I continue, madam? Shall I continue? Shall I continue?
Continue, ma'am. The same material methods, methodology you can read, ma'am. This.
Okay. Actually, before this, I just wanted to tell you about my benzopyrene. So, can you please go back to the previous slide? I'll just tell you one word about this benzopyrene. Yeah.
You can start, ma'am.
Okay, so materials and methods, the study was conducted with the Swiss albino mice, which has been 50 days old, and it is the weighing of 20 to 25 gram. And we had a very good diet for the mice, and our research work was completely based on female Swiss albino mice, which was sanctioned by the IAEC number is 18/1/2014. Next, ma'am. Next slide. Next slide. Madam, next slide. This is about the experimental design. Back, madam, experimental design. So this experimental design, our experiment was divided into 4 groups. So group 1 was treated as a control, which is a corn oil acting as a vehicle. And group 2, it is an animal which is treated with benzopyrene. So 50 mg per body kg weight was dissolved in corn oil. So this we have given for weekly twice for 4 weeks. And third one is lung cancer bearing animals, so which was already treated with benzopyrene. Again, we treated with nobiletin. Nobiletin, it is a drug. It is a polyhexamethoxylated. It is a flavonoid. It present in the peel of orange, and it present in the pulp of the citrus fruits. All the citrus fruits it's contained, and the major level is present in the orange. And 4 will be our control animals, which is a nobiletin. Next. Next. Madam, next. Yes. So after the experiment, this is the primary blast. So we have used so many primers. So in which the primer blast has been synthesized, and I have choose the base pairs of sequencing, and the primer was accordingly sequenced, and all the primer was forwarded and reversed. So both the primers with the proper temperature I have chosen, and with the use of some product size, based on the size only, I have chosen the sequences. So I have used around some 10 genes. 10 genes I have chosen, and all the 10 genome level were tested in genomic conditions. And I have given you a few examples. I have given you here in the picture, which is P53. It is an anti-apoptotic protein, and BAX is an anti-proliferative protein. PCNA, again, it is a inflammation protein. Caspases, they are the one which will induces the metabolism of metalloproteins, and all the protein will definitely enter into it, and the molecular level it will go and affect. And MMP9, which is a extracellular matrix, the matrix metalloprotein which is present in the extracellular, that protein will come and inhibit the level of cancer, and those level will be calculated with the help of these sequences. And GAPDH is again a dehydrogenase genes, which is responsible, and it is acting as a housekeeping gene. So when we do some research with the proteins and proteomics, the housekeeping gene has to be a permanent one, and which it is 116 base pairs. So 116 base pairs in the temperature of 59 degrees Celsius, which has been compared with the other P53 like BAX, BCL2, all the proliferatives and all the inflammatory gene markers has been tested. So when we do the experiment, we could see in nobiletin treated genes, the genomic level, the gene will go and inhibit the proteins, and all the protein level will be bring back to normal after the treatment of nobiletin. But in case of cancer, what happens? All the oncogenes, the invasion will be very high. So such a way, what happened? The invasion will become very darker. So what happened? All the metabolism level will be down. So the metabolism will down, and the caspases protein will be exhibited. So next. Madam, next, madam. Hello. Hello, am I hearing? Hello, madam, can you hear me?
Yes, ma'am. Yes, ma'am.
Next one.
Next. Yes, this figure shows the comparison of body weight and the lung weight. So during the cancer state, the body weight has depleted, as well as the lung weight also depleted. The organ weight and the body weight was depleted. After the treatment, you can see the differences between group 2 and group.
This is a time constraint. No, please, can you please tell the findings alone, ma'am?
Findings.
Yeah,
Go
sorry.
next. These are all my result only, ma'am. Next. Shall I tell oral, ma'am? I don't want to see the PPT also. I can tell orally.
Tables, picture no need, ma'am. So orally present your findings, ma'am.
Okay. It is okay, madam. I can present. So, so what is my findings and conclusion is, in cancer groups, the depletion of apoptotic cell will be bring back to normal in case of nobiletin treated animal. So what happened? The nobiletin, it will go and activate the matrix's protein. So this nobiletin will go and it will go and trigger the oncogenes, where the oncogene will be different. So there what happens, the TNF alpha and NF kappa B, both the genes will be activated. So once it is getting activated, what will happen? The nobiletin will come and inhibit, and it will start growing. So what happened? The invasion, the tumor suppressor gene will be very high, and when compared to the normal group 2 animal, the level of cancer cells will become very low. So which means we can control the proliferation. So that is why it is called anti-neoplastic. It has the properties of anti-neoplastic. And one more thing, it is also has the antioxidant property, anti-inflammatory property. So this antioxidant property, with the help of this SOD, superoxide dismutase, vitamin E properties, and the catalyst properties, all the catalases will go and help into it. So when we compare with the vitamin C, which is a normal antioxidant, the level was very higher, and when it is compared with the group 3 animal, it was very good. So my finding is, like, consume more citrus fruits, consume more orange, because the orange peels and orange pulps will have n number of polymethoxylated flavonoids, which is nothing but a nobiletin. So we can have it to avoid all these happening, because free radical scavenging and cell death will be very common in nowadays. So the antioxidant property of these will help to prevent ourselves from all these damages. So our day-to-day life damages, cell damages, can be prevented by having all these things. So this is my findings, madam. Yes. Hello.
Continue, ma'am. Proceed over, ma'am. Hello.
Yes, over, madam.
Okay, madam. Thank you, madam. This actually for animal study for the newer experience for nursing profession, ma'am. Just we want to know this, how you taken the blood sample, from where, which part of the mice you taken the blood sample. Can you please tell me, ma'am?
Yeah, sure, madam. Actually, it is
before taking this blood sample, any anesthesia might.
Yes, madam. Yes. We need to give, madam. We need to give only 1%, madam. Only 0.1% of this formalin can be given as an anesthesia, and we can take it from the artery.
How much blood sample, ma'am? Mostly for animal study means?
Actually, madam, we can take up to 2 ml, ma'am. It is based on the health of animal. One animal we can take 2 ml. One animal we can take 1.5 animal. It is based on the animal, madam.
Which part?
How healthy it is.
Which part of the mice, ma'am? Eye or tail? Which area you'll take?
We used to take from tail, ma'am. We used to take from tail. But during our dissection, after we complete the study, we'll do some dissection to take the organ. So what happened, by the time we'll take it from the heart of the mice.
Okay. Thank you, ma'am.
Yeah, we can take it.
Thank you for your presentation, ma'am. Thank you very much, ma'am.
Yes, madam. Okay. Thank you, madam. Thank you so much.
Okay.
Next.
Good afternoon to everyone. Now I invite Mrs. Jagadishwari, clinical instructor from Savita College of Nursing, Chennai, to present a topic on level of stress and adapting approaches among caretakers of cancer patients receiving palliative care. Start the session, ma'am.
Yes, ma'am. Afternoon to one and all gathered here. I bring greetings from Savita College of Nursing to the whole crew of College of Nursing JIPMER for conducting such a wonderful conference to all the nursing profession. Yeah, my scientific presentation is on level of stress and adapting approaches among caretakers of cancer patients receiving palliative care. Introduction, the cancer, as we all know, it's a primary cause of disease and the death which affects almost like 8.5 million people, and new cases just arises every decade by decade. Yes, ma'am.
Please, we may proceed with objectives and methodology and findings, ma'am.
Okay, then. Thank you, ma'am. Yeah, my objectives of my study is to evaluate the level of stress and adopting approaches among caretakers of cancer patients receiving palliative care, to assess adopting approaches among caretakers of cancer patients receiving palliative care, and to impel the correlation between the stress and adopting approaches among caretakers of cancer patients receiving palliative care. The methodology here, the approach which we have used is a qualitative research approach with descriptive survey design. The research is conducted at Savita Medical College and Hospital. The samples which we have taken is a family caretakers of cancer patients who are receiving palliative care, who has been providing palliative care at home for a period of at least 3 months. And the sampling technique is purposive sampling technique with a sample size of 60. Inclusion criteria, which is already mentioned, people who are giving palliative care for at least 3 months has been included, and people who are just recruited caregivers, like paid caregivers and distance blood relatives, are excluded from the study. The tools which is used here is demographic data, which includes age, sex, religion, marital status, type of family, educational qualification, employment status, the family income, duration of providing family palliative care, and the support of palliative care. And the main tool which we have used here is a self-administered stress rating scale, which has 28 items with 5-point Likert scale, with 5 domains, which is included here is a physical, psychological, social, economical, and the spiritual. The minimum score is 0 and the maximum score is 112. And the other scale which is used for assessing the coping strategy is the standardized tool, that is a standardized tool, which is Scope Inventory, which was found and developed by Kava. And this is also a 4-point Likert scale, which has 28 items with a minimum score of 28 and a maximum score of 112. The data collection procedure, it was initially started with obtaining the administrative permission and from the institutional review board. Followed by that, informed consent was obtained from all the participants, and information sheet was given to them to read up, and the purpose was explained to them. And also the data was collected from all the participants, like 60 participants. Along with that, the stress level was assessed by the self-administered stress rating scale, and the coping strategies was assessed by the Cope Inventory, which was already told. The data analysis, which was summarized and processed by using the descriptive and non-parametric statistics. The sample characteristics was described using the frequency and percentage, and the Persian correlation was used to impel the correlation between the stress and adopting approaches. Coming on to the results, here the table 1, which just predicts you, which depicts you the level of stress among the caregivers. Here, 85% of the caregivers have caretakers have moderate stress of 85%, and 15% have severe stress, and nobody has reported with mild stress. Coming on to the domains, as I just told you, like we have just categorized the stress with 5 domains: that physical, psychological, social, spiritual, and economic. And coming on to the physical, the possible score, which has to be 0 to 32, but the acquired score is 7 to 25 with the mean and standard deviation of 15.43 plus or minus 4.34. And psychological, the acquired score is 8 to 34 with the mean and standard deviation of 21 plus or minus 4.52. And the social, the acquired score is 5 to 11 with a mean and standard deviation of 6.20 to 3 plus or minus 3.21. And spiritual one is 8 to 15 with a mean and standard deviation of 11.70 to plus or minus 1.70. And economical, the last stress domain, the equate score is 5 to 13 and the mean and standard deviation is 8.95 plus or minus 2.81. Coming on to the adopting approaches, what the caretakers have adopted here is, we have just divided into the positive adopting approach and negative adopting approaches. In positive, there are 6 categories we have divided, out of which the highest adopting approach the people have followed is a religion. As Indians, we always, when there is a difficulty, we just surrender to the God. So this table shows clearly what the people are undergoing. The negative adopting approaches, the majority of adopting approaches people undergo is a negative adopting approach is a self-distraction. Yes, when there is a problem, we just distract ourselves by listening to some music or distract ourselves by reading books like that. So this also clearly tells you that what are the negative negative adopting approaches, we just do it. Coming on to the correlation here between the stress and adopting approaches, the caregivers, there is a significant negative correlation, that is R is equal to 0.8 and P is equal to 0.01. So this study clearly tells us when the stress increases, the coping strategies or the coping mechanism just declines. The discussion, this examination is clearly discussed by another author, which just they have done related to a survey as a caregivers and burden and coping among the caregivers of terminally ill cancer patients at NIU, Kanyakumari. Here, the examination discoveries that 38% of the people, caregivers had moderate burden and 32 had a severe burden. And coming on to the coping strategies, which they have assessed, 22% have minimal coping and 78% had a moderate coping. And here also there was a negative correlation between the caregivers' burden and coping. And another study which just supports here is they have just conducted a study to assess the stress, coping, and lived experience, which is a mixed study. Here also it depicts that 82% of participants had moderate stress and 18% had severe stress. And adopting approaches, there is both negative and the positive coping. There was a significant negative correlation between them. Coming on to the conclusion, during this palliative care, we just only concentrate on the patients, but actually we need to concentrate even to the caregivers equally, because they just undergo some financial problems and other problems also, which has to be taken care along with the patients in order to improve their coping mechanism. Thank you.
Thank you, ma'am. Any queries from participants can be clarified. Thank you, ma'am. It was a good presentation.
Thank you. Thank you, ma'am.
It was a very good presentation.
Lakshmi ma'am and Aruna ma'am for moderating the session. Now I invite Mr. B. Janardhan, Tutor College of Nursing, JIPMER, and Mrs. K. Muthulakshmi, Tutor College of Nursing, JIPMER, for moderating the session.
Good afternoon, everybody. Let me just call the first presenter of this group of presentations, Ms. Bhavna Rani, tutor from SGT University, and she will be presenting on perception of social support and prevalence of depression among patients with head and neck squamous cell carcinoma, treated at a tertiary care center in North India.
Good afternoon, all. I hope my slides are visible and I'm audible.
Yes. Yeah, yes.
Okay, thank you. So starting with the presentation, so the topic of the presentation is the perception of the social support and prevalence of the depression among patients with the head and neck squamous cell carcinoma treated at the tertiary cancer center in the North India. So coming to the introduction, head and neck cancer, they account for the significant global burden with an annual incidence of more than 750,000 cases and a mortality of around 350,000 per year. Owing to the
Ms. Bhavana,
yes, sir?
can you just directly go ahead with your objectives and methodology?
Yeah, sure, sir. Coming to the primary objectives, first primary objective was to estimate the perception of the social support among the patients with the head and neck squamous cell carcinoma. Second objective was to estimate the prevalence of the depression among patients with the head and neck squamous cell carcinoma. Coming to the secondary objectives, first secondary objective was to determine the correlation between the perception of the social support and prevalence of the depression among patients with the head and neck cancer. And second was to determine the association of the social support with the clinico-demographic variable. And third was to determine the association of the prevalence of the depression with the clinico-demographic variable. Coming to the methodology, the research approach used was the quantitative, and research design was the descriptive cross-sectional study. Site was the AIIMS New Delhi, and setting was the Dr. Bhimrao Ambedkar ISH OPD at AIIMS New Delhi. Study duration was the October to July 21. Population was the head and neck cancer patient receiving treatment at the OPD AIIMS New Delhi, and sample was those who will met the inclusion criteria at the Dr. Bhimrao Ambedkar ISH AIIMS New Delhi. Sampling technique was the convenience technique. Sample size was calculated based upon the assumption of the pilot study, and it was calculated to be 100 participants. Coming to the inclusion criteria, those who were willing to participate and between the age of the 18 to 65 and able to understand the Hindi and English language. Exclusion, those who don't want to give the informed consent and having known psychiatric illness before the diagnosis. Ethical consideration was obtained from the Institute Ethical Committee, AIIMS New Delhi. Tools for the data collection, total 3 tools was used for the data collection. First was the subjective data sheet. It was the self-structured tool which was include the demographic profile and the clinical profile. Second tool was to assess the social support. The tool was the multi-dimensional scale of the perceived social support. It was a 12-item standardized 7-point Likert type scale. Third tool was the PHQ-9, which mainly assess the screening, mainly used for the screening of the depression disorders among the patients, and the total score was ranges between 0 to 27. Data collection procedure, after having the inclusion and exclusion criteria, patient participants were given the information sheet and informed consent was taken, and then subsequently data regarding the socio-demographic profile, clinical profile, and social support depression was collected by face-to-face. Total time taken was the 25 to 30 minutes. Data analysis was done using the SPS 25 Strata 14 version. Coming to the study finding, table 1 is showing the demographic profile of the 100 participants. So total 37 participants were aged between ranges between the 42 to 54, and among the 100 participants, 85 were the males, and among 100 participants, 74 were the unemployed at the time of the diagnosis, and 61 participants were having the oral cavity as a tumor site diagnosis, and 85 participants were diagnosed at the advanced stage, and 26 were having the comorbid illness associated with the cancer diagnosis. And 12 participants were having the history of the cancer, and 58 participants were having the good performance status. Clinical profile, coming to the clinical profile, 56 participants were on the concurrent chemoradiotherapy as a treatment modality. Coming to the primary objective 1, to estimate the perception of the social support. So in this table 2, you can see the 60 participants were having the high social support, followed by the moderate, which was 38 participants were having, followed by the 2, which was the low social support. Coming to the table 2A, in this you can see in family social support, 98 participants were having the high social support, followed by the significant other, 66 participants were having the high social support, and from support from the friends, 52 participants were having high social support from their friends. Coming to the primary objective 2, in this pie chart, you can see the prevalence of the severity of the depression. You can see 6% participants were having the severe severity of the depression, followed by the 12%, which was moderate to severe, and then 18%, which was moderate, followed by around 60% population were having mild to minimal depression. Coming to the secondary objective 1, which was to find the correlation between the social support and the depression. In this, you can see there was a weak negative correlation, which suggests that if the social support increases, depression will decrease. Coming to the secondary objective 2, It was to determine the association of the social sport with the clinico-demographic variable. Table 4 is showing the association. In this, none of the variables shows the significant finding with the social sport except the performance status. Here you can see the p-value which is less than 0.05. That means if the participant, those who are having high social sport, they are having good performance status. Coming to the secondary objective 3, it was to determine the association of the depression with the clinico-demographic variable. Table 5 is showing the association of the depression with the clinico-demographic variable. Only 2 or 3 variables shows the significant finding. Here you can see the one, those who are having advanced stage, having moderate to severe depression. That means advanced stage of the cancer increases the chances of getting the patient into the moderate to severe depression. The value was the 0.045, which is less than 0.05. And second statistical significant finding was with the performance status. So here you can see the one, those who are having the poor performance status, they tend to have moderate to severe depression at the p-value 0.006, which is less than 0.05. Coming to the discussion, in the present study, most of the patients, 60%, had the overall high social support. These findings were consistent with the results of the studies given by the ED et al. And NG et al. And again, Hesse, Wolfe et al. In their systematic review again said the depression severity at the diagnosis, during the treatment and during the first month, but due to COVID-19 pandemic, I have assessed all the illness trajectory. So the overall, the severe depression, moderate to severe depression was 36% in our study, which is consistent with the previous study finding. And plethora of studies again demonstrated that the high social score is significantly associated with the less depressive symptoms, and the higher general mental health score again consistent with the present study finding. And again, in addition, the patients who had poor performance status were significantly more likely to have moderate to severe depression in this study, again concordance with the study results by Yadav et al. And Hamrild et al. So coming to the conclusion, despite receiving high social score, there was a high prevalence of the patients with a moderate to severe depression. Therefore, it is pertinent to monitor the mental health of the patients with the head and neck squamous cell carcinoma and provide the mental health rehabilitation as per their needs. In future, longitudinal studies may be conducted in a larger sample of the head and neck cancer patients undergoing uniform treatment to confirm the buffering effects of the high social support on the prevalence of the depression. These are the references of the research paper. Thank you.
Thank you, Ms. Bhavna. I just have a small clarification to be made. You said that there is a weaker positive correlation, isn't it? Yes?
Yes, a weak negative correlation.
Negative correlation, right. Okay, so what could be the reason for this? Because your study findings clearly states that the social support was relatively higher, wherein which, if you look into the percentage of depression, it is it's just going in the opposite direction. Could you just tell me the reasons for this? Like, what is the reason as an investigator? What do you feel actually?
So for getting high social score, still people are having. Sir, actually, I have not assessed the physical sign and symptom. Physical sign and symptom could have the more depressive, because in PHQ-9, the depression screening tool which I have used, the tool was more related with the the sign and symptom of the depression association, like sleep problem patients are having, pain symptoms patients are having. Due to that, the people are getting higher score on the PHQ-9 scale as compared to the journal. In this in the social sport, I have assessed only the emotional sport, not the other informational sport, and the spiritual sport I have not assessed. Only the emotional sport I have assessed. The depression could be high due to the physical sign and symptom only, which I have not assessed.
Okay, why did you choose this PHQ? Because I understand that it is not much comprehensive to meet the purpose of your study, I feel. Is there any specific reason of choosing this tool, PHQ?
Sir, actually, I have done various systematic reviews and various studies I have assessed, and then moreover, PHQ-9 incorporates the DSM-4 criteria, which other tools are not having that criteria.
Okay.
Here
okay,
you can see.
Yeah. Okay then. Thank you.
Thank you, sir.
On to the next presentation, which is going to be done by Ms. Nitish, Nursing Officer from All India Institute of Medical Sciences, Bathinda. And the title of the study is Nursing Care Bundle Sequential Exploratory Study. Ms. Nitish, are you online?
sir, for giving me this opportunity.
Please go ahead with your presentation.
Sir, am I audible? Am I audible?
Yes, you are audible. You are audible. You can please proceed with your presentation. Begin with your objectives and then go ahead with your methodology.
Okay, sir. So title of my study was Developing a Neutropenic Nursing Care Bundle. It was a sequential exploratory study. Objectives for my studies were to develop the neutropenic nursing care bundle and to determine the validity of this bundle. So research approach was a mixed method approach, and research design was sequential exploratory design with the use of instrument developmental model. And in this design, qualitative phase was dominant over quantitative phase. Research setting was AIIMS Rishikesh. There were two distinct phases, as I shown in this figure 1. There was two phases. Phase 1 was qualitative phase or interpretative phase, and it was done in 2 steps. Step first was focus group discussion, and step 2 was extensive literature review through the use of electronic sources. And in phase 2, which was quantitative validation phase, first in step 1 we prepared the neutropenic nursing care bundle first draft and subsequent further drafts. And in step 2 we validate the bundle first draft and subsequent draft with the help of Delphi technique. Then samples for my study in phase 1 for focus group discussion. For focus group discussion, the sample were nurses working in medical oncology, hematology ward and caring for neutropenic patients, having work experience of minimum 6 months in the medical oncology, hematology ward. And for phase 2, for Delphi rounds, the sample were 5 members, both professional and experiential members of medical hematology, medical oncology, microbiology and nursing department. So these were the samples. And statistical analysis, mainly we calculated the ICVI and SCVI for all the items which we included into the bundles. So items having ICVI under 0.8 was carefully scrutinized and modified, which means the items which are having the rating of less than 80% was modified and again circulated to the panel members. Items having ICVI over 0.8 was accepted for final bundle, and SCVI over 0.9 was accepted. So this is the flow diagram for the methodology. Now moving on to the results. So this table shows the demographic characteristic of nurses included in the focus group discussion. So mean age of the nurses were 28. Most of them were male. Total clinical working experience was 4 years, and year of experience in oncology unit was 3 years. So after conducting the focus group discussion, just we did the focus group discussion just to take their opinion, like what nurses think what should we include into the nursing care unit for neutropenic patients. So we identified 6 components. These were frequent, they said most of them met the consensus with these 6 components, which were frequent hand hygiene by the nurses, daily oral care, personal hygiene, central and peripheral line care, food hygiene, and environmental hygiene. So this was the first step in the study. After getting this, we reviewed these points further to get a evidence-based data. So in this, approximately 500 studies were explored. After reading the titles and abstract, most of the study were rejected based on inclusion and exclusion criteria. And finally, 26 studies meeting the eligibility criteria reached the saturation of evidence. And these studies were critically appraised by 2 independent reviewers, and data was extracted and tabulated. So after getting data from the focus group discussion and mainly from the literature reviews, current evidences, we develop a neutropenic nursing care bundle, our first draft, which consisted of 12 items under the 5 major domains. So these 5 major domains was hand hygiene, care of central venous catheter and peripheral lines, routine oral care, antiseptic bath, and perianal care. So after forming the draft, we gave this draft to the panel members for the content validation. And after getting back the first draft, these are the findings as shown in the table, as shown in table 2. These were the 5 domains, and under these 5 domains there were 12 items. and we calculated ICVI and SCVI based on the agreements of the panel members. So in this table, we can see all the among the 12 items, 9 items were not deemed reductant and they reached consensus and accepted for the final bundle. While the item A2 and item C4, even though they were meeting the ICVI, but the panel told to do some kind of modification in these items. So I did the modification and including the final bundle. While we can see here the domain E, which is perianal care, there was a item in item E1, the ICVI was 0.6, that was not meeting the cutoff value of ICVI. So this item was completely modified and and after the experts also gave some suggestion to incorporate 2 more items like diet and environmental hygiene. In first bundle, there was only 5 domain. Then after doing the first Delphi round, the experts suggested to add 2 more domains, which were diet and environmental hygiene. So the second bundle was having the 7 domains and 26 items. Then again, I circulated the panel members, but in the second round, all the domains and all the items were meeting the cutoff values of ICVI and SCVI. So the final, there was no content was suggested to supplement or remove after the second round of Delphi, but it was suggested to make it more practical and usable by the nurses. So I want to show you the final look of the bundle. It is not opening. Sir, is it visible?
No, it is not visible. Nitish, Ms. Nitish?
Yes, sir.
I think it is not getting opened. Probably we'll stop with this. I mean, have you got anything to present furthermore?
No, sir, just I want to show the final
This neutropenic nausea
bundle which I developed. Yes, sir. Sir, is it visible now?
What's it? I think it is. No, I think you need to change the slide. Opened. If you have any further slides, you can just move ahead. Otherwise, we will stop with this and move on with the discussion.
Okay, sir. So mainly the result were the 2 Delphi round was conducted to reach the consensus, and in the final bundle there were 7 domains, as those were hand hygiene, care of central and peripheral lines, routine oral care, antiseptic bath, perianal care, diet and environmental hygiene. So these were the main domains which was included into the bundle, and further in these domains 26 items were included. So this is the summary of my results and research study. Total, we included 26 literature reviews, and at the start of round first of Delphi, 12 items was there under 5 domains. It was circulated to 9 panel members. So from 12 items, 9 items were accepted without any kind of modifications. 2 items were accepted but modified on the basis of comments of the panel members. 1 item didn't reach the consensus and it was completely revised again. So again, we formulated the bundle and we gave for Delphi round 2. So in Delphi round 2, there was 15 items circulated to the panel members, and in second round, all the 15 items reached the consensus. And at the round of 2, 15 items were incorporated into the final bundle, and final bundle contained 26 items under 7 domains. Limitations of my study was it was just limited to the developmental process, was limited only to the content validation computations due to time constraints. Moving on to the discussion, the present study was conducted in 2 phases. In first phases, data was collected from the focus group discussion with oncology nurses and best evidence-based literature from generation of item pool and a bundle draft of neutropenic nursing care, and was further validated through 2 rounds of Delphi, and ICVI was found to be over 80% and SCVI was found to be over 0.9 at the end of bundle development. A similar study was conducted in India by Kumar P. et al. In 2020 for development of protocol for nurses and caregiver related to prevention, early detection and management of chemotherapy-induced neutropenia. And it stated the consistent result with the present study. They also found the content validity index protocol was found 100%. A similar study was conducted by Kumar A. to develop the risk assessment tool for prediction of pressure ulcer. The ICVI was ranged from 0.8 to 1, and the content validity index of risk assessment tool, which is SCVI, came out to be 0.9. So these findings suggest a consistent result with my study. So conclusion is the sequential exploratory mixed method approach assisted in viewing the context of the study from multiple perspectives, integrative both qualitative and quantitative method, enhance the understanding of knowledge gaps and facilitator of neutropenic nursing care. The present study has provided a set of valid written nursing care interventions for nurses related to neutropenia.
Thank you, Ms. Nitish. I think we are running out of time.
Thank you, sir.
I just have one clarification. Like, what was the total duration of your study? Now, how long did you take to complete this? I mean, your process of doing this data collection, both qualitative and quantitative.
Sir, actually, data collection I start into the November 2021.
Okay. And are you there?
Yes, sir. Yes,
sir. How are you going to take this neutropenic nursing care bundle which you have developed further? I mean, like, what's your plan for the future?
Sir, actually, we can implement this bundle for the nurses into the clinicals, and they can use.
Are you doing something
on the daily basis, and we can see how consistent the results is, whether they are used to whether they are able to complete the all domains or not.
All right. Have you started doing that?
No, sir, not yet, sir.
Okay.
Actually, sir, I'm working, like currently I'm working in AIMS Batinda. There are not so much patients like who are neutropenic or not IPD have been started. So I'll do the further project once I get the patients.
Okay. Thank you so much, Ruchika.
Thank you, sir.
Okay, then next presentation is going to be by Ms. Sarika ML, tutor from SUM Nursing College, Bhubaneswar. And the topic of the study is a correlational study to assess the perception and exercise barriers among type 2 diabetes mellitus patients.
Yes, sir. Sir, slides is it visible, sir?
Just a second. Yeah, the slides are visible now.
Yes, sir. Thank you.
Please begin with your objectives and then.
Sir. So good afternoon, sir. Myself, Sharika ML. My study objectives are to find out the correlation between the exercise barriers with the level of perception among diabetes mellitus patients. The study design is it is a correlational descriptive research study, and the samples were type 2 diabetes mellitus patients, those who are attending the medicine OPD, IMS and some hospital Bhubaneswar, and the sample size for this study is 128, and the sampling technique is purposive sampling technique. And the inclusion criteria where the patients with diabetes, those who are having the RBS value more than 130 milligram per deciliter, and those who have diabetes mellitus are diagnosed more than 6 months, and the patient, those who can speak or understand Odia language, Hindi or English or Bengali language, and age more than 18 years, and the exclusion criteria where the mentally ill patients and physically ill patients were excluded. And the data collection tools here, totally 3 tools were used, and the self-structure sociodemography proforma, and then a standardized appraisal of diabetes scale and a personal diabetes questionnaire. In the standardized appraisal of diabetes scale, it is a 7 questions are there, which deals with the thoughts and feelings of people, those who are having diabetes, and it is used to assess the level of perception among type 2 diabetes mellitus patient. And it had a maximum score of 27 and a minimum score of 15. The smaller the total score, the more positive appraisal strategy will give. And the personal diabetes questionnaire here, it will assess so many components are there, in which the physical activity components are selected for the study, and to find how hard it is to start the exercise. And this section consists of total 7 questions with a maximum score indicating there is more barriers, and it have a maximum score of 42. And analysis here, among 122 patients, around 60.2% were males, and among these patients, 94.5% does not perform any kind of exercise, and there are so many barriers they are expressing, and about 83.6% patients having a family history of diabetes, and around 60.9% have a normal BMI, and 78.1% do not have any history of substance abuse. And the level of perception and the exercise barriers here, among the total 128 patients, the majority of them had a negative appraisal on the diabetes mellitus with a mean value of 17.98. And while considering the exercise barriers, they have so many, or majority of them have exercise barriers with a high score of mean score of 36.7. And the correlation, it is the table showing that there is a negative weak non-significant correlation. It is got like a minus 0.143, the value got between exercise barriers and level of perception. And the association with the level of perception and selected sociodemographic variable, it is showing the source of information have a significant association with the perception of diabetes, and the exercise barriers are showing that there is a significance with the exercise practice will have a significant association with the exercise barriers. And some similar results were got from some other studies, like another study, it was reported that the physical activity was undertaken by 34% of the patients with the diabetes, and only 9% of these patients exercised sufficiently to achieve a large change in the heart rate or breathing. The main reason for inactivity include the perceived difficulty in taking part in exercise, feeling of tiredness, and so something good on television. These are the barriers they were telling. And some another study, it was quoted that the barriers and enablers to diabetes control in Eastern India showed that almost 2/3 of the patients were reported performing physical activity frequently, and the majority of the patients cited walking as a most preferable mode of physical activity. And as a conclusion, exercise together with the medical nutrition therapy forms the cornerstone for diabetes therapy. And the study results showed that there were a lot of barriers are there among the diabetes patient to continue their exercise in daily life, and it had a significant association with the diabetic control also. And also there is a positive relation between diabetes barriers and exercise and the perception of diabetes. Thank you, sir. These are my references. Thank you.
Thank you.
Hello.
Sarika, are you online?
Yes, sir.
Can you just tell me the barriers which you have actually studied here in this particular research project, exercise barriers? Because nowhere.
Sir, there are 7 components are there. What are the components? What they are feeling like to be continue, whether it is a family not supportive, and 7 components are there, sir. Whether it is continue without daily, whether they are feeling fatigue on the continuing of exercise, like that. So 7 components are there. With the score also there, sir.
Okay. And one more thing, what is this appraisal which you are mentioning in your analysis? Because in quantitative studies, when you're presenting numerical data, I think, is this the term which is actually given in the instruments which have used?
Yes, sir. Yes, sir. It is in diabetes appraisal scale. It was written, sir. Sir, it is having a quantitative rating, sir.
Quantitative
Standard,
rating.
yes, sir. Standardized tools.
Okay. Okay then, thank you.
Yes, okay, sir. Thank you, sir.
Okay, next we have Mrs. Abra Pearl, PhD nursing scholar from College of Nursing, Pondicherry Institute of Medical Sciences, Puducherry. And she would be presenting on online educational program for parents of adolescents on HPV vaccination during COVID pandemic. Mrs. Abra?
Yes, sir. Just
Yeah, you can
I'm just
start
sharing.
doing. Okay.
At the outset, I would like to thank the organizers for giving me the opportunity to present my pilot study of my main study. So it's an online education program on HPV vaccination during the COVID pandemic, and I was guided by Dr. Navneeta, HOD of Community Health Department, Pondicherry Institute of Medical Sciences. So the title of the study is The Effect of Online School-Based Education Program for Parents of Adolescent Children on Human Papilloma Virus Vaccination. Research question was, is school-based education program on HPV vaccination effective in improving the knowledge and attitude of parents of adolescents and the vaccination status of adolescents? So the objectives were to assess the existing level of knowledge and attitude of the parents of adolescents on HPV vaccination in 3 groups. And second objective, to evaluate the effectiveness of school-based education program for the parents of adolescents on the knowledge and attitude on HPV vaccination in the 3 groups. And the third one was to correlate the knowledge with attitude of the parents of adolescents on HPV vaccination in 3 groups. So this is the conceptual framework that was used based on King's goal attainment theory for all the research methodology. The approach was quantitative. The research design was experimental, pre-test, post-test design with 3 groups in the study with 3 different types of interventions. So here, the samples were selected from 3 higher secondary schools at Uttanjatram, Dindigul district. Population was parents of adolescents. Samples were parents of adolescents who fulfill the inclusion criteria. The important criteria was they should know English or Tamil and be confident to use an Android mobile because it was online education. Sampling technique was systematic random sampling. The sample size was 45 because it was a pilot study. And the data collection tool consists of 3 parts. First one was demographic data. Second one, self-administered questionnaire on HPV vaccination. Part 3 was a 3-point modified Likert scale. And part 4 was the intervention, which was specific for the 3 different groups. So data collection due to the COVID-19 surge and lockdown, the study was conducted online. A total of 45 samples were selected, and permission and contact details of the parents of adolescents studying in the 7th, 8th, and 9th standard were obtained from 3 different schools at Uttanjatram. The schools were allotted to each group or arm of the study by lottery method. The parents were contacted over the phone and informed consent was obtained. Pretest was done with Google Forms. Data collection for group 1 was after the pretest educational lecture was given through with PowerPoint presentation on the Zoom platform. 16 parents participated and post-test was administered after a week. In group 2, after the pre-test, a Zoom meeting was arranged and the short film was screened for the participants, followed by discussion. And post-test was administered after 1 week, and there were 15 respondents in this group. Group 3, after the post-test, the self-learning e-booklet was sent to their WhatsApp number, and a total of 16 parents participated in this group. Coding of the scores were done, and analysis was also carried out. So these are a few pictures of the data collection. This is on lecture and the short film clippings and the self-learning booklet. Reliability of the tool, the test-retest method was used, and Carl Pearson method was used to compute the correlation. The structured knowledge questionnaire, the reliability was 0.969, and the reliability of the attitude tool was 0.975. So data analysis and results, socio-demographic variables, 82% of the parents were the mothers of the adolescents, and 58% lived in nuclear families, 64% were Hindu by religion, and 47% lived in the rural area. Most of the parents were either graduates or postgraduates, and more than 60% of the fathers were non-healthcare professionals, whereas 42% of mothers were unemployed. Of all the samples, 36% said that they have not heard about HPV vaccination, and most of them, that is 73%, reported that they have not vaccinated their child with HPV vaccination. The three groups of parents subjected to different methods of teaching were found to be homogeneous. Now going group wise, first knowledge about HPV infection and vaccination. So here we can see in the pre-test, this is for group 1, the lecture with PowerPoint method was used. In the pre-test, the nearly 83.3% parents had inadequate knowledge, while in the post-test, 53.3% had gained adequate knowledge. Regarding the attitude, most of them had a moderately favorable attitude in the pre-test, and in the post-test, most of them had a favorable attitude. Knowledge related to the second group, that is short film with discussion. Here, 73.3% had inadequate knowledge in the pre-test, while 53.3% had gained adequate knowledge in the post-test. Coming to attitude, most of them, that is 86.7%, had moderately favorable attitude in the pre-test, where in the post-test, 26.7% had only favorable attitude. And in group 3, where self-learning booklet method was used, there was inadequate knowledge, 93.3% in the pre-test, while in the post-test, the knowledge was adequate for 53.3%. And in the attitude, most of them had moderately favorable attitude in the pre-test, which was slightly increased. The favorable attitude was 53.3% in the post-test. So this is the table showing the evaluation of the effectiveness of the three methods. So Kruskal-Wallis method was used for to see the pre-test between the groups. So there we can see in the pre-test it was non-significant, that was the groups were homogeneous. In the post-test it was found that it was significant, and Wilcoxon's test was used for in-group comparison, and all the three values in the knowledge showed all the three values in the knowledge showed a improvement, the significance. While coming to the attitude also, the groups were homogeneous because it shows non-significant in the pre-test, and in the post-test there was a significance, and Wilcoxon's test for the individual methods inside in the group showed that it was significant. Correlation between knowledge and attitude for all the three groups were done separately, and for all three it was found that there was a positive correlation and the p-value less than 0.05. Discussion. The objective of this small-scale study was to identify the feasibility of conducting online education program for the parents of adolescents on HPV vaccination. From the study, it was found that most subjects in the group had heard about HPV vaccination, 64.44, and most of the parents of adolescents were literate. But still, the level of knowledge of the subjects was found to be inadequate in the pre-test. It was found that there was significant increase in the knowledge of the parents in all the three groups, leading to the acceptance of the research hypothesis, which stated that there will be a significant difference between the pre and post-test knowledge scores of parents of adolescents on HPV vaccination. It was found that the pre-test mean attitude percentage in the three groups was 72%, 67.1%, and 71% respectively, and the post-test mean attitude percentage in the three groups were 74.1%, 72%, and 76.8% respectively. So implications and recommendations. School-based education program can be conducted in all the schools to educate parents on HPV vaccination and create cancer awareness. As a part of the parents teachers meeting, special lectures can be arranged to create HPV vaccination and cancer awareness. Short film can be screened at the schools during the open days for dissemination of information, and distribution of self-learning booklet through the school can also be done. The study can be replicated with a large sample for further. Conclusion. Online education has become the new normal in today's education scenario. Through the systematic conduct of the online education program, the researcher found that there's a possibility of reaching the parents and educating them on HPV vaccination. So the study revealed that the school-based education programs were significantly effective in improving the knowledge regarding HPV vaccination among the parents of adolescents. So these are my references, and thank you.
Thank you, Mrs. Abra. Yeah, I just have a clarification to make with you. Can you just tell me why did you choose three different method of online education program for three different groups? See, you had three different
so I can
program on the same content, isn't it? Yes.
Sir, I missed your point. Can you tell me once again?
No, you had 3 groups,
Yes.
right,
Yes.
on which you have studied, and
So I can't hear you, sir. Hello? Sir, I'm not able to hear you. Hello?
am I audible now?
No, yes, sir. Now I can hear you.
See, my question is, like, you had 3 groups, no?
Yes, sir.
Yes, 3 groups, right? And you have given this online educational program. Short film, and the third one is a distribution of booklet,
Yes,
right?
sir. Yes, sir.
Why was it done like that? I mean, was there any reason for it?
My objective was to create a cancer awareness and to reach the parents through the school. So my main study is to find out which method is better so that that can be given to the schools and they can take it forward on a large scale.
If so, I think you must have given clarity in your objective also, because your objective or your methodology does not really clarify on that.
Okay, so this was a pilot study, so it was concised a little bit.
Okay, so this is a pilot study report, is it?
Yes, sir. This is the pilot study report. Sir.
Okay, okay then, thank you.
Thank you.
Thank you, Mr. B. Janardhanan and Mrs. K. Muthulakshmi for moderating the session. Now I invite Mrs. Vempu K, Tutor College of Nursing, JIPMER, and Mrs. K. Shanmugapriya, Tutor College of Nursing, JIPMER, to moderate the session.
Yeah, the speaker is Mr. Varun Babu. The topic is a study to assess the perception of body image among college students at selected colleges.
Can you see my slides?
Yes.
Okay. 1 second, ma'am. Ma'am, my topic is perception of body image among college students. And the introduction for my topic is body image is a perception of a person, how he or she feels about his own self, and it plays an important.
Excuse me, sir, please proceed with your title, objectives, methodology, and research.
Okay. My statement is a study to assess the perception of body image among college students at selected colleges of Puducherry. And my objective of the study is to assess the perception of body image among selected college students. And second one is to associate the perception of body image with the demographic variable among selected college students. The hypothesis of the study is there will be a significant association between the perception of body image with the selected demographic variables. When it comes to the methodology part, my approach is quantitative approach. And when it comes to a design, it is a descriptive research design. A setting is conducted in a selected colleges Puducherry. When it comes to the sample size, it is 160 students of BS nursing students. And population for my studies, the population includes students who are studying in the selected college, nursing college Puducherry. And sampling technique was a convenient sampling technique. The tool which we used for the data collection is modified questionnaire for assessment of body image, and the analysis and interpretation has been made. When it comes to the sampling criteria, inclusion criteria is students who are willing to participate in the study, all boys and girls studying in BS nursing students, BS nursing students in College of Nursing, PMS. And comes to exclusion criteria, it is a 4th year BS nursing students are excluded, and the students who are not willing to do a study. When it comes to the result part, here most of them are 93 students, around 58 1% comes under 19 to 20 years of age group. With regard to the gender, 138 were female, and with regard to the year of course, 36.9% are from first year and third year. And looking to the domicile, 109 around 68.1% are living in urban area. Among siblings, 116, 72.5% having one sibling. Here the mean value was 31.33 and the standard deviation was 17.099 for the perception of body image among the selected college students. And come to the hypothetical part, it was found that there was statistical significant association between the perception of body image with the selected demographic variables such as year of course and domicile at the level of p-value 0.05. And the study concluded that there was an impact on the perception of body image among college students when it comes to the percentage distribution of a perception of body image among selected college students is mild level of distress of body image was 83.75% and moderate level is 16.25 and no any severe level of distress found among the group. This was the result and this was my reference. Thank you.
Yeah, thank you, sir. I have a small clarification. How many colleges have you included?
The College of Nursing PIMS.
Okay, and we have told in the inclusion criteria only 19 to 20 years of students. And
yes, ma'am.
So can you hear me?
Yeah, yes, ma'am. Yes, ma'am.
Yeah, you have mentioned the inclusion criteria 19 to 20 years, but you have told only final year students are excluded. What about first year, second year? Which students have included here?
First, all 3 years have been included since the
But
final year students.
Yeah, but you have given only 19, 20, 19 year, 20 year, only 2 year students only have taken. What about the remaining, sir?
That's what, ma'am. Because they are coming under the data collection group, ma'am. That's why I didn't.
Only 19 year and 20 year. One more year?
Yes. That's what, 19 and 20, ma'am.
Well, you have given in the inclusion criteria only 19.
No, ma'am, I have not mentioned anywhere.
And even if you are not included the fourth year, you'll be having some many supplementary students will be coming comes beyond 20 years also. That means you didn't include it if we are in second year.
But I didn't mention anywhere. No, ma'am, I didn't mention 19, 20 years. Is there anywhere?
You have given it. Okay. Okay, sir, and one more thing. Have you included BMI? Because
No,
as
ma'am.
it's related to your body image, so
Yes.
I think you can add in BMI also, sir.
Okay, ma'am. Okay, ma'am. Thank you.
Thanks a lot. Thank you.
Thank you. Thank you.
Sir, one more clarification. Just
Yes, ma'am.
which tool you have used to assess the perception?
Ma'am, actually, it is a modified tool, ma'am.
Modified? Which
Yes, ma'am. Actually, it has been taken from different clusters, 3-4 tools, because when we taken for content validity, we had a mini issue. There was a question related to sexual contacts and other components. So it was coming under ethical issues. So we have excluded those things.
Questionnaire or somewhere it is a standard questionnaire you have used? Standard
No, ma'am.
validated.
No, ma'am. We have modified the tool and we have intervened with the samples.
Can you just tell me which tool you have modified according to your setting?
Yes, ma'am. Yes, ma'am. According to my setting, I have taken from 3-4 components, ma'am. Then we have modified the tool.
As you have said, it is perception and your result shows it is distress. So whether actually your tool have assessed the outcome of interest?
Yes, ma'am. Actually, the perception towards their body image, it carries about size, height, weight, and the behavior as well as their attitude behind the body image.
So it includes attitude also, but your title reflects only on like a perception.
Yes,
so
ma'am, yes.
perception on, but your result shows that it is a distress.
Yes,
So,
ma'am. No, ma'am. Their perception was to mean that they have a distress or not towards the body image.
Okay, sir, one more clarification that in your exclusion criteria, you didn't mention about students with disabling physical or mental illness.
Yes,
Have you
ma'am, yes.
included those students or have you excluded them?
Actually, we don't have such kind of student. That's why we didn't think about it.
Okay,
If it's so, I could have thinking.
Okay,
Thank you.
Thank you. Thank you so much. Okay, the next participant is Mrs. Sheila J. Her title is a pilot study report in the assessment level of job satisfaction among nurses working in a selected hospital, Puducherry. Madam, please proceed, but you please start with your title, objectives, methodology, and results. Are you there, ma'am? Mrs. Sheila? Mrs. Sheila, are you there? Please unmute, ma'am.
Okay, good afternoon, everyone. The statement of the problem is a study to assess the effect of the structured nursing rounds on the level of patient satisfaction and job satisfaction among nurses working in the selected wards PMS Puducherry. The objectives of my study is to assess the level of job satisfaction among nurses, and my second objective was to assess the and
Madam, we could not hear you. Can you please start from your title, madam? Please unmute and speak, ma'am.
Ma'am, can you hear me now?
Yeah, ma'am. Please, ma'am. Yeah, please proceed.
Okay, the statement of the problem is a study to assess the effect of structured nursing rounds on the level of patient satisfaction and job satisfaction among nurses working in a selected wards, PIMS Puducherry. The objective of my study is to assess the level of job satisfaction among nurses. Second objective was to assess the level of satisfaction among patients. Third objective, to evaluate the effect of structured nursing rounds on the level of job satisfaction among nurses. Fourth objective was to determine the effect of structured nursing rounds on the post-test level of satisfaction among patients. Fifth objective was to associate the post-test level of job satisfaction among nurses with their socio-demographic variables. And sixth objective was to associate the post-test level of satisfaction among patients with their socio-demographic variables. And I have used the instruments to collect my data was for the nurses, I've used individual work performance questionnaire, and for patient, I've used patient satisfaction with nursing care tool. And this is one of my pilot study report. And method of data collection is I included the sample size of nurses was 6 and patient 30, and sample design was it was one group pre-test and post-test design for nurses and only post-test design for patients. And my target population, I include 2 wards, that is one is plastic surgery ward and OBG wards, and patient was admitted in the plastic surgery and OBG wards. After obtaining the participant information and informed consents and confidentiality of the thing. It includes 4 phases. The first phase consists of pre-test for the nurses and the patients nurses satisfaction for the control group, and the second phase is consists of a training section which is carried out for the period of 2 weeks. And third phase, which consists of the assessment and monitoring phase, which was conducted for the 3 months. And the fourth phase was the post-test thing. And data analysis, this is one of the data according to this. The majority of the participants were like married, and they were graduates, and they're working in the plastic surgery and 2 wards only, and they had an experience of 1 to 5 years. And this is the demographic variables according to the patients. And going to my objectives, my first objectives was the first assessment on the first objective is like distribution of nurses according to the level of job satisfaction in the control group. In the control group, majority were found in the pre-test they were moderately satisfied and unsatisfied. In the post-test also, I got a result like they were moderately satisfied and unsatisfied. Whereas in the experimental group, in the pre-test level of assessment, I found them they were moderately satisfied and unsatisfied, and in the post-test level, I found them they're like they were satisfied. My going to the like my objective, third objective was to assess the effect of nurses. It was statistically significant with the effect of structured nursing rounds. And one of the objective like the effort to assess the effect of structured nursing rounds on the level of satisfaction among patients in the experimental and control group. Even I found that it was statistically significant. And my last objectives was to find out the association, and I found only 2 association was significant. That is it was significantly associated with the type of family as well as duration of the stay. It was statistically significant. Rest all the parameters was not significant with my studies. I did not do correlation because my sample size was less. So the findings of the study is that effect of structured nursing grounds is one of the training which we need to implement for better job satisfaction among nurses. Thank you.
Thank you, madam. Madam, can you hear me?
Yes, ma'am.
Ma'am, you have conducted structured nursing rounds, no? So,
yes, ma'am.
What are the focus or main component of these ward rounds, madam?
It consists of 9 P's. One is when the nurses are going for rounds, usually it is not in a routine type of round. It is one of the special rounds which have been implemented, which consists of 9 components, like 9 P's. One is pain assessment and position, and comfortable patient, comfortable, all that proximity, all that we have to assess at the single time. When the nurses are going for rounds, they have to assess all the 9 parameters together.
Okay.
So it will enhance their working environment as well as not going frequently and doing the assessment.
Okay, it's a good trial. Yeah, it's good trial checking job satisfaction with nursing rounds. And one more thing, I have included only BSc nurses who have completed BSc nursing only, like 1 to 5 years.
Ma'am, in the PIMS, we have a recruitment of BSc nursing graduates only. So I have like that only, ma'am, okay. Nurses.
You don't have any other categories like senior
no, ma'am, because they are involved in the monitoring also. So they are not included. Whether the staffs are conducting structured nursing rounds, whether they are implementing. So I've included ward in charges, assistant nursing superintendent, DNS level also. So they will be monitoring the staffs, assigned patients and staffs. So I've not included them.
Hello, can you hear me, ma'am?
Yes, ma'am.
Just a clarification. And this is a
yes, ma'am.
Intervention was structured rounds, right, ma'am?
Yes, ma'am.
So it would be better if you would have assessed because of this nurse.
Hello.
Whether would it improve the patient outcome rather than nursing satisfaction, right? Really, this.
Yes, ma'am. Yes, ma'am. I've included both the components, patient satisfaction as well as job satisfaction, because to register. Yeah, I've included that also, ma'am.
Clinical outcome, whether the incidence of other miscommunication because of this rounds has reduced, or any like patient clinical outcome would be better, right? Because you are not anything communicating with the patients, rather than patient satisfaction, patient clinical outcome would have been improved because of this structured nursing rounds, right, ma'am?
Yes, ma'am. I will think about that, ma'am. This is pilot study only. In the main study, I try to implement that also, ma'am. Anything, ma'am?
Yeah, ma'am. Thanks a lot.
Thank you so much.
The next presenter is Sister Sumi PJ. Her topic is a study to assess the effectiveness of nutrition supplement with beetroot, jaggery, and lemon on mild anemia among nursing students in the selected College of Nursing at Puducherry. Madam, you please proceed with the title, objectives, methodology, and results, please.
Good afternoon, ma'am. Is my slides visible?
Yeah, ma'am, it's visible, ma'am. Please proceed, ma'am. Ma'am, can you start? We could
Yes.
not...
My title of the study is Effectiveness of Nutrition Supplement with Beetroot, Jaggery, and Lemon on Mild Anemia. Young reproductive age is the preparatory period for the physical development of the future mothers. Anemia is a main nutritional deficiency disorder in India and other developing countries. According to ICRW, adolescent girls, 58% are having hemoglobin level less than 12 grams per deciliter. In India, anemia is a major health problem. The level is being 56% in 15 to 49 years of age group.
Madam.
In Tamil Nadu,
Madam, please proceed with your title, objectives, methodology, and results only, madam.
okay, ma'am. Statement of the problem, a study to assess the effectiveness of nutrition supplement with beetroot, jaggery, and lemon on mild anemia among BSc nursing students at College of Nursing, PIMS, Puducherry. Objectives of the study: to determine the hemoglobin level among nursing students before nutrition supplement, to determine the hemoglobin level among nursing students after 25 days of nutrition supplement, to determine the difference in hemoglobin level before and after nutrition supplement, to find an association between predetermined hemoglobin level with the selected socio-demographic and clinical variables. Hypothesis: there is a significant difference between pre-test and post-test level of hemoglobin after the administration of nutrition supplement with beetroot, jaggery, and lemon. Methodology: research approach was quantitative approach. Design: pre-experimental, one group, pre-test, post-test design. Setting: College of Nursing, PIMS. Population: all BSc nursing students. Sample: second year and third year BSc nursing students. Sample size 35. Sampling technique: purposive sampling. Sampling criteria: inclusion criteria: BSc nursing students with hemoglobin level between more than or equal to 10 gram per deciliter to less than or equal to 11.9 gram per deciliter. Exclusion criteria: BSc nursing students who are not to suffer from urolithiasis, kidney diseases, bile duct stones, and non-case of allergy to beetroot, and day scholars and students who are not willing to participate. Data collection process: pre-hemoglobin determination done by photometric method. Students with mild anemia were identified, and on day 0, deworming done by tablet albendazole 400 mg HS. Nutrition supplement 50 gram for 1 to 25 days before lunch was given to the students. Post-hemoglobin estimation on 26th day by photometric method was done. Data analysis: distribution of nursing students according to socio-demographic variables.
Among the nursing students, 65.7% comes under the age group of 18 to 20 years. 57.1% students were second years. According to clinical characteristics of the nursing students, 88.6% students had regular menstrual cycle. 3.3% students had a history of passage of worms in stool. Distribution of nursing students according to the hemoglobin levels before nutrition supplement. Among the nursing students, 34.3% had a hemoglobin level 10 to 10.9 gram per deciliter, and 65.7% students had hemoglobin level 11 to 11.9 gram per deciliter before nutrition supplement. Distribution of nursing students according to hemoglobin level after nutrition supplement. Among the nursing students, 25.7% had an increase of 11 to 11.9 gram per deciliter. 37.1% had an increase of 12 to 12.9 gram per deciliter. And 11.4% had an increase of 13 to 13.9 gram per deciliter in their hemoglobin level. Difference in hemoglobin level before and after nutrition supplement. 14.3% students had an increase of hemoglobin level 0.621 gram per deciliter. 17.1% students had an increase of 1.1 to 1.5 gram per deciliter. And 17.1% students had an increase of more than 1.5 gram per deciliter in their hemoglobin level. The median difference in hemoglobin level between pre and post-test administration of nutrition supplement was 0.5 gram per deciliter, and this difference was observed to be highly statistically significant at 0.001. Association between predetermined hemoglobin levels of nursing students with selected socio-demographic variables. In this, history of chronic anemia had significant association with the predetermined hemoglobin level at 0.05 level. Discussion. The first objective was to determine the hemoglobin level among nursing students. Among 75 students who fall in the criteria, 44 had mild anemia and 12 had moderate anemia. Such study was conducted by Babida in 2014. And second objective, 20% had an increase of 10 to 10.9 gram per deciliter. Sood and Sarada D have done a same study. The supplement was given for 60 days. In third objective also, Milkan and JIPMER had conducted study. They have given beetroot juice and there was an improvement in their HP levels. Hence, the study has proved that nutrition supplement with beetroot, jaggery and lemon was very effective in increasing the hemoglobin level of nursing students with mild anemia. This was my references. Thank you.
Thank you, ma'am. I have a small clarification that how did you control the extraneous variables? Like, for example, students will be regularly consuming egg milk, like green leafy vegetables, pulses, grains, and all. And whether it is having some impact on your.
Yes. Hello, ma'am. It was my one of the limitations of my study. Actually, I have taken the students from hostel. Other extraneous variables I couldn't control.
Okay, madam. Thank you. And one more thing, in your results, before and after intervention, the HP almost 25.7% people didn't improve. It's having the same value. What's the reason for that, ma'am?
That reason, after study intervention, I have counseled the students. So they have told because of nutrition supplement intake, they have skipped their meals many days.
Okay, madam. Okay. And stool test, did you conduct them at the end of the intervention, like test for ova and cyst?
No, no, no.
Before or after the intervention? No.
No, no, no.
Okay, madam. Thank you.
Can I ask a question?
Yes, yes, sir.
Janardhanan, can I ask a question?
Sir, you can proceed, sir. Please, sir.
Good. Study is interesting. Anemia being very common among girls. In fact, yours is hostel girls. Like it is an experimental group. They eat only the common diet. So
yes.
Diet not much different. Can you tell this? These three things, how did you combine? How many times a day? Hello.
Sir, I didn't get your question, sir.
How many times a day? How
Yes.
did you combine these three things and gave them?
Beetroot, jaggery, and lemons.
Yeah. How did you combine everything?
Yes, sir. I have taken 50 gram of beetroot.
Okay.
Then 50 ml of boiled and cool water and 2.5 gram of jaggery in a syrup form and 2 ml of lemon juice for
So this
one
is
student.
early morning when it was given?
No, sir. No, sir. Before lunch, I have
Before
given,
lunch
sir.
you give this.
Before lunch.
Good, good. Maybe my suggestion is it is a good study, not bad. So you should have tried for all the levels of anemia.
Yes, sir. I have presented in the institutional review board committee meeting. So moderate anemia and severe anemia, we have to refer to doctor. So they have suggested only mild anemia students you can take for supplement.
No, I think we should have tried. If it works, okay. I know
Yes.
you have to give other, you have to take care of the severely anemic in a different way.
Yes.
But this only an observation, sorry, your nutrition supplement, no?
Yes, sir.
It's not a drug you are giving. Maybe next time when you are doing this study, you can try in
Sure.
all other groups.
Sure, sir.
It's good study, nice.
Thank you, sir.
May I ask one clarification?
Yes, ma'am.
You prepared or otherwise already you are ready-made, you prepared and given to everyone. Every day you are prepared freshly?
Yes, ma'am. Freshly prepared every day by myself, ma'am.
Yourself?
Yeah, yes, ma'am.
Any standardization? How you standardize your preparation is?
Yes, ma'am. I prepared 3 samples and gave to Pondicherry University Food and Science Department. They have checked the 3 samples and they have estimated the iron and vitamin C values and they gave me certificate. So the 3 samples, first sample only the beetroot and with extract, and the other one beetroot, jaggery and lemon, and the third one I have filtered it, strained it, only that diluted part I have taken and added the beetroot, jaggery. So among these 3 preparations, the third one was good. The iron and vitamin C values were good values in the third sample. So I have given this third sample to the students.
You got any fund support for your study?
Nothing, ma'am. I only took. It was not fun.
Okay, thank you.
Thank you.
Ma'am, did you exclude the students who are taking vitamin C, like multivitamin supplements? Have you excluded those students in your study?
Yeah, they were not taking. I assured they were not taking any vitamin supplements during my study period and before.
Okay, ma'am.
Excuse me, ma'am.
Yes.
It's a very good study because you know that before the people are entering into a reproductive age group, which is very essential part in our country as such.
Yes.
The thing is, once you are not able to control the extraneous variable because you know you are not able to control the upset, for which you should have had at least a control group to see attribute your results to your credit of intervention, because you have only one group pre-test and post-test.
Yes.
Then how would you attribute the results to your credit of your intervention? If it is you have a control group because you are taking from a hospital, it would be better you can say that you are, because of your intervention, people had a difference in the HB level.
Yes, ma'am. That intervention period also was a 6 weeks only. It was actually PG study. So the time period was very less. And that time, this mild anemia people also, I didn't get much.
But having a control,
So maybe
that will not differentiate your time as such.
Maybe next study I can do like that with experimental control group as comparative study.
Thanks a lot, ma'am, for your clarifications. Thank you.
Thank you.
Thank you, Shanmugapriya ma'am and Vembu ma'am for moderating the session. Now I invite Mrs. S. Rani, Tutor, College of Nursing, JIPMER, and Mrs. Wahida S., Lecturer, College of Nursing, JIPMER, to moderate the session.
Good evening to one and all. May I invite Ms. Sharadi Nayak to present her study on level of happiness and May I invite Ms. Sharadi Nayak? So sorry for the delay. Just we will skip on to the next speaker. Mrs. Jacqueline Lilly, ma'am, are you ready online? Yes. May I invite Mrs. Jacqueline Lilly, Assistant Professor from College of Nursing, PIMS, to present her topic on effect of support service intervention on the outcome of drug compliance and psychological well-being among patients with mental disorders. Ma'am, the stage is yours. You can proceed now.
Hello.
You can share your slide. Yes, you are audible, ma'am. You can
Slide
share your
in the slide. Ma'am, am I audible, ma'am?
Yes.
Ma'am, is my slide is visible?
Yes, it's visible. You can start your session. Kindly proceed with the title, objective, methodology, and results, madam.
Okay, ma'am. Good afternoon to everyone. I am Mrs. Jacqueline Lillipriya, working as an assistant professor, doing my PhD as a part-time under Pondicherry University. I would like to present my pilot study report on effect of support service intervention on the outcome of drug compliance and psychological well-being among patients with mental disorder. Introduction. Drug compliance is one of the commonest cause of therapeutic failure in both medicine and psychiatric. With a psychiatric patient, the factors contributing to non-compliance are related to illness variable, patient's variable, medication variable, and patient therapeutic variable. Need for the studies related to the drug compliance are limited. Compliance to medication is an important clinical issue in psychiatric, as non-compliance to medication is one of the commonest cause of treatment failure. Support service intervention has shown beneficial effect towards the management of patient with mental disorder. Statement of the problem, effect of support service intervention on the outcome of drug compliance and psychological well-being among patients with mental disorder at selected hospital, Puducherry. Objective to assess the level of drug compliance and psychological well-being among patients with mental disorder before the intervention, to evaluate the effectiveness of support service intervention on the outcome of drug compliance and psychological well-being among patients with mental disorders, to find out the association between the pre-test level of drug compliance and psychological well-being with selected socio-demographic variable. Hypothesis, there was a significant difference in the level of drug compliance and psychological well-being on post-test level after support service intervention among patients with mental disorder. There was a significant association between the level of drug compliance with selected socio-demographic variable among patients with mental disorder. Hypothesis number 3, there was a significant association between the psychological well-being with selected socio-demographic variable among patients with mental disorder. Ethical consideration, the study approval was obtained from Institutional Review Board and Doctoral Committee of College of Nursing, PIMS. Formal permission was obtained from Director Principal and Principal College of Nursing, PIMS. Written informed consent was obtained from the study participant before the data collection. Proper explanation was given to the study participant regarding the purpose of the study. Confidentiality of information was maintained by utilizing PIMS EMR number of the samples. Research methodology, quantitative approach, and research design is quasi-experimental design. Psychiatric OPD is my setting. Target populations are patients with mental disorder. Samples is 20. Sampling technique is convenient sampling method. There is a 2-group experimental group and control group, 10 in each group. Pre-test was conducted in for the both the group, but intervention was given for experimental group after 1 and 3 months. Post-test conducted for both experimental and control group. So pilot study was assessed to assess the feasibility and of the setting and reliability of the tool by inter-rated method. The study was conducted among patients with mental disorder who fulfilled the inclusion criteria at PIMS in the month of June 2021 to September 2021. Then experimental group were given support service intervention after 1 and 3 month. Post-test was conducted for both experimental and control group. Data was analyzed for frequency and percentage mean and standard deviation. One way ANOVA was done for find out the association of demographic variable. An unpaired test was done to compare both the group. This is the intervention model I have prepared for support service intervention. All the aspects I have covered. For number one is family support education to the caregivers and psychoeducation directly given to the patients for memory cues. In that, I have explained about prepared self-calendar for the patient. All the 10 participants I have given. In that, I have mentioned morning, evening, night, then the timing also, whether the patient is educated, both the language I have used for the calendar and a medication container, how to use. And I have given one more instructional pamphlets also to go through. According to the, based on the objective, the analysis is frequency and percentage distribution of participants according to the level of drug complaints in the experimental group and control group before the support service intervention. It shows that in experimental group and control group, 10 that is the 100% of participants had poor level before the support service intervention, respectively, both the experimental and control group. And a percentage distribution level of psychological well-being among patients with mental disorder in the experimental and control group before the support service intervention. It shows that the experimental and control group with regards to psychological well-being, 90% of participants had moderate level and one of them had good level before the intervention, respectively. According to the objective number 2, the table 1 shows that effectiveness of support service intervention in pre and post-test level of drug compliance and psychological well-being among patients with mental disorder between the experimental and control group. It shows that compared to the pre-test, the post-test level of drug compliance shows significant result, that is t-value is 28.531. Simultaneously, in psychological well-being also comparing to the pre-test, post-test value of psychological well-being shows significant value. In the association of pre-test score of drug complaints among participants with a mental disorder with a selected socio-demographic variable in age group, that a majority of them comes under 31 to 45 in age, most of them are male. Education level, they are school level. Occupation, they have unemployed majority of them. And the type of the family also nuclear family. In marital status and the area of residence, equally half of the participants are married and unmarried, half of them are living in urban and rural, and the actual duration of mental illness is more than 1 month to 3 years, and medication mostly administered by the self. It shows that association of pre-test score of drug complaints among participants with mental disorder are not associated with their selected socio-demographic variable in experimental group. Likewise, association of pre-test score of psychological well-being among participants with mental disorder with their selected demographic variable. The result shows that the pre-test score of psychological well-being among participants with mental disorders not associated with their selected socio-demographic variable in experimental group. In the results, in the experimental group with regards to drug compliance, 10 participants had poor, that means 100% before the support service intervention, and 100% of them had good level of drug complaints after the support service intervention. And with regards to psychological well-being, 90% of participants had moderate level and 10% of them had good level before and after support service intervention. In control group, with regards to drug compliance, 10 participants had poor level in pre and post test with regards to psychological well-being, and 8 of them had moderate level, 2 of them had good level in pre-test, and 90% of participants had moderate level and 10% had good level after the intervention. The study concluded results suggested that support service intervention can be used for a better outcome of drug compliance, and it also helps to improve the psychological well-being of patients with mental disorder. Thank you, ma'am.
Thank you, ma'am. Thank you, madam. It was a nice presentation. I have just a few clarifications. Because we have taken, and there are patients with bipolar disorders, schizophrenic disorders.
Yes, ma'am.
And the side effects of each drug varies, whether it is an antipsychotic or lithium toxicity, because that becomes a major extraneous variable, right? Because of the toxicity, that might be the reason why it is hindering their compliance. Have you included those in your variables to find out whether it is having any correlation?
Ma'am, actually, according to the suggestion, they informed me to correlate. I have included only 2 major disorder, ma'am, schizophrenia and mood disorder. Ma'am? Hello?
Hello. May
Ma'am, am I audible, ma'am?
Yes, you are audible, ma'am.
Yes, ma'am. Yes, ma'am. Schizophrenia and mood disorder only I have included. Because of correlations, the results are similar, ma'am. There is no subgroup to compare. So in the major study, I will include the correlation and I will correlate with the 2 domains, ma'am.
And have you included what are the drugs they are taking, ma'am? Adherence to different drugs or just
No, ma'am. I'm not included with the drugs anything because I'm dealing with the caretaker and the patient. Since it is vary with each patient. It is since it is a group of drug. So I didn't mention that. But factors I have included later, ma'am. The causes of factors, whether it is disease related or patient related or physician related. Likewise, I had included, ma'am, after the study in the DC corrections.
One more clarification, ma'am, and you have stated that it is all the patient who takes the medicine on their own, right? Self, most of the time.
Most of the time, self, ma'am.
That means you have taken patients under remission or patients are on acute illness or only remissions you have taken, ma'am?
No, ma'am. Chronic patients only we have taken. Actually, duration should be more than 6 months to 1 year. That patient only I am selected as a inclusion criteria.
So all these patients, 100% of patients had a poor adherence before your intervention. That
Yes,
means
ma'am.
there was
Such kind of patients only I am selecting, ma'am.
Patients or symptoms worsening.
Yes, ma'am.
Okay, ma'am.
Thank you, ma'am. Thank you to the organizing all the team members. Thank you, ma'am, once again, ma'am.
May I invite Ms. Sharadi Nayak to present her topic on level of happiness and mental well-being of students studying nursing and allied health sciences program in Union Territory Medical College. Yes, Ms. Sharadi Nayak, the forum is yours. You can proceed now. And kindly proceed with the topic, objective, methodology, and results.
Good afternoon. My topic is assessment of the level of happiness and mental well-being of students studying nursing and allied health science programs in JIPMER, Puducherry. Assess the level of happiness and mental well-being of nursing and allied health science students Methodology. For this, I used descriptive cross-sectional study. Research approach was a quantitative approach. I did this research in JIPMER, Puducherry. Population, we selected the nursing and allied health science students studying in JIPMER, Puducherry. Inclusion criteria, we included all the BSc nursing and allied health science students, and the students were above 18 years of age. We excluded the students who were having chronic illness. The sample size, we estimated it to be 384 using the statistical formula for single proportion. The expected proportion of students felt happy and good mental well-being was 0.5, that is 50%. And the sample size is estimated at 5% level of significance, 5% relative and precision. And we used convenient sampling technique. The variables we used were, we had the independent variables were the demographic variables and academic variables. The dependent variables were the level of happiness and the level of mental well-being. Tools we used were part A were the variables, socio-demographic variables, academic variables, and associative factors. Part B, I used 2 sets of questionnaires, that is the Oxford Happiness Questionnaire, which is a standardized questionnaire used for the happiness. And the second, we used Warwick-Edinburgh Mental Wellbeing Scale, which is standardized questionnaire for assessing the mental well-being of a person. Data analysis, the comparison of the level of happiness and mental well-being between different categories of subjects were carried out using independent student t-test or man-Whitney u-test, and the level of happiness and mental well-being, the association square test or Fisher exact test, and these were done using with a 5% level of significance and p-value less than 0.05. Results: the significant demographic variables were put in a frequency and percentage as frequency and percentage. Then academic variables were also put as a frequency and percentage distribution pattern. Associative factors were also shown as frequency and percentage distribution. See that majority of them were not particularly happy, that is 41.9%, and next 27.6%. This table shows us that the mental well-being and the happiness are correlated with each other. That is 0.001. The p-value less than 0.05 is significant. That it shows that if the mental well-being and happiness are directly proportional. This is the association of the level of happiness with gender. Gender is associated directly, and subject is also associated with the level of happiness with p-value 0.037. The correlation of level of happiness and mental well-being of the students, in this we can see that only age is correlated to level of happiness and mental well-being among all the demographic and academic variables with p-value 0.005. Between the level of mental well-being of the students among all the demographic and academic percentage. Majority had one sibling. Most of the students were from Kerala. Most of the students did not have any health issues. For academic variables, most of the students, that is 57.3% students, were nursing students, and 61.2% students had a course duration of 4 years. Most of them had a 4 to 6 numbers of subjects per year, and majority did not have arrears in the course. The study result finding is concluded that most of the students were somewhat happy to not particularly happy, that is about 69.5%. It shows that overall the happiness index indicated it was somewhat happy. The mean score of the well-being shows that the students were moderate, they had a moderate mental well-being. It also shows that higher the level of happiness, higher will be the mental well-being of the student. We had a study which supported my study, that is which was done with relation between mental health and happiness in Tehran youths. It showed that happiness is directly proportional to the mental well-being. And gender, number of subjects were associated with the level of happiness. We also have a study conducted by Chinese students to support gender arrears and health issues associated with mental well-being of the students, and among all the factors, variables, only age had a correlation with the level of happiness and mental well-being. The research delimitation was data collection 3. Thank you.
Thank you, Ms. Sharika Nayak. As we know that the students are the pillars of the future, as mental well-being of the students is a very important component to establish their academic outcome as well as the life outcome as such. It's a good study which has been taken up. I just have one thing. As you have identified the mental well-being and level of happiness, and you found that most of the students were somewhat happy. As a research outcome as such, did you had any interest to develop any intervention for these students whom you find they did not happy with their academic performance or mental well-being was not good?
It is a part of my BSc project. I reported the study findings to the dean to show this result that students are not happy. So in future.
Thank you, Ms. Sharnet. Very good. Thank you. Is there any from the audience? You can raise your questions if you have anything. If not, we will proceed with the next session.
Now I call upon Ms. Suryakala S, Assistant Professor, Tagore College of Nursing, Chennai. Her study title is Study to Assess the Compliance and Reason for Non-Compliance to Lifestyle Modification Among Patients with Renal Calculi in Selected Settings in Chennai. Suryakala, now it's your turn, and proceed with title, Objectives, Methodology and Results.
Yes, ma'am. Thank you, ma'am, for giving this wonderful opportunity. Good afternoon, ma'am.
Good afternoon, ma'am.
My screen is visible, ma'am.
Not is shared, ma'am.
One second, ma'am.
Shall we share Suryakala?
Yes, ma'am. Yes, ma'am.
Can you able to see?
Yes, ma'am. Yes, ma'am.
Yeah, proceed with the title, objectives, methodology, and results. Okay.
Okay, ma'am. Thank you, ma'am. So the problems, my study was a study to assess the complaints and reason for non-complaints to lifestyle modification among patients with renal calculi in selected settings, Chennai. Next, ma'am. Objectives to assess the compliance to lifestyle modification among patients with renal calculi, to assess the reason for non-compliance to lifestyle modification among patients with renal calculi. Next, ma'am. So this is my conceptual framework. I have used Rosenstock's and Becker-Meinmann's health belief model. Methodology, research approach was quantitative in nature, and research design I've used is descriptive in nature. The settings was Deepam Kidney Stone Center and Nandini Hospital in Chennai. Next, ma'am. Sample, my sample size was 60 patients who have diagnosed to have renal calculi were selected. My inclusion criteria, male and female patients under the age group of 25 to 50 years, patient who underwent surgical management for renal calculi, patients with a recurrent renal stone, patients under medical management coming for follow-up. And my exclusion criteria, patients who are diagnosed at first time, patients who are coming for the first time follow-up, patients who are participated in pilot study. Next one, sampling technique was a non-probability sampling technique. Data collection tool. The data collection tool used in this study was structured interview schedule, and it consists of two parts. Part one consists of demographic data like age, gender, educational status, marital status, and section B, it consisted of structured questions to elicit information regarding the clinical history of samples with renal calculi, like at what age they have diagnosed, duration of their illness, family history, history of recurrence, duration of treatment, nature of treatment, and instruction whether they have received or not, and what are the other sources of information they have received. Next, ma'am. Next, ma'am. Hello? Hello?
You can proceed now, ma'am.
Yes, ma'am. My questions are categorized under food and fluid, bladder elimination, prevention of infection, and follow-up care. And the tool I have used was 4-point rating scale, which has never, rare, sometimes, and always. And the marks I have given are rated from 0 to 3. And the scoring and the interpretation, I've graded it like high complaints, moderate complaints, and low complaints. Samples were coming under more than 75% will they are adhering to high complaints, and 50 to 75% moderate complaints, and less than 50% low complaints. Data analysis and interpretation to assess the frequency and percentage distribution of demographic variable, and section 2 frequency and percentage distribution of clinical history of patients with renal calculi. Section 3, frequency and percentage distribution of level of compliance to lifestyle modification among the patients with renal calculi. Section 4, frequency and percentage distribution of reason for non-compliance to lifestyle modification among patients with renal calculi. And section 5, association of level of compliance to lifestyle modification with selected demographic variable of patients with renal calculi. And section 6, association of level of compliance to lifestyle modification with selected clinical history of patients with renal calculi. And this is the frequency and percentage distribution of demographic variables. So this table shows out of 60 samples, majority 80% of the samples were married, and majority 71.7% of the samples were employed. 43.3% of the samples monthly income was up to 10,000, and 38.3% of the samples were in the age of 25 to 30 years. And this is the frequency and percentage distribution of clinical history of the patients with renal calculi. 70% of the samples will come under second term recurrence. And next, this is the frequency and percentage distribution of complaints to lifestyle modification on various aspects. Like majority 66.7% of the samples were adhering high complaints to food and fluid, and 95% majority 95% of the samples were adhering to the prevention of infection and follow-up, and the 58.3% of the samples were adhering high complaints towards the elimination pattern. Frequency and percentage distribution of overall level of complaints to lifestyle modification among the patients with renal calculi. This is the result, overall result, like majority 66.7% of my sample are adhering to high complaints, and 33.3% of the samples were adhering to moderate complaints. Next, ma'am. None of them will come under low complaints. Next, ma'am. The samples had non-compliance to the following aspects of food and fluids, such as salt-restricted diet, avoidance of pickles and canned foods, restriction of fruits and vegetables, avoidance of fatty foods, organ meat and mushroom, limiting of coffee, tea and colas, drinking of 2 liters of fluid. The reason expressed where it's their favorite item and commonly preparing food at home, and it's tasty, so they can't leave it, and they're married. The result, there was no significant association between the level of complaints and demographic variables. Only there is a significant association between the level of complaints with marital status at to 5% level. The younger age group 25 to 30 years had high complaints comparing to others. Graduate and married persons are also had high complaints. There is no significant association between the level of complaints with selected clinical history like age of diagnosis, duration of illness and family history, history of recurrent renal calculi, duration of treatment, instruction received or not, and mode of instruction received, other sources of information. Next, ma'am. Discussion. The study findings gave an insight to the investigator about the complaints to lifestyle modification and the reason for non-complaints, which will help in further improving the moderate complaints to high complaints lifestyle modification for preventing the recurrence of renal calculi. So I have given pamphlets to improve the moderate complaints towards the high complaints by giving the pamphlets.
Ma'am.
Thank you, ma'am.
Thank you for your presentation. It was a nice presentation in need of an hour because you know that most of the adults are suffering with renal calculi nowadays.
Yes, ma'am.
I have few clarifications to be asked.
Yes, ma'am.
You have said that you have used it to structure the tool to assess the complaints as such. How did you
Yes, ma'am.
the reason for what was the tool used for reason for non-compliance, ma'am?
That was prepared by me, ma'am, under the following headings like food and once again, ma'am, like elimination, food and fluid, and their follow-up.
So was it a structured tool you have used to by whether it being conducted as focus group interview with the people who had non-complaints? As such, your result shows none of them had a non-complaints. Almost most of them had a moderate and high complaints. So
yes,
with whom you have for non-compliance, because your result shows none of them had a non-compliance as such. Then how
yes,
we will interpret the results that people already had a moderate complaints? Then how we could interpret the results with non-complaints? And
so I will help the moderate complaints samples to high complaints by giving by issuing pamphlets, because some of my samples have not received instructions, ma'am. They only received oral instructions.
Okay, ma'am. Was it a focus group interview to assess your non-compliance? Because the tool was not it was not a structured tool or which guided you to ask the questions. Because that was not projected as such, we were not aware of which tool was used.
Yes, ma'am. For compliance, I have used the tool was prepared by me based on the 4-point rating scale, like never, rare, sometimes, and always. And the questions were totally 29 questions, and it is based on the food and fluid, like are you avoiding they have to avoid canned foods and pickled. They have to restrict salt restricted diet, and are they taking 2 liters of fluid per day? So like that it will come under, ma'am. And in the bladder elimination, it will be like are they passing urine, or are they because most of my samples are graduates, so sometimes because of their busy time schedule, they will forget to they may forget to urinate. So the questions were under like that, ma'am. And prevention of infection and follow-up, like are they coming for follow-up?
Okay.
Okay. Was it clear, ma'am? Yes, ma'am.
Am I audible? Am I audible?
Yes, ma'am.
Yeah. See, you prepared the tool by yourself, isn't it?
Yes, ma'am.
Have you checked any reliability, validity?
Yes, ma'am. We have checked, ma'am. The tool has an internal consistency and reliability coefficient Cron BATS alpha of 0.7025 for its 29 items, and the tool was reliable, ma'am.
Okay. You got the information orally from the student. Am I right?
What, ma'am? Yes, ma'am.
You got the information orally from the students.
This is not from students, ma'am.
From who is a study participant? Patient.
Renal calculi patients, ma'am.
Renal calculi patient.
Yes,
you have got the information. Yeah, that is, you got the information orally.
No, ma'am. It's a structured interview schedule, ma'am. I prepared a tool.
Yeah, that's why the structured interview schedule only you used. You asked how much their fruits, how much vegetable they have taken, like these type of question also there, no, in your tool.
Yes, ma'am.
Yeah. So that how you measured how much food, how much fruits, how much vegetable they are taking per day, how you measured, what is the reliability of their answer, reliability of their response?
Actually, shall I read one of my question, ma'am, so that it will be easy for understanding, ma'am? So, like my questions are.
Yes, tell me.
Regarding food and fluid, my first question is why you are not taking salt restricted diet every day, and this is for non-compliance reasons, ma'am. The first option is taste, preparing common food for all, and C is taking outside food, or while attending function. If any other means specify. And the second is why you are not avoiding pickles and canned foods. There will be options. First one is favorite food, and second one is taste or unable to change my habits, and third one is time saving and easily available, and fourth one is any other specified.
You got content validity from any urologist?
Yes, ma'am. Deepam Hospital, ma'am.
No, I am asking you got the content.
Yes, ma'am. Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Nursing JIPMER to moderate the session.
So now I invite Ms. Mahalakshmi, tutor, Tagore College of Nursing, to present a paper on
Yes, ma'am. Good evening, ma'am.
present about statement of problem, objectives, methodology, and result. You can proceed, Ms.
Okay,
Mahalakshmi.
ma'am, please share my PowerPoint, ma'am. Good evening, ma'am.
Good evening, ma'am.
Thank you, ma'am. My study was effectiveness of balloon blowing exercise on respiratory parameters among tobacco smokers in selected community, Kanjipuram, Tamil Nadu in India. My objectives was assess the pre-interventional respiratory parameters of tobacco smokers in control group and steady group. Second one, evaluate the effectiveness of balloon blowing exercise on respiratory parameters among study group. Compare the third one, compare the pre and post test respiratory parameters of tobacco smokers in control and steady group. Fourth one is association of post test respiratory parameters with the selected demographic variables in the study group. Next, ma'am. Hypothesis. The hypothesis one is the mean post-test respiratory parameters score of the study group is statistically significant than the mean post-test respiratory parameter score of the control group. Hypothesis 2 is there is a statistically significant association between post-test respiratory parameters with the selected demographic variables. Next, ma'am. Next, see about the research methodology. My research approach was quantitative evaluative research approach. Research design was an experimental design, post-test randomized control group design, and then research setting is the study was conducted at the Kadumbadi and Pelmaleri villages. Next, ma'am. The population among my study group under that 30 to 60 years of male adult who are scored above 3 in the Fagerstrom nicotine dependence test scale. Tobacco smokers only I was taken. The sample and the sampling techniques and the sample size were group 1 is taken in the Kadumbadi village, that is control group. Under that 66 samples, and then Perumalleri itself I was taken study group 66 samples. The sampling technique was I was used a purposive sampling technique. Next, ma'am. The inclusion criteria are males 30 to 60 years, tobacco smoking male, willing to participate, Tamil and English understanding persons. They are score of nicotine 3 and above. Next, ma'am. The exclusion criteria is history of chronic any respiratory disorders, diseases and cancer, oral ulcer, any cardiac failure patients, recent eye surgery, presence of acute disease process that might interfere with the test performance, that is nausea, vomiting, previous accidents or surgeries involved in thorax or abdomen. Next, ma'am. My tools are used for this questionnaire. It is under the demographics, smoking behavior assessment, tagged from nicotine scale, respiratory symptoms, and respiratory parameters. Next, ma'am. In that itself, this is the frequency and percentage distribution of the demographic variables. Most of the in the control group and study groups under the 40 to 49 years of age, and education in the control group itself, primary education. In study group itself, no formal education for them. Occupation itself, they are skilled workers under the control group and non study group. Next, marital status, most of them married in both. In socioeconomic background, they are under low middle class in the study group, and then in the control group, they are under the upper middle class. In the type of diet, most of under the non-vegetarian. In tobacco chewing habit also, in the control group, they are using the tobacco chewing, and in study group, they are not using the tobacco chewing. And then alcohol consumption, both in the control group and study group, is high in alcohol consumption. No, they are not taking the alcohol. Next, ma'am. The frequency and percentage distribution of the behavior, smoking behavior of the tobacco smokers. They are under the 15 years in the control group and above 15 years in the common in the study group. The duration of the smoking more than 1 year. They are comes under the both in the group. They are much. The number of cigarettes are 20 and above in both control group and study group. And then they are quitting attempts. One time is the common in both in control and study group. The methods of quitting attempts without intervention they are using. Only by the surroundings only they are using that. Next, ma'am. This is the effectiveness of balloon blowing. Sorry, that before that slide, ma'am. Fagerstrom nicotine dependence scale. Okay, ma'am. This one. Before this. Fagerstrom nicotine dependence scale. Before it, ma'am. Before one, ma'am. Yes, ma'am. This before small table, ma'am. Okay, no problem. Okay, no problem, ma'am. I will tell. Low to moderate is okay. We are divided by the using the Fagerstrom nicotine scale, low to moderate and high, ma'am. In that, low to moderate is more common, and in the moderate level, 51% in the control group, 45% in the study group, ma'am. Results, ma'am. Graphical representations. Okay, ma'am. This is the mean respiratory rate for the smokers. First one is the control group, and then second one is the experimental group. That is some variations in that. 27.97 in the pre-test and 26.67 in the post-test. This is the effectiveness of the balloon blowing exercise, ma'am. Next one. This is the main SpO2 rate of the smokers. This is included in the experimental group, 91.65 to 93.83, ma'am. Next one, ma'am. This is the mean breath holding time to the time of the smokers in experience group, 46.92 seconds to 60.20. Next one, ma'am. This is the mean axillary diameter of the smokers, that is 111.55 to 115.32. Some variations in that, ma'am. There some improvement. This is the mean zippoid diameter of the smokers. This is also 114.21 to 117.23. There is some variations. mean of the 10th intercostal region of smokers. Next, ma'am. That is also 121.21 to 124.27. This is the last one is the mean peak flow rate of the smokers. That was 155.30 to 202.27 in the post-test experimental group values, ma'am. Next, ma'am. Major findings of the study. Before slide, ma'am. Okay, ma'am. There was a significant improvement in the respiratory parameters among tobacco smokers who received the balloon blowing exercise in the experimental group. Next one is there was no significant association between the demographic variables except age, educational status, and occupation socioeconomic status. Next one, ma'am. The conclusions: balloon blowing exercise was found to be effective in improvement of respiratory parameters among tobacco smokers. The findings of the study revealed that there was significant improvement in the respiratory parameters among the experimental group after the balloon blowing exercise. Results revealed that the research hypothesis was accepted and the null hypothesis was rejected because there is a relationship between the balloon blowing exercise and the respiratory parameters among tobacco smokers. Next, ma'am.
Yeah, Miss Mahalakshmi, I think it is. No? Thank you for
yes, ma'am.
Yeah, thank you for your presentation. And I have some clarification to ask. So you have
Okay,
written in a sampling in this, and you have written randomized control design.
Yes, ma'am.
So how you have randomized the group into experimental and control? You have written purposive sampling technique. Then how you have randomized to experiment? What method you have used?
First, I was taken by using the Fagerström nicotine dependence scale, ma'am.
Yeah.
That is the standardized tool I was taken. First, I will take by that taken 66 for the control group and study group, ma'am. So I take 100 samples and then randomize and select the samples, ma'am.
No, I'm asking how you have randomized. What means what method you have used? Randomized means what technique you used for randomization?
Odd number, even number, ma'am.
Odd number, even number.
Even number. For the odd number for the control group and even number for the study group.
Can you explain about technique? How you have done balloon blowing? How many balloons? Any
yes, ma'am.
you have?
I was per day 2 times, ma'am. At a time, 3 balloons are given to the participant.
Yes.
Take a deep breath for 20 seconds. After that, blow the balloon, ma'am, for 1 minute. How they effectively blow?
So immediately you have assessed their post tester, like peak. You have said now.
Yes, ma'am. Peak flow rate, I will check it, ma'am.
Immediately after blowing.
No, ma'am. After it is consecutive 28 days, ma'am. I seen in the studies. So I take the 14 days, ma'am. 14 consecutive days per day 2 times.
Yes. Okay.
After 14 days completed, 15th day I take the post test, ma'am. Per day itself 2 times, ma'am.
Okay. Okay. So
1 time, 3 times.
If they are not able to blow 3 means what you have done for that particular sample?
In between, we give the, I gave time to 1 minute or 2 minutes. They take rest. After that, blow the second balloon. After that, only take the third balloon, ma'am.
So you have taken only that Fagerström some scale you said, na? That is a standardized.
Yes, ma'am. Yes, ma'am. Standardized tool, ma'am.
So only nicotine dependent patients.
Yes, ma'am.
Okay.
Nicotine dependence above 3 score, ma'am.
So only substance, nicotine or any other substance you have included?
Tobacco chewing only I was taken, ma'am. Sorry, tobacco smokers. In that itself, nicotine dependence, because they are mostly nicotine dependence only. They are having the respiratory disorders, no, ma'am. So only I take that, ma'am.
So in the tool you mentioned structured questionnaire, but you have used oxygen, that pulse oximeter, that
yes, ma'am.
These and all biophysiological measures, no?
Yes, ma'am.
So that you have not mentioned that about the reliability of this pulse oximeter, everything.
Yes, ma'am. I already checked the reliability of the commonly used SpO2 parameter, ma'am. So only I check it for the 100 members in the regular management, and then commonly used only one, ma'am, for the both control group and study group. And then I use the peak flow rate for both group, but I give the mouthpiece each person separately, ma'am. Use on through mouthpiece.
Okay, Ms. Mahalakshmi, thank you for your presentation.
Thank you, ma'am.
Now I request Mrs. Usha, Associate Professor, Shri Siddhaganga Institute of Nursing Sciences and Research Center, Tumkur, to present a study on to evaluate the effectiveness of video-assisted teaching program and knowledge regarding hazards of open air defecation among women in selected rural community at Tumkur. Mrs. Usha, you can proceed with your presentation. She's there. Madam Usha, are you there? Madam Usha? Madam Usha? Madam Usha? Madam Usha?
Maybe she is not responding. Can we go for the next person?
Yes,
Roy?
sir. Yes, sir.
Sorry,
Yes.
I am not supposed to interfere. I am just suggesting.
Yes.
Very good evening to one and all. Now I am glad to invite Ms. Dania. Present the paper, study title for that randomized control trial to compare the effectiveness of urinary catheter care protocol on prevention of urinary tract infections among
Hello. Hello.
ma'am.
Hello.
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 Am I audible, sir?
Ms. Tanya, are you on the line? Ms. Tanya, are you on the line?
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah, go ahead.
Hello.
Yeah.
Yes, ma'am. Hello.
Proceed, my dear.
Ma'am.
Am I audible, ma'am?
Yes, you are audible.
Start to present, ma'am.
Okay, so I am going to present my paper presentation. A randomized control trial to compare the effect of two urinary catheter care protocols on prevention of urinary tract infection among patients with urinary catheter admitted in intensive care units of GGS MCH Faridkot, Punjab. So my objective with protocol A that chlorhexidine and normal line. Forwarding and normal line and protocol B among catheterized.
Then result you can present, ma'am.
Madam, are you there?
Yes, ma'am, I'm there.
Yeah, we are not able to hear. Are you
Yes,
presenting?
ma'am. Actually, due to some internet connection, I'm unable to pursue. Now I'm hearing.
Yes, ma'am. Start.
You can proceed only with objectives, methodology, and result. Only that is enough.
Forwarding 19 and normal line and protocol B line on incidence of UTI among catheterized patients in intensive care units. My intensive care units of GGS Hospital, Faridkot. Population of the study the variables which are used under the study are and poverty iodine.
Hello. Madam Tanya.
Yes, ma'am. Due to some technical issues, I am unable to show my slides. Can you please show my slides?
Yes, we'll do it. Wait a second.
Yes. Okay. Ma'am, I am continuing with the research design, which includes variable under the study.
Start to present, ma'am.
So a diagram of research design, first is research approach, that is quantitative research approach. Then next one is research setting, that is intensive care units of GGS Hospital Freeport. Next one is population of the study, which includes catheterized patients admitted in intensive care units. And next one is sample and sampling technique, that is sample size is 78, include catheterized patients only. And the sampling technique was purposive sampling technique. And the next one are the variables under my study are independent variables, which include chlorhexidine with a normal line and povidone iodine with a normal line. And my dependent variables are incidence of UTI. And the next one is the tool. My first tool is sociodemographic variable. Second one is the clinical profile. Tool 3 is the urine microbiological analysis. Tool 4 is urine culture reports. And tool 5 is UTI clinical sign assessment checklist. So criteria which measures includes pus cells, epithelial cells, RBCs, other abnormal cells, and type of organisms. So my first objective was to compare the incidence of UTI among patients receiving catheter care with protocol A, that is povidone iodine and normal saline, and protocol B, that is chlorhexidine and normal saline. So I compared both of the group first povidone iodine with normal saline and group 2 with chlorhexidine and normal saline, and the sample was 39 in each group. So if we look out for the growth, so the in group 1 which include povidone iodine and normal saline, 31.4% of the people who is having the incidence of the UTI. So if we talk about the patients who is having no growth, so it includes group 2, that is chlorhexidine and normal saline, in which 91.4% of the population having free from the incidence of UTI. So this is the comparison. I have taken maximum 3 days and minimum 15 days. So I compare the data between the protocol A and protocol B in 12 days from day 3 to day 15. So I took the sample on day 3, day 5, day 10, and day 15. So if we compare the data, so in all the days, the protocol A having incidence of UTI is high as compared to protocol B. And my second objective was the assessment of the effect of protocol A, povidone iodine and normal saline, and protocol B, that is chlorhexidine and normal saline, on incidence of UTI among catheterized patients in intensive care units. So this is the values. A total difference in UTI incidence in catheter care protocol A and catheter care protocol B. That is, number of days are from day 3 to day 15. Total number of days are 12, and the sample taken is 99 in both the group. So by calculating chi-square, my value is 7.461, and the p-value is 0.006, means my value is significant. So discussion related to first objective. In my study, the entire period of 12 days from day 3 to day 15, the incidence of UTI in catheter care protocol is 15.4%, were less as compared to catheter care protocol A, that is 43.6%. Hence, it is concluded that there was less occurrence of UTI was in catheter care protocol B as compared to catheter care protocol A. So there was 59% reduction in 40 incidence. So I compared this with the Plowman that is submitted a report on incidence of UTI. This report states a urinary tract infection are the most common infection acquired in the hospital and long-term care facilities. Moreover, the study estimated the incidence of healthcare associated UTIs is around 2 to 3% per 100 admissions. And my studies related to the second objective is, in my study, the incidence of UTI was significantly different in catheter care protocol A, that is 14.6%, and catheter care protocol B group, that is 15.4%, with a chi-square value of 7.461 and p-value of 0.006. Hence, it is concluded that the catheter care protocol B, that is fluorhexidine and normal saline, was more effective than catheter care protocol A, that is povidone iodine or normal saline, in preventing the incidence of UTI when compared during the period of 12 days from day 3 to day 15. So the study through which I correlate my second objective is the results reveal that the number of cases of catheter-associated asymptomatic bacteriuria for 100 catheter days was analyzed and found to be effective in reducing the catheter-associated urinary tract infection of 67% in chlorhexidine and 33% of normal saline. So the conclusion of my study is the study result shows that catheter care protocol B, that is fluorhexidine and normal saline, was more effective in reducing the incidence of catheter-associated urinary tract infection. Clinically, there is a significant reduction in the rate of UTI in catheter care protocol B, that is fluorhexidine and normal saline group. And statistically, there was a significant difference between the both povidone iodine and normal saline versus fluorhexidine and normal saline in reduction of urinary tract infection. So chlorhexidine can be recommended for the urinary catheter care in clinical practice, which help for evidence-based practice as well as it is also cost-effective. So the study findings agree with various other similar studies conducted. Thank you.
Thank you, ma'am. You are presented well, ma'am. I'm having one doubt, ma'am, that you didn't mention that ratio of the dilution, ma'am. They both chlorhexidine and betadine solution. It's normal solution.
Okay. Yes, sir. I have used, sir. I have used 30 ml of povidone iodine and 50 ml of normal saline, and same ratio in the catheter care protocol B. 30 ml chlorhexidine and 50 ml normal saline.
Okay, ma'am. Current according to the CDC recommendations, currently this practices are used. Current status.
Yes, sir. These practices are used. Yes, sir.
In your hospital, ma'am?
This is used in the, I'm currently working in the Sangha hospital as a nursing superintendent. So here we are using these protocols.
Okay, currently that no catheter care is given specifically, ma'am. Just through soap and water wash only is recommended, no? That's why I'm asking doubt, ma'am.
Sorry, sir?
Currently, they are washing the catheter soap and water. The routine through the routine care they used to give. Special catheter care is nowadays no areas given, ma'am.
Sir, I'm not getting your question.
He is telling that nowadays they recommend that not to use any solution while taking bath itself.
But ma'am, if we are talking about the patients who are on ventilators and who are sick patients, so the secondary infections or hospital-acquired infections are very prone in the hospital areas. So according to me, it is necessary to use the solutions for cleaning the catheters and urinary area.
Okay. Thank you, ma'am.
Thank you for your presentation.
Okay, ma'am. Thank you, ma'am.
First, Madam Usha.
Yes, ma'am. Can you hear me, ma'am?
Yeah. Yes, madam,
you.
you can present.
Yeah, thank you, ma'am. Thank you, organizer, for giving me an opportunity to present my study. Statement of the problem. A study to evaluate the effectiveness of video-assisted teaching program on knowledge regarding hazards of open air defecation among women in selected rural community areas at Tumkur. Objectives: to assess the knowledge regarding hazards of open air defecation, to evaluate the effectiveness of video-assisted teaching program on knowledge regarding hazards of open air defecation, to find the association between the pretest level of knowledge with selected demographic variables. Hypothesis: there will be significant difference between pretest and post-test knowledge scores regarding open air defecation among women. And hypothesis 2, there will be significant association between pretest level of knowledge with selected socio-demographic variables. Conceptual framework, I have used Imogen King's goal attainment model and methodology, research design. Ma'am, am I audible?
Yes, madam. Yes, madam. Proceed.
Research design, pre-experimental, one group, pre-test and post-test design. And this is the research methodology or schematic representation. Selected rural communities at Tumkur was the setting, and women's are my samples. And purpose of the study is to find out the effectiveness of video assisted teaching program on hazards of open identification. Research design, one group, pre-test, post-test. Pre-experimental research design, sample size was 100 women, and their knowledge was assessed before and after the video assisted teaching. Sampling technique was non-probability convenient sampling. Step 1, so structured interview schedule was prepared and video assisted teaching was prepared, and content validity was done by experts, and the content and tool was tested for their reliability, and pilot study was conducted. Step 2 was administration of video assisted teaching, and step 3 procedure for data collection. And data analysis was done with descriptive and inferential statistics. And variables, independent variables is video assisted teaching program. Dependent variable is knowledge score, and socio-demographic variables are age, education, occupation, marital status, religion, monthly income, latrine facility available, source of knowledge regarding hazards of open air defecation. So results we have organized under 3 headings. Section 1 deals with frequency and percentage distribution of socio-demographic variables. In that, majority of women, means 29% were between the age group of 26 to 30 years, 71% were married, 76% were belongs to Hindu religion, 35% were studied up to high school, 56% were homemakers, and 49% were having family monthly income of above 3,000. And 64% of the women were practicing open identification, and 76 were not having any previous information regarding hazards of open identification. And analysis of pre-test and post-test knowledge on hazards of open identification among women, it shows that. So in pre-test, so none of them has adequate knowledge. 70% of them was having moderately adequate knowledge, and 30% of them were having inadequate knowledge. And this is the overall post-test knowledge, means 61% of the women has adequate knowledge, and 39% of the women had moderately adequate knowledge after post-test. And analysis of effectiveness of video assisted teaching program. So it shows that there is a significant difference between pre-test and post-test knowledge score of women regarding hazards of open air defecation. So therefore research hypothesis as accepted, because we can show here, we can see here mean difference was 34.42 with standard deviation of 2.875. And so association of pre-test level of knowledge with socio-demographic variable, if we see. So selected socio-demographic variables such as religion, occupation, and family monthly income was not significant with the pre-test level of knowledge. And this age, marital status, education status, latrine facility, and source of information regarding hazards of open air defecation having significant association with the pre-test level of knowledge. And data reveals that discussion. Data reveals.
We can skip this and move on to conclusion.
Sure, ma'am. Sure. Conclusion. Overall mean knowledge score of pre-test was 16.33 and post-test was 34.42 with standard deviation of 4.44. So that's why it shows that there will be significant difference between pre and post-test knowledge score of women regarding hazards of open air defecation. So video assisted teaching on hazards of open air defecation among women was effective. Thank you.
Thank you, madam, for your presentation.
Yeah, sorry for the inconvenience, ma'am.
No problem, ma'am. When you have done your post-test, ma'am?
Ma'am, after 8 days of video assisted teaching, ma'am.
So that means a video assistant means that video you have means you have shooter you have developed, ma'am, or already available sources?
No, ma'am. Actually, I have prepared, ma'am. Even we have conducted the interviews, some interviews of women who were practicing this open air defecation, and even what are all the problems they have faced. So all those we have shooted, ma'am. And with that, even we have prepared, I have prepared PPT that I used to present, especially where the self-help groups of women are there.
Okay, only PPTs or some videos you have shown? Or?
Yeah, ma'am, PPT with video. I have shooted the video, ma'am, interviews with the women who are practicing this open air defecation. Ma'am? Ma'am? Ma'am, am I audible? Ma'am? Am I audible, ma'am?
Madam Usha?
Yes, ma'am. Am I audible, ma'am?
Yeah, can you hear me, ma'am?
Yeah, ma'am. I can hear you now. Please, ma'am. Yeah. Ma'am, any more question? I cannot able to hear you, ma'am. Now? Ma'am? Ma'am, I can't able to hear you, ma'am.
Now can you hear me?
Yeah, now I can hear you, ma'am.
Madam, one small clarification that have you added temporary residents of that particular area, Tumkur? Like
no, ma'am. No, ma'am. It is a community area. We have taken permanent residents, ma'am.
Okay, that you haven't included your exclusion criteria, madam. Okay, thank you.
Yeah, ma'am. Yeah, ma'am. Thank you, ma'am. Thank you very much.
Clarification, ma'am.
Yeah, please, ma'am.
Have you validated this video?
Ma'am? Yes, ma'am. Yeah, ma'am. Even videos we have sent for the experts, ma'am. Sociologists, even community medicine specialists. For them, we have sent the video after validation only, and even whatever the content we are going to add into the video and PPT, that also we had made, ma'am. And even PPTs also and videos we had sent them, ma'am. After validation, we have presented this.
And it would be better if you would have checked the practice whether it has changed after the knowledge has enhanced because of
yes, ma'am. Yes, ma'am. We are having planning because now even after Swachh Bharat scheme, still they says that through WHO and UNICEF, 15% of the people are still practicing that. We are having idea to continue with practice, ma'am.
Can you please justify why it was selected only the sample from women? Why the other gender was not included? Could you please justify the why it was targeted on women?
Yeah, ma'am. Actually, women are the one who will be like having control on all the activities. If women are educated, actually, this is mainly a teaching program. If we teach the women, that will be better for whole family. To change even the knowledge and practice. That is the reason why I have selected the woman, ma'am.
I feel better if both the people gender included because the financial management is being managed by
yeah, sure, ma'am, sure. Next,
the others will use automatically. I think that it would be better if you would have included both this gender.
Yeah, sure, ma'am. I will look into it, ma'am.
Thank you, ma'am. Thank you,
Thank
Usha,
you.
for your presentation.
Thank you very much, ma'am. Thank you.
Next, I will call Professor Mrs. M. Manimegalai, MSc Nursing Vice Principal, VB Panniya Perumal Nursing College. The title is for assessing the knowledge and attitude on cervical cancer among the middle-aged women who is attending the OPD in the Aruppukkottai Government Hospital. Can you present the paper, ma'am?
Yes. Good evening to all. Thank you for this platform. Am I audible to all?
Yes, ma'am, audible.
My title of the study, a descriptive study to assess the knowledge and attitude on cervical cancer among middle-aged women who are attending outpatient department in selected government hospital. Objectives to assess the knowledge regarding the cervical cancer among the middle-aged women, to determine the attitude towards cervical cancer among the middle-aged women, to correlate the knowledge and attitude of cervical cancer among the middle-aged women, to find out the association between the Yes, yes, sir.
Share your slide, ma'am.
It is not moving. Slides are not moving.
Now, sir.
It's not moving. Same slide only is there.
Try to share it again. Try to share it again. Stop sharing and try to share it again. So it will work.
Yes, sir. Now.
Yes, it's working now. Your voice is clear. You can start now.
Yes, sir. So now is it visible? Yes, sir. Now is it visible?
Yes, ma'am. Can proceed.
Yes. A descriptive study to assess the knowledge and attitude on cervical cancer among middle-aged women who are attending outpatient department in selected government hospital. Objectives: to assess the knowledge regarding the cervical cancer among the middle-aged women, to determine the attitude towards cervical cancer among the middle-aged women, to correlate the knowledge and attitude of cervical cancer among the middle-aged women, to find out the association between the knowledge of cervical cancer among the middle-aged women with the selected demographic variables like age, marital status, educational status, occupation, family income, religion, history of cancer in family, age at menarche, frequency of menstruation, duration of menstruation, and experience of symptoms. The last, to find out the association between the attitude of cervical cancer among the middle-aged women.
Excuse me, ma'am.
Yes, sir.
Change this slide and talk, ma'am. Change the slide.
Slide is not moving, ma.
Yes, sir. Yes, ma'am. Yes, ma'am. So now is it visible, sir?
Yes, ma'am.
Yeah,
Go to the slide share, ma'am.
Yes, methodology, sir. Is it visible, sir?
Yes, ma'am. But
Yes.
methodology, the objective slide. Next slide.
Okay. Yes, sir. Is it visible, sir? Sir,
Just say next. Okay, is that okay?
is it
We'll share the content.
Okay, sir. Okay, sir. I can give stop, sir. Sir, can you share for me, sir?
Okay, ma'am. Start to present, ma'am.
So it's not, yes, sir. So methodology of my study, the quantitative research approach was used for this study. The non-experimental descriptive research design was used for this study. The setting of this study was government hospital, which is located in center of city. It is 250 better National Accreditation Board for hospital, and daily around 60 to 80 females are coming to the female outpatient department and non-communicable disease department. The next slide, sir. The population of this study was women who are between the age group of 40 to 55 years attending an outpatient department at government hospital. The sample consisted of 50 middle-aged women who are attending the outpatient department at government hospital. The purposive sampling technique was used for this study. Next. So next, sir. Next slide, please, sir. The next slide.
Yes, ma'am.
Yes, criteria for sampling selection, inclusion criteria, Women who are willing to participate in this study, available during data collection, able to understand Tamil and communicate easily. Exclusion criteria: women who have undergone health education previously regarding cervical cancer, who have undergone checkup previously, and who are severely ill or sick. Next slide, sir. The description of tool. The tool consisted of 3 parts: part 1, part 2, and part 3. Part 1 consists of demographic variables and personal data like age, marital status, educational status, occupation, family income, religion, age at menarche, duration of menarche, and experience of symptoms like excessive vaginal bleeding, bleeding between two. Sir, previous slide, sir. Sir, previous slide, please, sir. Excessive vaginal bleeding, bleeding between 2 periods, leg pain or back pain, excessive white vaginal discharge, pain during sexual intercourse, history of cervical cancer. Last demographic variable, history of cervical cancer in family. Part 2 consists of structured interview schedule, was used to assess the knowledge among middle-aged women regarding cervical cancer. It consists of 25 questions to record the knowledge regarding cervical cancer. And part 3 consists of 5-point Likert scale to assess the attitude of cervical cancer. The attitude question consists of 10 items with agree, strongly agree, neutral, disagree, and strongly disagree. The next slide, sir. Scoring procedure. Part 2, the structure interview schedule had 3 responses. The right answer was given 1 and wrong answer was given 0. The total attainable score of knowledge questionnaire is 25. The total score was converted into percentage and the resulting score was interpreted as adequate knowledge about 75%, moderate knowledge between 50 to 75%, and inadequate knowledge below 50%. The next is the 5-point Likert scale had 10 previous. With 5 responses, and attitude based scoring was classified as positive attitude above 75%, neutral attitude between 50 to 75%, and negative attitude below 50%. Then, sir, excuse me, sir, previous slide, sir. Sir, previous slide, please, sir. Sir, excuse me, sir. Previous slide.
You can skip that and you can move on to result part.
Okay, result. The first objective of this study was to assess the knowledge on cervical cancer. So the study findings showed that knowledge of cervical cancer among the middle-aged women, nearly 60% middle-aged women are having inadequate knowledge. 38% of middle-aged women are having moderate knowledge, and 1 women have adequate knowledge. The next slide, sir. So the attitude scoring. Next slide, sir. The attitude scoring, none of the women middle-aged women was having positive score, sir, positive attitude, and the middle only 12% of, sorry, sir, previous slide. Otherwise, I will go to conclusion part, sir. 12% of middle-aged women are. So the third objective was to find out the correlation between the knowledge and attitude of cervical cancer among middle-aged women. So it was referred that there is a significant relationship between knowledge and attitude of cervical cancer among middle-aged women. And there was a significant last objectives of my study, knowledge and attitude with demographic variables. So it is referred that there was a significant relation, even association between the all demographic variables with knowledge and attitudes. So to conclude my topic, last conclusion. So this study only 38% of women are having moderate knowledge, and 60% women are having inadequate knowledge, and only 2% of women having adequate knowledge, and none of the women, no one is having positive attitude. So 12% of women are having neutral attitude, and there was a significant association between the all the demographic variables with the knowledge and attitude score. Thank you, sir.
Thank you, madam, for your presentation. Then why you have restricted sample to only 50? Because I think OPD many women will come. Any reason for restricting your sample size to 50?
Ma'am, I did like a mini project. That's why I restricted it to 50 samples. Ma'am, based on these findings, definitely in future I will increase the sample size.
Excuse me, ma'am, one more clarification.
Can
Yes,
you just
ma'am.
tell whether it is a structured questionnaire or a standard questionnaire you have used for assessing the knowledge on cervical cancer and attitude?
Ma'am, only I prepared the tool, ma'am, with a consist of 25 questions, ma'am. It is a semi-structured questionnaire only, ma'am.
Regarding attitude, ma'am.
Attitude for 5-point Likert scale, ma'am, which consists of 10 statements, ma'am, and I categorized as agree, strongly disagree, neutral, and disagree and strongly disagree, ma'am. 5 categories I have given, ma'am.
Please just to describe whether it's attitude on cervical cancer in the sense, or whether it is related to treatment or accessibility to treatment.
No, ma'am. It's generally, ma'am. It's generally focused on how they think about cervical cancer, like it is a communicable disease or it is a hereditary disease, and regarding HPV vaccine, whether vaccination cures cancer, or whether their willingness to come for cervical screening, like that I have made the statements, ma'am. 10 statements.
Coming for cervical cancer is okay, but whether it is a disease or something, some questions reflects knowledge. Can you just say the questions in attitude, whether it really reflects the attitude of women on cervical cancer? Can you just say that?
Yes, ma'am. Because definitely the knowledge, if knowledge is improved, definitely the attitude also will be improved, ma'am.
No, ma'am, I'm not asking regarding the correlation. Can you just take one tool so that we can see whether it really reflects the attitude?
Ma'am, I'm not able to get you, ma'am. Can you please repeat, ma'am?
Can you hear me, ma'am? Am I audible? Can you just take? Am I audible to you, ma'am?
Yes, ma'am. Yes, ma'am. Tell me, ma'am.
Can you just say one or two attitude items on attitude?
Yes, ma'am.
Reflects the real attitude on cervical cancer. Can you just say one or two items?
Yes, yes, ma'am. Yes, ma'am.
Your tool.
Wait a minute. Hello. Hello.
Yes, ma'am. You're audible.
Yes, ma'am.
Can you just give examples or what are items you have included in your attitude scale?
Yes,
one
ma'am.
or two items can you read out?
Cervical cancer is a communicable disease, ma'am. 40 to 55 years of women risk for cervical cancer. Cervical cancer is a hereditary disease. Cervical cancer is caused by sin, and viability test is needed for all women.
Yes,
Yes, ma'am. These are the questions.
It looks like a knowledge question. Doesn't reflect the attitude as such, isn't ma'am?
Yes, ma'am. Yes, ma'am. But some of the questions
like non-communicable, this is the knowledge aspect. Doesn't reflect the attitude on cervical cancer.
Yes, ma'am. Yes, ma'am. Yes, ma'am. I understood, ma'am. I understood.
So
And some of the
that is why you're saying if you are taking and stand purpose.
Yes, ma'am. Yes, ma'am. Yes, I understood, ma'am. I have to select based on the attitude question, isn't it, ma'am?
Okay. Thank you, ma'am, Manimegale, for presenting your paper.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Mr. Ferisami sir for moderating the session. Now we have come to the end of the scientific paper presentation session. Now I'll hand over the session to Angel ma'am for validation.
We've come to the end of our 6th CNE webinar on oncology nursing. Like we had the resource person across the globe sharing their expertise with us. Like we were enriched with their presentations. That was really mind-blowing presentation which we had for the past 2 days. Like with this in this evening, it's a real time of experimentation. You never want to look the same way. Let me analyze that whether we are the same as we came into this webinar or this has made an impact on our knowledge. Okay, now coming on to the validatory function. Now I request Dr. M.J. Kumari, Professor cum Principal Acting, College of Nursing, JIPMER, to give the welcome address.
Thank you, Dr. Mrs. Angeline.
Yes, I delight to welcome the dignitaries speaker from abroad, Dr. Mariam, Dr. Vasanta Kumari, Dr. Martha. So everyone, they are presented, their topic is excellent way and the informative way. So thank you for all your support. The internal speakers, Dr. Suresh Sharma and Gopi Chandran, Riksha and Priksha also, they are Ruchika and Riksha also, they did their job well. The internal participant, our JIPMER faculty, Dr. Biju, Dr. Smita, Kumar, Mr. Ramesh, Dr. Lakshmi, Dr. Vetishelvi. So all the speakers, they did their job in the excellent way. They put maximum effort to prepare the content and they are enrich our participants. I thank all the participants for your elaborated, wonderful presentation and thank for the Ramesh also still on the line. Throughout the past 2 days, they are attended all the conference, they observed the full session in detail. Thank you so much. I thank our, welcome our faculty and thank our faculty team for the young and energetic faculty members with Ento, the kind cooperation and timely help, timely management. The team effort is made this program successfully. I welcome you all and my dear students, especially for the MSc second years, I welcome you all for this validatory function. Thank you.
Now let's hear to the report of the webinar by the organizing secretary, Mrs. Padmavati Nagarajan, the Assistant Professor, College of Nursing, JIPMER.
Good evening to one and all. College of Nursing, JIPMER conducted 6th CNE webinar on oncology nursing with the theme current updates on oncology nursing for effective patient care. MC for this conference. So all over we had 233 registration and apart from that we had 17 speakers national and international and 28 paper presentations were there and the pre-test course, the item analysis is shown and there is a comparison between pre-test and post-test scores. There is approximately 20% increase in the score from the mean post-test. So all participants nationally and internationally actively participated.
Thank you, ma'am, for your report. Having been with us for 2 days with the mind packed with the resources from our experts, now we would like to hear your feedback.
Hello.
Give a feedback on our webinar. Like you can give us suggestions that we would like to make changes for the future webinars.
Any of the participants, can you give your feedback about our conference? Any participant?
Good evening to all. Yes, ma'am. Am I audible, ma'am? Yes, ma'am. Am I audible?
Yeah, yes.
On the whole, ma'am, 2 days I observed a 2-day session, ma'am. So the session was very informative and useful for us, and recent technologies also we learned. And regarding paper presentation, I could see different categories of paper presentation, and all the session was very useful, including scientific paper presentation, ma'am. And bottom of the heart, I express my sincere thanks to all the organizers of JIPMER. And in future, you can include other specialty topics also, ma'am. And regarding that time, little bit we felt some of the inconvenience in arranging that time only, ma'am. Thank you so much for this session. Thank you, everyone.
Thank you.
Thank you for the feedback, ma'am.
Yeah, anybody? Yes, Dr. Ramesh, you want to give any feedback? Ramesh Shanmugam.
Yes, ma'am. Yes, ma'am. I want to give some sharing my experience regarding about the conference. Okay, thank you for giving this opportunity to give the presentation about the feedback about the conference. Actually, a warm good evening to one and all. I am very glad to be here to say the heartfelt thanks to organizing team in the JIPMER. It's my gratitude to my narratieful and warm thanks to eminent leader Dr. M.J. Kumari, organizing chairperson JIPMER and their team. Actually, I have some of the comments about the conference. Some of the key points I know down there regarding the past 2 days I was attending there continuously. First of all, the selection of conference title is really wonderful and as well as an excellent one. And really it's updated. Actually, the need for updation of our nursing professions. So it's one of the amazing aspects. The second one is the quality of internet from throughout the beginning to the end of the conference past 2 days is wonderful. Even without disturbance, is maybe a continuity of the conference proceeding. Next one, the sequence of the content really is step by step or systematically, orderly. They arranged for the speakers, continuity of the understanding of the participants regarding the conference titles. And the next one is a resource persons or speakers. They arranged from the different developed and developing countries. That's also is one of the important for the part of the arrangement of the speakers related to the title and suitable of the experienced aspects. Why is very important for that means actually somehow this is already developing. Sorry, is already for the cancer related title. Even still how much experience you have, also still you have the lack of knowledge because of our actually nursing. Actually the medical profession is developing lot of technological changes will be there in the part of the treatment as well as management aspects. That's why it's maybe have the up and down will be there for the field of medical. So different country or different exposure of the exposed people in different country, they are sharing the part of experience in the international webinar. It's really is useful for the participants. So is in that aspects, I'm really is amazing to the organizing chairperson to arrange this type of the point aspects. Next, again, they are given that challenging for the participants and stimulation manner. They are included for the pre-test and post-test assessment. Is really is stimulation. Is one type of the stimulation. Their knowledge level. That's one. What is wonderful. And next one is the. It's also is allocated for the licensed way of the conference with help of the Tamil Nadu Nursing Council for the credit hours also. This is really is most useful for the participants as well as the speakers and whoever may be. And the next one is the and the next one is the speakers, those who are participated here. They are really is a wonderful presentation. And as well as they did for their hard work, and as well as they are share their originality of their life experience, they bring it out and they are present in the conference. Really hands up all the eminent speakers from the different country wise. And finally, really I'm appreciating Dr. M.J. Kumari and their team. They're done well, dedicated, organized in the part of the conference, and we wish you all the best and success. Furthermore, they want to continuity of the conducting the international conference as like in a different titles and different exposure. It's may helpful for our profession to enlightening the all aspects of the quality of care and patients aspects. So thank you, madam. Thank you so much for once again for did well, and overall is excellent organization of the conference activities. I'm really is blessing for the JIPMER
team, those who are in behind that, helped for really proceeding of this conference. Thank you so much for given this opportunity to give the feedback about this.
Thank you.
Thank you, sir. Thank you so much. Any other feedback?
Any participant want to give the feedback about the conference? Okay, shall we go for the next?
Okay, having heard about our feedback about the webinar, now this webinar cannot end without a word of thanksgiving. Like the wheel was started rolling when it started a planning, when it was initiated. Like it is the team effort which has been made and the effort of the organizers, the chairperson and the secretary. Now I would now call upon Mr. R.S. Ramesh, Assistant Professor, College of Nursing, JIPMER, to propose the vote of thanks.
A warm good evening to everyone. I am really privileged and happy to propose a webinar on oncology nursing. First of all, I like to thank our director, Dr. Rakesh Agarwal, for his inaugural speech, Dr. Ravi Kumar Chittoria, Acting Dean Academic, and Dr. G.K. Paul, Acting Dean Research, for their felicitation. We'll be ever thankful heads as they are very helpful in conducting these regular workshops, seminars, and webinars. And importantly, I like to thank Madam Dr. M.J. Kumari, Professor cum Principal and Organizing Chairman for this webinar. Doubts anyone has, she is very patient to give clarification then and there. Really appreciate her energy. I don't know where she gets this much energy to carry on the housework at the home. Then conducting these webinars is not an easy thing. I think for the past 3 months, you would not even slept properly. We thank you, madam. We thank the organizing secretary, Dr. Padmavati Nagarajan, for all the efforts taken to complete this webinar. We thank all the participants and resource persons and the paper presenters. So namely, we like to thank Dr. Preksha Sharma, Dr. Suresh Sharma, Dr. L. Gopichandran, Dr. Smita Koyal, Dr. Vasanta Kumari, Dr. Ramesh Shanmugam, Dr. Mathar Mohideen, Mrs. Gomati Munusami, Dr. Lakshmi Ramurthy, Mrs. Ruchika Rani, Dr. A. Balasubramaniam, Dr. C. Shivakumar, Dr. Miriam C.A. Wangaru. Same time, we also like to thank the chairpersons like Dr. Malliga Kannan, Dr. Ashok Kumar, Dr. Lata Venkateshan, Madam Kumari, Dr. Kamala, Dr. Felicia Chitra, Dr. B.V. Kartyayani, Mr. Kumaraswamy, Dr. Muttamil Selvi, Dr. Manju Dandapani, Dr. Asha Shetty, Dr. Vasanta Kalyani, Dr. Jayarekha, and Dr. Padmavati Nagarajan. Also, we like to thank the Selvi for Registration Committee Head, Dr. Lakshmi Ramurthy Technical Committee Head, Dr. Purkudi Ravindran for Scientific Committee Head. We like to thank all the paper presenters, namely Dr. Jaslina Gnanarani, Ms. Komal Preet Kaur, Dr. Sampurnam, Dr. Rajati Shaktivel, Ms. Silpi Kumari Ray, Ms. Sarita Devi, Dr. Selvaraj, Ms. Bhavani, Ms. Satinder Kaur, Ms. Priyadarshini, Mr. Unnikrishnan Puliyakur, Mr. Srinivasan, Miss Jasmeet Kaur Nairam, Mrs. Jagadishwari, Dr. Bhavana Rani, Miss Nitesh, Mrs. Sarika, Mr. Varun Babu, Mrs. Sheila, Sister Sumi, Miss Sharadi Nayak, Mrs. Jacqueline Lily, Miss Suryakala, Miss Mahalakshmi, Miss Usha BS, Miss Tania, and Professor Madam M. Manimegalai. We thank all the faculty without whom the wheels would not have run of College of conducting scientific program, conducting feedback, pre-test, post-test. They have really done a commendable job. We are thankful to each and every faculty of Nursing College for their efforts for the again past 3 months. We thank the staff and College of Nursing support they have provided, namely Mrs. Renuka, Mrs. Geeta, Mrs. Devakodi, and Mrs. Nitya. We thank all the IT wing staff, particularly Mr. Ramachandran and his colleague, for their help in connecting all the speakers through net and correcting the fault lines then and there. Because as webinar, we completely depend on the internet. We thank all our students of College of Nursing for their active. We thank the Tamil Nadu Nursing Council for the support we get in conducting these webinars, workshops, or whatever it is. And we got 4 hours for this webinar. We are really thankful to the registrar. We thank the person who gave us the food, Mr. Ravi, for his nice refreshments we had during lunch and the tea breaks. We thank each and everyone directly or indirectly who has taken part to make this webinar a grand success. Thank you all.
Thank you, sir. Thank you.
Thank you so much. We are to the end of our webinar. Thank you. Thank you. Thanks to all the participants across. And thanks to our ma'am. Thank you, ma'am. Thank you so much. Thank you to all the participants who are now have joined now. Thank you so much. So we have come to the end, ma'am. Anything to add up, ma'am?
I thank all the team members, especially College of Nursing. They are each and everyone, they did their effort. That is 100% they put their effort. Otherwise, it's not feasible. So all the credit I dedicate to our faculty and students for made this function successfully. I thank Punita and Vetri, the office staff. They did their wonderful job. They're going here, making arrangement, all the things. The technical committee, the past 2 days, they are the vital role past 2 days. Before that, registration is started long before itself. Still their work is going on. Till they are distributing their service also, their certificate also, the work is keep on going. I thank all the team members. You are the dedicated faculty. That's why we are completing this conference successfully. Otherwise, it's not feasible. Thank you so much. All the credit I dedicate to you. If anything is wrong, I take responsible. I will not repeat it again, but all the credit I dedicate to you. Thank you so much, all of you. Thank you. Shall we leave?
Yes, ma'am.
Thank you, thank you, thank you, thank you, thank you, Dr. Ramesh and Mugam. Thank you so much. You are the one. Thank you for your maximum support for giving this speaker detail everything. Thank you, thank you.